So, hello everyone. Hello everyone, good evening. Sorry for the delay, there was some technical glitch. So, just let's wait for others also to join. And just let me know in the chat box whether my audio, video, everything is fine. Good evening, Rajat. Asgar, good evening. So Asgar Ali, the name seems familiar. I think you were there in one of the previous sessions also. Yes. All right. So I think audio, video, everything is fine. Okay, everything is fine. Good. Kushbu, Ajay, good evening. We'll just start in 2 minutes. Okay, just waiting for others to join also. Tanya, don't worry, I just started, okay? Just started. All right, so how are everyone doing? How's studies? Okay, so Mahesh, good evening. Dikshita, good evening. Okay, Jahangir, you want to know how long is the session even before the session starts. Well, I might take for 4 to 5 hours. Okay, 4 to 5 hours. This is not MCQ, this is going to be a topic discussion, Jashit. Okay, this is going to be a topic discussion. And we'll be discussing very, very important topics. Okay, so like we'll be discussing COVID-19 management, because that is going to be the hot topic for your exams definitely. So I'm actually going for a full-fledged a discussion of the management of COVID-19, and then stroke localization, because many students had messaged me like they're finding stroke localization a bit tough. In fact, they find it tough to understand it conceptually and to integrate the radiology, anatomy and medicine part of it. So stroke localization would be a sort of an integrated session that I'll be taking, so that after the session you will be very confident with the stroke localization. And let me assure you one thing, after this session you will not have to by heart all these stroke syndromes and the manifestation. So you will understand it very much conceptually. And then myocardial infarction, we'll be going to the management, because there again many students, when asked what is the next step in the management, they are not quite sure with the guidelines and what is the next step, so they get often stuck in that. All right, so that also will be dealt with. And bronchial asthma also, the GINA guidelines of bronchial asthma, again a very, very important topic that also I will be discussing. So some very, very important topic discussions are there. So are you all with me? Tanya, again, I think you were there in the previous sessions also. Tanya, regarding one more session, let's see how the session goes, and in case you want me to discuss certain other topics, I'll definitely think about it. Okay. All right. So let's begin. Okay. So first of all, this is going to be a quick revision program of very, very important topics. And it's good to see that you all are following the other sessions also. I can see that many of you using these sessions very effectively for your final round of revisions. And let me tell you, it's very important to attend all these quick revision sessions, because when a faculty takes a quick revision session, we'll try to incorporate all the essential points in that session, and that will definitely help you for your exams. Okay. All right. So let's begin. So first of all, just to tell you, especially for the students who are going to write the exam, the next exam. So doc tutorials, they are having different packages. Okay, they have a PG Power Pack, a quick revision program if you just want quick revision sessions alone. So this PG Power Pack, the good thing is that this is at a very low cost and a nominal cost. Okay, so if you see this, you can avail this at a very low cost. Okay, very pocket friendly, budget friendly courses of doc tutorials. But again, there is no compromise on the lecture quality or the lecture content. Exhaustive lectures are there. For medicine, I have taken very exhaustively the medicine topics. Okay, and then you have the other plans like Doc C and Doc E, especially for the MBBS students, the first and second year MBBS students, you have the Doc E plan. All right, so are you all with me? Let us start the first topic for the day. Yes, stroke localization and management. Okay, stroke localization and management. All right, stroke localization and management. Okay. So I'll be focusing mainly on the localization aspect, because I'm not going to repeat the very simple things, but with respect to the stroke, but the basics of localization I would be teaching you. Okay, right from the basics. All right. So let's start. First of all, to understand stroke localization, you have got to understand two terminologies. So one terminology is called the anterior circulation. Okay, just write down anterior circulation. And the other terminology is called posterior circulation. Okay, two terminologies that you should understand. Now, when you have got, you see here, you see the image here. Lots of images I will be showing you in this session to make things very simple for you. You can see the aorta, you can see the brachiocephalic trunk. So from the brachiocephalic trunk, you can see that there is further subdivision into the common carotid artery as well as the subclavian artery. And then you have from the left side, you can see the subclavian and the left common carotid artery. And the common carotid artery at the upper border of thyroid cartilage, it will divide into internal carotid and external carotid. And the internal carotid is the one that enters the middle cranial fossa, and it supplies the much part of the cranial cavity. So the internal carotid and its branches, okay, that will actually form a part of, that will form the anterior circulation. Okay, so anterior circulation is your internal carotid and its branches is the anterior circulation. Whereas posterior circulation means, you see the vertebral artery here. Okay, so the vertebral artery entering the cranial cavity, you know that the vertebral artery ascends through the foramen transversarium. So the two vertebral arteries will join together to form the basilar, it will join together to form the basilar artery. The basilar artery runs forwards and then runs upwards, and then it divides into the two posterior cerebral arteries. So the vertebral artery, the vertebrobasilar system is what you call the posterior circulation. Okay, so the vertebrobasilar system is the posterior circulation. Now what is important? Yes, Nikhilesh, this is the first topic. The first point I want you to understand is, when I say anterior circulation stroke, it means the stroke has affected the internal carotid artery or its branches. What are the branches? We'll come to that in a short while, but I hope you understood this term, anterior circulation stroke. Similarly, when I say posterior circulation stroke, it means the vessel that has been involved is the vertebro-basilar system, which can be the vertebral artery, its branches, the basilar artery, its branches, the posterior cerebral artery, its branches, whatever it be. Okay, so that terminology is very clear, anterior and posterior circulation. Yes, all right. Now just again another image just to reinforce. Okay, you see here the brachiocephalic trunk, the subclavian artery, you can see the common carotid artery, and from the subclavian artery you can see the vertebral artery originating, vertebral artery going through the foramen transversarium, and I hope this image again reinforces the two terms, the carotid circulation becoming the anterior circulation and the posterior circulation. All right, going forward. Now regarding the internal carotid artery, see the internal carotid artery, it gains access to the middle cranial fossa. The internal carotid artery has certain parts. Okay, it has a cervical part, it has a petrous part, it has a cavernous part, and also it has a cerebral part. Okay, now if you may ask, sir, why are you teaching this anatomy here? Listen children, if you want to conceptually understand stroke localization, you have got to integrate your anatomy knowledge with that of your medicine knowledge. Okay, similarly your radiology knowledge is also important, which I will be teaching you, don't worry. So you see the cerebral part of the internal carotid artery, you can see the various branches. Okay, we'll just see in the subsequent images also. All right, so these are the subdivisions of the internal carotid artery. All right, okay. Now this one is quite famous. This is the circle of Willis. Now tell me, if there is a stroke that involves this vessel, which is your middle cerebral artery, you tell me what sort of stroke is it, anterior circulation or posterior circulation? If it involves ACA, a stroke involving the anterior cerebral artery, is it an anterior circulation stroke or posterior circulation stroke? Tell me in the comment box. And if you have a vertebral artery involvement, a basilar artery involvement, a posterior cerebral artery involvement, what sort of strokes are they? They are the posterior circulation. So ACA, MCA strokes, even the anterior choroidal artery stroke also, you can see the anterior choroidal artery is also a branch of the internal carotid artery. So ICA, internal carotid artery, in the cranial cavity, it is giving off branches. So when you have an ACA involvement, you have MCA, anterior choroidal artery, all these are actually anterior circulation strokes. Okay, very clear. Now if I may ask you one question, you tell me which is that blood vessel that actually connects your anterior circulation with the posterior circulation. Tell me, which is that blood vessel that connects the anterior circulation and the posterior circulation? This is going to be your posterior communicating artery or your PCOM. So PCOM is acting like a bridge that connects the anterior circulation with the posterior circulation. Very clear. Okay. Now this is again a simple diagrammatic representation, which again you have got to understand. This is the lateral surface of the cerebral hemisphere, and you tell me what is highlighted in yellow, which vessel distribution? Well, the yellow is corresponding to the middle cerebral artery distribution in the lateral part of the cerebral hemisphere, and this one, the blue, is corresponding to the ACA, anterior cerebral artery, and the last one is corresponding to the PCA. Okay, why you have got to understand this? Because if you know this, then when it comes to strokes affecting the individual hemispheres, okay, individual sites, you will understand what are the manifestations. Okay, very clear. Now coming to the medial cerebral hemisphere, Okay, just look at this. You can see that it is the ACA that predominates the blood supply in the medial cerebral hemisphere, and this you can see is the PCA part, okay, and a very small part is supplied by the MCA. So lateral cerebral hemisphere mainly the supply was MCA, medial cerebral hemisphere mainly the supply is the ACA, okay. Alright, now coming to the inferior aspect. The predominant blood supply of the inferior aspect is from the PCA. Yes, you will have supply from the MCA, you will have supply from the MCA, as well as you will have supply from the ACA as well, okay. Alright, so this much portion is clear, no? This much portion like regarding the hemispheres and what is the major vessel supply. Pakka? Alright. Now listen to me, very important, very important. We are going to discuss regarding MCA strokes, okay, MCA strokes. So you are quite clear that middle cerebral artery stroke is an anterior circulation stroke. So I'll tell you the basic, the anatomy of the middle cerebral artery so that you understand when occlusion occurs in a particular aspect of the vessel, manifestation would result accordingly. You see here, you can see the internal carotid artery, okay. Then you can see the middle cerebral artery. Now the middle cerebral artery, you can see once the MCA is actually formed from the ICA, it actually goes laterally, that is in this direction, okay. It goes laterally in this direction, and when it goes laterally in this direction, you see first of all, it actually gives off certain lenticulostriate vessels. Okay, these are actually small vessels which are actually given off, lenticulostriate vessels, and you know that they will be supplying the region of the internal capsule and the basal ganglia. Yes, you can clearly see these lenticulostriate vessels, correct? No, lenticulostriate vessels. Now once these lenticulostriate vessels are given off, it further actually proceeds, and this is the region of the sylvian fissure, where you can see again the MCA is dividing, there are subsequent divisions, and finally when it comes out through the lateral cerebral hemisphere, lateral aspect of the cerebral hemisphere, it gives off a superior division and an inferior division. Okay, now listen to me very carefully. Okay, so till this part is clear. MCA, initially the lenticulostriate vessels, subsequently in the sylvian fissure it divides, and subsequently in the lateral cerebral hemisphere, superior division and inferior division. Okay, all right. Now you see this, the MCA can be divided into certain sub portions. Now this first one, the proximal portion of MCA is the M1 segment. Okay, the proximal portion is the M1 segment, and it's only just distal to the M1 segment that these lenticulostriate vessels are given off. And then what happens is that you have the subsequent divisions. This is the M2 segments. Okay, M2 segment, early part of sylvian fissure, it actually divides. This is M2, and this one is M3 segment, okay, towards the terminal portion of the sylvian fissure, and the final portion is M4 segments. So M1, M2, M3, M4. Now listen to me very carefully. If you read certain other textbooks, you might find that in some textbooks it is written, yes, there is an M1 segment, but this M2, M3 and M4, they have given it as M2 alone. Okay, they have not given us subdivisions into M2, M3, M4. They have just said this is M2. And some textbooks, you might also find that the part inside this M2 and M3, they have given together as M2, and the one which I have marked as M4, they have given as M3. So children, don't worry regarding that. Okay, nobody is going to ask you point to M3, point to M4, because even different standard neurology textbooks will differ, in the identification of these vascular subsegments. Okay, so don't worry regarding that. For the time being, you understand what I am teaching you. Okay, so that subsequently when I say M3 or M4, you understand what I am trying to convey to you. All right. Okay. So any doubt? No doubt. All right. Fine. Next, let's proceed ahead again. All right. So till this part is clear. Okay. So Now you see here, when you say that there is a stroke, okay, this is again a similar view. When you have a stroke that is affecting the lenticulostriate vessels. Now you tell me, are these lenticulostriate vessels small vessels or large vessels? They are small vessels. So since they are small vessels, whenever you have a stroke due to the lenticulostriate affection, you will call it small vessel stroke. Okay, you will call it small vessel stroke. Okay, so this small vessel stroke, or even you can call it lacunar stroke. Okay, lacunar stroke. Now why do I call this lacunar stroke? If you see the green part, you know, this green part here. So whenever there is a penetrator vessel affection, the region of infarct is going to be small, almost in the shape of a small lacune. Okay, so since it is a small lacunar infarct, okay, this is called a lacunar stroke, or you can even call it a small vessel stroke, because very small vessels, no? Okay, this is a small vessel stroke. At the same time, when you have a stroke that is involving your MCA, middle cerebral artery, especially the M1 segment, what name would you want to give to it? You want to give to it the name a small vessel stroke or large vessel stroke. This is called a large vessel stroke. Now children, when I say this term large vessel stroke, okay, when I say this term large vessel stroke, don't think that, okay, large vessel stroke means only it is a stroke involving some large vessels like aorta, subclavian, carotid. No. See, that is with respect to vasculitis. When it comes to stroke, okay, even a vessel like a middle cerebral artery M1 segment, it is a large vessel stroke. Okay, it's a large vessel being affected. At the same time, when it comes to the M4 segment, you remember the M4 segment. So when there is an M4 segment that is affected, you know, if it is one of the smaller branches, that again can produce, you know, a lacunar type of stroke. But if it is a major initial branch of M4, it can produce a large vessel stroke. Even that also you can call it large vessel. Okay, but predominantly it's a small vessel stroke. All right. Okay. So till this portion is actually clear for you. Okay. Now the pathology actually also differ, because when you have a lenticulostriate affection, it is commonly the result of atherothrombosis or lipohyalinosis. Okay, I am sure that you already have learned this. Lipohyalinosis or atherothrombosis. Lipohyalinosis or atherothrombosis, that is the pathology in case of a small vessel stroke. But when it comes to large vessel stroke, the pathology is that of atherosclerosis. So different pathologies affects different caliber vessels. That is what you have got to understand. Okay, so that is also clear. Okay, all right. Now what you see in the picture now is again the lateral part of the cerebral hemisphere. The green one of the which is marked in the figure is again the middle cerebral artery, okay, MCA, and the Sylvian fissure, you know, has been dissected open, and you can see the subdivisions into the superior division of MCA. Yes, the superior MCA, and this one being the inferior MCA. Superior MCA and the inferior MCA. So I hope that part is actually clear. Superior division, inferior division. Okay, don't think that this is going to be an anatomy class. In a short while you will understand why I have spent time for this. Okay, all right. Now again, something that you should definitely know is regarding the blood supply of the internal capsule. Well, the internal capsule has an anterior limb, a genu, and the posterior limb. Now the anterior limb, genu and posterior limb, the upper part is actually supplied by the striate branches of the middle cerebral artery. If you remember the picture that I had shown you here, you see this lenticulostriate vessels. No, I just circled it green. You see there, you know, this is actually going on to supply the region of the internal capsule. So it is having a significant contribution to the blood supply of the internal capsule. Okay, very clear. So the upper part is definitely supplied by the striate branches of MCA. Now the anterior limb, the inferior portion is supplied by the recurrent branch of ACA. The genu, the inferior part, is supplied by the branches from the internal carotid and posterior communicating artery. Now who is going to tell me in the chat box? Posterior communicating artery is a branch of which vessel? Just tell me in the chat box. Okay. So posterior communicating artery, that is also a branch of the internal carotid artery. Okay. So you see the retrolentiform part and the inferior part of the posterior limb, that is being supplied by the anterior choroidal artery. Okay, that is being supplied by anterior choroidal artery. So just let me know if you are clear with the blood supply of the internal capsule. This is very, very important. Okay, this is very, very important. Okay, all right, fine. Now coming to the internal capsule again, what are the fibers going through the internal capsule? See, the corticospinal tract is predominantly involving the genu as well as the anterior two-thirds of the posterior limb of internal capsule. And the face area is located towards the genu part. And when it comes to the posterior limb of internal capsule, you see it is in the order of arms, trunk and leg. Okay, arms, trunk and leg. And you can remember by this mnemonic, fat lady. Okay, you can remember by this mnemonic, fat lady, F-A-T-L. Fat lady, that is the arrangement of fibers in the internal capsule. Okay, very clear. Now this is important, and also just note that very adjacent to the internal capsule you have your thalamus, and also you are having the head of the caudate nucleus, and laterally you are having the lentiform nucleus, which consists of the putamen as well as the globus pallidus. So whenever you are having a stroke involving the internal capsule, it is a good chance that even the surrounding areas may also be involved in certain scenarios. Okay, and you can see the auditory radiations as well as optic radiations. So again, when you have a stroke that is involving the internal capsule, the optic radiation also may be affected, which is why in certain cases you can have visual manifestations also in case of a stroke. Okay, all right. Now this is a very, very important figure. This figure is going to help you answer many questions of your anatomy, radiology integrated questions. Now look very carefully. First of all, remember children, we are dealing with MCA strokes now, which means I want you to now focus on the MCA branches only. I will come back to this same figure again when we deal with ACA strokes, but this is the axial section. Okay children, as understand, this is the axial section, and in the axial section you first look the MCA. Okay, you see this is the MCA D branches. Now who is going to tell me in the chat box, what do I mean by this D branches of the MCA? Will you agree with me that D branches of MCA means the lenticulostriate mainly? Correct, no? So you can see the area that is supplied by the D branches of the MCA. And once the MCA gives off the lenticulostriate, as we saw, it goes laterally and then in the Sylvian fissure, correct? And then it divides into superior and inferior division. Now you look at this. This is the supply of the superior division of MCA. You see the blood supply of the superior division, and this is the inferior division of MCA. Okay. So if you are asked what is the total supply, it includes the MCA, superior division, inferior division as well as the D branches. But you have got to understand what are the individual subset vessels which are, of the MCA. That is the D branches, the superior division, the inferior division. I hope that is also clear. Okay. So I am not saying anything about ACA now. I am not saying anything about PCA. I will come back to that. For the time being, I want you to understand MCA only. All right. Okay. Now look at the coronal section. Now look at the coronal section. Now when it comes to the coronal section, you see here, this is the anterior cerebral artery. Okay. And this is the MCA. Now MCA also look, the region supplied by the superior division, region supplied by the inferior division, and the region supplied by the D branches of MCA. Now children, these two figures which I showed you just now, you should have a visualization of this. Because when it comes to questions that will integrate anatomy and radiology and maybe medicine also, this visualization should be there in your mind. Okay, which region is supplied by which vessel? Very, very important. Okay, I'll come to PCA later. Okay, you see the PCA deep branches, posterior cerebral, we'll come to that later. And also you can have certain watershed regions also. That is, you can see this is the ACA, MCA watershed, and this is the MCA, PCA watershed in the coronal section. And in the axial section, this is the ACA, MCA watershed, and this is the MCA, PCA watershed. Okay, all right. So Karthik, very good. You are answering correctly. You know, we'll come to that particular question in a short while once we are going to discuss the individual manifestations. All right. Now, remember, we have seen in detail regarding the course of MCA and the regions of the brain supplied by MCA. Now, before we come to the individual manifestations, this is actually the path of the corticospinal tract. So, from the cortex here, you can see the fibers are descending down through the region of corona radiata, through the region of internal capsule, then it comes down to the region of brainstem, and it actually crosses in the lower medulla. It actually crosses to the opposite side, okay, the lateral corticospinal tract. So the lateral corticospinal tract descends, subsequently it synapses with the anterior horn cells of the spinal cord. So till this much portion, till the anterior horn cell, just above the anterior horn cell is the upper motor neuron, and from anterior horn cell it is the lower motor neuron. Upper motor neuron, lower motor neuron. Okay, this is the path of the corticospinal tract. Okay, this is also very, very important. Now, when this corticospinal tract descends, I already told you, if you look at this is the axial section. Okay, this is the axial section. I told you in the region of internal capsule, the corticospinal tract is mainly occupying the genu and anterior 2/3 of the posterior limb. And in the internal capsule, the arrangement is in the fat lady, face, arm, trunk and leg. That also you have got to remember. Very, very important. All right. So this is again very, very important. And then when it comes to the brainstem, now this is also very important. A very, very important conceptual point. In the brainstem, you see this is the section, axial section of midbrain. You see there again you have the fat lady, but that is from medial to lateral. So medially face, then arm, then trunk, then leg. That is how the fibers are arranged. Okay. Now you see in the spinal cord here, in the spinal cord that the corticospinal tract in the medulla, 80% will cross to the other side as the lateral corticospinal tract, and 20% will continue as the anterior corticospinal tract. And the fibers that actually cross the lateral corticospinal tract, you can see medial to lateral is arm, trunk and leg. And you can see the trunk region is also there in the anterior corticospinal region, because the anterior corticospinal tract is involved in the supply to the truncal muscles, which will help to maintain the posture also, the erect posture of the individual. That also is important. So that is regarding the motor pathway. Now regarding the sensory pathway, just one point you have got to know, you have got a posterior column that ascends, okay, as well as a spinothalamic tract that ascends, because sensory pathways will ascend whereas the motor pathways will descend. So the posterior column, you tell me, where does it actually cross? Does it cross in the region of spinal cord? Answer is no. It will go up, and you can see that it will cross at the level of medulla, where it subsequently continues upward as the medial lemniscus, and then it goes up. Similarly, you have the spinothalamic tract also, but the spinothalamic tract will actually cross at the level of spinal cord itself, and then it will actually ascend. So you can see that both the medial lemniscus as well as your spinothalamic tract, they will go and synapse with the ventral posterolateral VPL nucleus of thalamus. VPL nucleus of thalamus. So sensations of one half of the body, it actually goes to the contralateral VPL nucleus of thalamus. But what about the face region? Tell me, What about the face region? Which nucleus of thalamus is concerned with the sensory innervation of the face? It is the VPM nucleus. That is the ventral posteromedial nucleus. Okay, very important. VPM nucleus. All right, so that is also clear. Okay, good. So this is about the sensory pathway. Now, see, I am just briefing regarding each of this. After that, I'll tell you the individual clinical features of stroke. But if you know this basic concepts, it is very easy. Now, next concept I want to tell you is that you also have the optic radiations. That is, from the lateral geniculate body, you have the optic radiation to the occipital cortex. And the optic radiation is also going, so when the optic radiation actually goes, because it is also forming a part of the internal capsule, which we have seen earlier. So there also, when a stroke is affecting internal capsule, it can affect the optic radiation and there may be visual manifestations. Okay, very clear. So this is the optic radiation. So once again, you see this is the thalamus, and just adjacent you have the lateral geniculate body, and this is the optic radiations going to the occipital cortex. So when you have an optic radiation affection, you can have visual symptoms. Okay, all right. Now, another important concept that you have got to know is regarding the lateral cerebral hemisphere, having two very important areas. One is Broca's area and other is Wernicke's area. Okay, so Broca's area is located in the posterior part of the superior frontal gyrus. So Broca's area is area 44. Okay, and your Wernicke's area is located in the posterior part of the superior temporal gyrus. So that area is area number 22. Now children, very, very important. The Broca's area is supplied by, you tell me, is this going to be supplied by the superior division of MCA or the inferior division? Because we have already seen, it comes through the Sylvian fissure and will divide into a superior division and inferior division, MCA. So the MCA superior division is going to supply the superior division of MCA is going to supply the Broca's area, and when you have inferior division affection of the MCA, but remember, not in the non-dominant, it has to be a dominant hemisphere lesion. So majority of individuals, it is the left hemisphere that is the dominant one. So when you have a superior division of MCA stroke, it can have a Broca's aphasia as a manifestation. Now this is the first clinical point that we are learning today. Superior MCA division, Broca's aphasia. Inferior MCA division, it is going to be Wernicke's aphasia. Okay, very important. Okay, all right. Now suppose, okay, now starts the clinical features of MCA strokes. Okay, now you have got to answer with me. Now suppose, okay, you have got a MCA proximal occlusion. Okay, MCA proximal occlusion. So what I am showing to you is you can see is the coronal section. So when the MCA is occluded proximally, the regions of the MCA territory which are supplied by the deep branches of MCA, superior division of MCA, inferior division of MCA, everything is gone. So what you are seeing in the figure, this area that is being highlighted, so this entire area will be infarcted. Okay, so when you are having a stroke, in the proximal part of the MCA, you are having a big stroke. Okay, it is going to be a massive stroke which affects both the deep branches and the area supplied by the superior division and inferior division. So in such a case, what are the likely clinical manifestations? So one thing is the patient is going to have motor symptoms. You tell me what is the motor symptom? It is going to be hemiplegia. Now you tell me, is this going to be a hemiparesis or a hemiplegia? Most likely. Now this is going to be a hemiplegia. Why is this going to be a hemiplegia? Is because you see the region of internal capsule especially which are being supplied by the deep branches. So the issue about internal capsule is all the fibers are densely packed in the internal capsule. So even a small stroke there can cause a dense hemiplegia and also a severe weakness. So one of the manifestation of MCA proximal occlusion is contralateral hemiplegia. Okay, contralateral hemiplegia. Correct? Now second is, what about sensory manifestations? Yes, you will have sensory manifestations. So sensory manifestation, it will be a contralateral hemianesthesia. Contralateral hemianesthesia. Okay. So you know there is a contralateral hemianesthesia because you have already seen, because from the region of thalamus you have the thalamic radiations projecting to the cortex. So both the spinothalamic tract and medial lemniscus are having their relay in the thalamus, and then you will have the sensory pathways ascending to the sensory areas 3, 1 and 2. So that is a sensory radiation. You will have contralateral hemianesthesia. Now just somebody tell me, I am going to write one more clinical feature, contralateral hemianopia. So you tell me why there is a contralateral hemianopia here. I want you to tell me why there is contralateral hemianopia. I will be waiting for your answer. I just want to know why there is a contralateral hemianopia. Yes. Oh, great, 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 excellent. So it's basically because the optic radiations are involved. The optic radiations are involved, and that is the reason why you will have hemianopia. Now this contralateral hemiplegia, contralateral hemianesthesia and contralateral hemianopia, this is the classical triad of a MCS stroke, a proximal MCS stroke, or even lenticulostriate also can produce. Okay, I'll come to that, but here definitely this is going to be a triad of manifestation. Now at least some of you might ask me, sir, I have seen some MCS strokes in my ward. I have seen MCS strokes, but I have not seen hemianopia in all patients. Some patients, yes, I have seen hemianopia, but many patients are there who have only weakness and sensory symptoms but no hemianopia, or only motor and I am not able to get much sensory involvement. So why is such a disparity? Please understand that. See, when you have the blood supply to the brain, God has given us collaterals. So whenever there is an occlusion in the cerebral circulation, just like your coronary circulation, even here also you will have collaterals, which is why every patient with MCS stroke, we are talking of a proximal MC occlusion, is not the same. Okay, there can be variations depending upon the extent of collaterals. See, my collateral network may not be that great, but your collateral network might be great, which means I might suffer from a very severe stroke while you might suffer from a minor stroke. Okay, so please understand, this is the classical triad. Okay, now in addition to this, can we have language abnormalities? That is the next point, language abnormalities. Now language abnormalities may be there when you have a dominant hemisphere involvement. Now if there is a, remember we are talking of a proximal MC occlusion. Now if it is a proximal MC occlusion, you tell me which is the vessel that is going to be affected, or which territory is going to be affected, Broca, Wernicke or both, you tell me. Okay, Broca, Wernicke or both. So it's very clear that when you have a proximal MC occlusion, you are going to have affection of Broca and Wernicke, because why? Indirectly both the superior as well as inferior division is going to be affected, because it is basically a continuation of MCA. So what aphasia are you going to get here? You are going to get a global aphasia. You are going to get a global aphasia. Okay, global aphasia. Now I'll answer one question. Somebody asked, can we have basal ganglia involvement? Good question. So as you rightly said, basal ganglia is very adjacent to the internal capsule. See, but one very interesting fact is, maybe some God-driven mechanism, we are not exactly sure on the exact mechanism. When it comes with stroke, it is very less likely that a stroke can produce a Parkinsonism. Well, you can have a vascular Parkinsonism, which is a different entity, long-standing small vessel ischemic disease resulting in Parkinsonism, that is different. Even in the doctutorials app, in the Parkinson's chapter, I have explained that. But this one is not like that. Have you seen anybody developing an acute stroke and presenting with Parkinsonism? No. So why that happens is always a mystery, because basal ganglia somehow is not much affected. I am not saying it is not, because you can have acute vascular event producing chorea, because it is a vascular event that can affect the basal ganglia. But many other times, especially strokes, you see that you won't have acute extrapyramidal manifestations in stroke. Okay, so that is also clear. Okay, all right. So global aphasia. So you have understood conceptually why it is a global aphasia. All right. Okay, so that part is also clear. Now I'll tell you another point. Okay, I'll tell you another point. Now when you have a MCA stroke, okay, I'll just show you. This is going to be a CT image. Okay, listen everyone. Now we are entering the crux. We are entering the main area. Now see, if this is a particular patient who has presented with right hemiplegia, you tell me which vessel is involved here. I'm not giving you much clues. This patient presented with acute stroke, and you tell me which is the vessel that is involved here. You might get this as a clinical question. Which is the vessel that is involved? So this is a plain CT, axial section. You just tell me which is the vessel that is involved. You remember the figure that I told you of the MC? You remember that figure that I showed you? Remember I told you this figure will come in handy. Let me just show you that figure once again. Yeah, this is the same figure. I'm trying to correlate anatomy, radiology and medicine. Okay, just look at this. So you see here, it is a big infarct. And when it is infarcted, you agree with me, this is involving, the CT that I showed you is involving the MCA deep branches, superior division and inferior division, which means the CT is actually showing a hypodensity which is almost like this shape. Okay, almost this shape, correct? Almost this shape. So this is almost corresponding to the MCA territory. Now if you are asked, is this the deep branch that is involved? Yes, deep is also involved, superior is also involved and inferior is also involved. So what sort of stroke is this? This is a proximal MC occlusion. This is a proximal middle cerebral artery occlusion that has produced stroke. Did you understand or not? And yes, this is a left MC occlusion. But again, I want like Shubham, Gaurav, I want you to say left MCA proximal occlusion. Okay, because from the next time you see the same CT, you should tell me not just MCA, where in the MCA? Sir, it's a proximal occlusion. It's a proximal occlusion. Examiner might ask you which vessel, but you be very thorough. It's a proximal MCA occlusion. Okay, proximal MCA. Now sometimes in the exam, they might not give you CT, they might go for an MRI, because you know that the most sensitive investigation for an acute ischemic stroke is a diffusion weighted MRI. So when it comes to a diffusion weighted MRI, you see this is the diffusion sequence. This is the diffusion sequence and this is the ADC. Diffusion sequence and this is the ADC. Now you tell me, just looking at these two images, what is the problem here? You just look at these images and radiologically you tell me what is the problem. You can see that in the diffusion sequence it is hyper intense. It is appearing bright. Whereas in the ADC, which stands for apparent diffusion coefficient, ADC it is appearing hypo intense. Because in MRI you use the term hyper intense and hypo intense. So you can see the hyper intensity, you can see the hypo intensity. Correct? Now the impression from this is that the patient is actually having diffusion restriction. Diffusion restriction. Now what do I mean by diffusion restriction? See, in case of stroke, what happens is, suppose I am standing here. Suppose I have a friend of mine who is standing slightly beside me, another friend standing here, but there is this gap between the three of us. But when it comes to stroke, you tell me what sort of edema occurs in stroke. Is it cytotoxic, vasogenic or interstitial? It is cytotoxic edema that occurs in stroke. Cytotoxic means cell edema. Cell becomes edematous, swells up. So I become big, my friend becomes big This friend also becomes big. So you see, we are all very close to each other now. So the diffusion of the protons, okay, the diffusion of the water molecules, that will be affected. Okay, and because of that, you can say that there is a diffusion restriction. So when it comes to acute stroke, the imaging finding of acute stroke is diffusion restriction. But understand why there is diffusion restriction is because of cytotoxic edema. So this one that you are seeing on the screen is a manifestation of cytotoxic edema. Now you tell me, what is the blood vessel that is affected in this clinical condition? Do you want to just comment as MCA or you want to change your answer? This is a proximal MCA occlusion. Let's be more clear on that. This is a proximal MCA occlusion. Okay, this is a proximal MCA occlusion. Remember, any acute infarct will be bright on the diffusion sequence. It's almost like a tube light, okay, as bright as that, and dark on the ADC. Okay, so I hope that is clear. Yes, yes, children, just tell me, Tanya, Sonali, are you understanding? This is an MCA stroke, left proximal MCA. Yes? All right, all right. Now, this is again another patient, you know, where in addition to the infarct, sometimes you can have a hemorrhagic transformation. So sometimes in the exam, they may ask you a bleed. So a bleed that is involving the middle cerebral artery, again, this is a bleed that is involved in the MCA, because they might give you some image for the exam and they might ask you which is a blood vessel that is involved. They might tell you a patient presented with acute onset headache, weakness of right upper limb and lower limb. So this basically, you know, is a condition where there is some sort of a hypodensity also here, and plus that you will have hyperdensity. So this is an infarct that has undergone hemorrhagic transformation, but not only that, this is having is a big bleed, so that there is a mass effect and midline shift also. So this patient will have a poor prognosis. So understand that this is again the MCA that is being involved. Okay. Now, I'll just tell you another clinical scenario. Okay. This is again a scenario where you have in the exam, this question is being asked. This is a patient who presents with an acute stroke. Okay. He is having hemiplegia and hemianesthesia and hemianopia, contralateral. You just tell me, okay, hemiplegia, hemianesthesia, hemianopia. So it's a classical triad of a MCA stroke. But you tell me, is this vessel that is involved the right MCA or the left MCA? Just tell me which vessel is involved. Lokesh, you are having a doubt. Can it be a venous stroke? Okay, see, one important point about venous stroke, just to clarify your doubt. In a CT, if it is a venous infarct and a bleed, there will be a disproportionate edema. That is, hypodensity will be disproportionate. So here the mass effect is more because of the bleed than because of the hypodensity. I cannot say with 100% confidence that this is never going to be a venous bleed. It is possible, but most likely this is not. Why do I say that? Because one of the important features of a venous infarct and a hemorrhagic transformation is disproportionate edema. You will see lot of hypodensities also. Okay, all right. Now you tell me which is the vessel that is involved here. I mean the right MCA, left MCA. So as I can see, many of you are correctly answering. So this is actually a right MCA infarct. Okay, I'll tell you why. Okay, I'll tell you why. Now you must be very attentive here. Very attentive. See, this is the frontal eye field. Okay, this frontal eye field is very important for horizontal gaze, horizontal conjugate gaze. What do we mean by conjugate gaze? Means, you know, both the eyes moving together. So for maintaining a conjugate gaze, the right frontal eye field is important, and subsequently it comes down as the frontoreticular pathway. Frontoreticular pathway. Then it comes down and it goes to the contralateral PPRF, contralateral parapontine reticular formation. Subsequently, it goes to the yellow one, which is the abducens nucleus. Abducens nucleus. And further supply is occurring from the abducens nucleus. Now, you have got to understand one thing. This abducens nucleus and abducens nerve, you have got to understand the difference. Abducent nerve means it is supplying only the lateral rectus. But when it comes to abducent nucleus, it is having two types of neurons. So the abducent nucleus will contain two types of neurons. One is going to be the neurons which are going to supply the lateral rectus. Okay, but in addition to that, it will have certain interneurons, and this interneurons will actually connect it to the medial longitudinal fasciculus, MLF. And via the MLF, okay, via the interneurons, it is connecting to the MLF. And please understand that this via the MLF, it will innervate the contralateral medial rectus also. Okay, because you see here, this is the PPRF in blue, the yellow abducent nucleus. You see the MLF, right MLF. So the left abducent nucleus by means of the right MLF goes to the oculomotor, third nerve nucleus, thereby it supplies the medial rectus. Okay. Now this right frontal eye field, okay, right frontal eye field is very important for your conjugate gaze to the left. Okay, your conjugate gaze to the left. Why is that? Because right frontal eye field will go to the left abducent nucleus, which will supply the left lateral rectus and the right medial rectus, which will cause a leftward gaze. Right frontal eye field will help in the left gaze. So when you have a left frontal eye field, left frontal eye field is important for rightward gaze. I hope it is very clear that about how the right frontal eye field causes a leftward gaze is because you have the supply to the left lateral rectus and right medial rectus. In the other way, if it is the left frontal eye field, you will have a right lateral rectus activation and a left medial rectus activation, causing a conjugate gaze to the right side. Okay. Now, suppose if the right frontal eye field is involved, okay, or the right frontoreticular pathway is involved, okay, right frontal eye field or right frontoreticular pathway is involved, what will happen? So what will happen is that the left frontal eye field is pretty much normal. So the conjugate gaze to the right is okay, but what about the conjugate gaze to the left? It will not happen. So when you have a destructive lesion, what do I mean by destructive lesion? An infarct involving the right frontal eye field, you tell me the conjugate gaze will be towards which side? Towards the right. That is, the patient will actually look to the right. Correct, no? So that is what is happening here. This patient has got an MCA stroke, possibly a proximal MCA stroke, because I already told you it is hemiplegia, dense hemiplegia, hemianesthesia, and also is having some sort of a raised intracranial tension also. Why raised ICT? Because proximal MCA will produce a large stroke, and large stroke can cause increase in the intracranial tension. So will you agree with me that this can very well be a right proximal MCA occlusion? Right proximal MCA occlusion, yes. Right frontal eye field is affected, conjugate gaze to right, gaze preference, and as Lokesh is rightly saying, the patient is looking to the infarct, or it's like patient will show you where is the infarct. Okay, so that is what happens in case of a frontal eye field lesion. But the reverse actually happens in case of a lesion in the PPRF, because PPRF, you see here, this is the left PPRF. Left PPRF, from that fibers go to the left abducent nucleus. So left PPRF is involved in conjugate gaze to left. Right PPRF is involved in conjugate gaze to right. So when you have a stroke in the brainstem where the PPRF is affected, if it is a left PPRF affection, it's not the same as the case of a right frontal eye field affection. Left PPRF affection means patient will have gaze palsy to that side or gaze preference to the other side. Remember, we use two terms which mean the same. In this patient, either you can say he is having gaze preference to right, or you can say there is a gaze palsy on the left side. Gaze preference to right or gaze palsy on the left side. Okay. Now, I hope you understood the difference. So when we come back to what we were discussing regarding MCA strokes, so you see you will agree with me that you will have a gaze palsy here, gaze palsy, or you can even use the term gaze preference depending on how you use the term. Okay, so in this particular stroke, you can have a gaze palsy because it is a large stroke and the frontal eye field as well as the frontoreticular pathway is involved, because we have beautifully seen the frontoreticular pathway also coming down, correct? No? Because you see in that particular picture, the frontoreticular pathway, the same pathway also will be affected, no? Frontal eye field and frontoreticular pathway will be affected. So there will be a gaze palsy also. Okay, so this is what happens in case of proximal MC occlusion. Now when it comes to a distal MC occlusion, okay, now I am talking of distal MC occlusion. Now what do I mean by distal MCA? So proximal occlusion, we have just seen that, okay. Now there are a couple of other important points which we will come to later. So distal MC occlusion, you see what is the major difference? Already the lenticulostriate vessels have been given off. Okay, if you remember this particular picture that I showed you initially here, so distal MCA means you see this region of the penetrator vessels which are supplying the internal capsule, that supply is normal. So distal MCA means distal to the lenticulostriate. So lenticulostriate is involved in supply to the internal capsule. So internal capsule is where you have the fibers very much densely packed. So there is significant weakness. So if you have a cortical affection of the MCA branches, you tell me what is going to happen. You tell me what is going to happen. Is it going to be a hemiplegia or a hemiparesis? Tell me that first. Is it going to be a hemiplegia or a hemiparesis? This is going to be a contralateral hemiparesis. Okay. All right, and if it is a hemiparesis, you tell me what is going to be more affected. Will it be the region of the arm, or is it going to be the region of the leg that is going to be affected? If you remember the diagram that I had shown you again initially, the lateral surface of the cerebral hemisphere. Now imagine that you have your motor strip here. Okay, you are having your motor area here. So the motor homunculus is having an inverse representation. So your leg area will be actually towards the medial aspect, and the arm area, the face area will be more towards the lateral aspect. So when you have an MCS stroke, you tell me this is more likely to involve your upper limbs or lower limbs. So a distal MC occlusion will produce a contralateral hemiparesis, but more involvement of your upper limbs more than lower limbs. Then you might ask me, sir, you only showed us that motor homunculus picture where you showed us that ACA is supplying the leg. So you did not show us in that particular picture that MCA was supplying the leg. So what if you just tell us why there is a leg weakness? I am expecting only arm weakness. Please understand that. Though in all the anatomy textbook everything is drawn like there is a watertight compartment between MCA ACA, in real life it's not like that. You can have some overlaps, your MCA going into supply some part of the leg area also. So you can have some sort of leg involvement, but upper limb involvement will be more compared to the lower limb. Okay, and yes, you can have involvement of your face also. Okay, but please understand that what about the type, when you have a facial involvement, you must always understand that the facial nerve, okay, the upper part, what is the peculiarity of the facial nucleus? The upper part is actually having what? It is having bilateral innervation. The lower part of the facial nucleus is not having a bilateral innervation, which is why, okay, suppose you have a lesion here, it is involving the face area as well. Remember, when it comes to the fibers to the facial nerve nucleus, upper part is having bilateral supply. Okay, so the upper part will actually be spared. Even if one part is gone, it's okay. But the lower part of the face is only having the contralateral supply, which means you will have a facial deviation. So when there is a MCA involvement this side, okay, or the left side, you will have a facial involvement, the right element. So if there is a right hemiplegia or a hemiparesis, you will have a right element facial palsy also. Okay, there will be a element facial palsy. Now if you ask me, sir, is it just in a distal MCA or even in a proximal MCA also? Even in a proximal MCA also, you can have a contralateral UMN facial palsy. Okay, contralateral UMN facial palsy, upper motor neuron type of facial palsy. Here also it's not LMN facial palsy, it is a contralateral UMN facial palsy. Only thing is that lower part of the face is affected. Okay, contralateral UMN facial palsy. Okay, all right, so that is also clear. Okay, so there will be a hemiparesis, and just tell me, if distal MC occlusion, are you going to have sensory affection? If you are having a first of all, you tell me, will you have sensory affection? Second point you have got to tell me is, if there is a sensory affection, is it going to be the superficial sensations that is going to be affected, or the deep sensations that are going to be affected? Tell me, is it the superficial sensation or the deep sensation? Just tell me. Well, the problem here is, see, the lenticulostriate has already supplied the region of the internal capsule, you have adjacent thalamus region. So that supply is done. Now it is coming to the cortical type, no? So there you will have predominantly a cortical type of sensory loss. Okay, there will be a cortical sensory loss. Okay, so I am sure that you would have learned in your physiology what are the deep sensations and what are the cortical sensations. So you will have a cortical type of sensory loss here, which means I'll tell you. Suppose, I had a patient, I was discussing a case with one of a medicine resident. So he told me, like, this patient is having a stroke. So it was actually a stroke in the parietal region. Okay, it is having a stroke in the parietal region. So he was because it is a MCA, a distal MCA stroke. So he was looking for pain, temperature. So he's asking me, sir, in spite of the parietal area being affected, why there is no affection of pain and temperature? Can you tell me why? It's because this pain, temperature are actually deep sensations. Deep sensations only require the thalamus for its appreciation. Sir, but you told me that from thalamus there is a thalamic radiation. Yes, thalamic radiation is there, but deep sensations for its appreciation actually requires an intact thalamus only. When you have affection of your cortical areas like your parietal area, the medicine resident should have ideally looked for the cortical sensations. Okay, and you tell me what are the cortical sensations. Just let me check, if you are answering it correctly. Just answer, what are the cortical sensations? Let me just check your knowledge of cortical sensations. Yeah, stereognosis. Okay, 2-point discrimination. Okay, so these are the ones, the cortical sensations are the ones that you have got to check in a cortical type of stroke. Okay, that is also clear. Okay, all right. So distal MCA will have motor weakness, but it will be hemiparesis, upper limb more than lower limb. You will have sensory problems, but it is again cortical type of sensory loss. And will you have visual symptoms? See, visual symptoms you may have depending upon what part of the optic radiation is affected. Because I am sure that you would have learned in your ophthalmology also regarding the optic radiations. You have the one passing through the region of the temporal lobe, the region of the parietal lobe. You would have learned regarding the Mayer's loop. So you might get visual problems, but this might not be a hemianopia. This is likely to be a quadrantinopia. Okay, quadrantinopia. Because see, it is not a proximal MCA and it's not affecting the entire optic radiation. So when it comes to mostly a cortical one, it is likely that some of the fibers may be affected and there may be a quadrantinopia. So obviously it might not be, very much visible. Okay, all right. So that is also clear. So motor symptoms, sensory symptoms, visual symptoms I have explained to you, and also the facial also is there. Now let me ask you another point. So I told you that if the dominant hemisphere is being involved, you are going to have language. Now in case of a cortical stroke, if a superior division of MCA, assume that a superior division, because when I say the middle cerebral artery cortical affection, it can mean the superior division or inferior division or just before the division into superior and inferior. When you have a superior division affection, what type of aphasia can result? Broca's aphasia. When you have an inferior division MCA, what can happen? There can be a Wernicke's aphasia. Now this is why sometimes you can have patients with Wernicke's aphasia. Okay, now I am going to ask you a question. This particular patient presented with acute onset irrelevant talk. Okay, this particular patient, elderly, smoker, hypertensive, acute onset irrelevant talk. So he was perfectly fine since morning 6 a.m. Then he is suddenly developing this irrelevant talk. So when he is developing this irrelevant talk, whatever is being asked to him, he is answering something else. When he is being asked, do you want food? He is actually talking about, going to the washroom or something else. So he's talking all absurd things. So he's having a Wernicke's aphasia. Now you tell me, what is the likely vessel territory involved? Inferior division of MCA. But my question to you is, see, stroke just as Wernicke's aphasia, why this patient is not having weakness? You tell me, why this patient is not having weakness? Inferior division Wernicke aphasia. It would have been easier if the patient had some weakness. But really, can you have strokes where a patient only has Wernicke's aphasia? Can you tell me why? Yeah, Shubhanshu Dev, can you explain? You are saying inferior division, correct? But tell me why there is no weakness in this patient? Why there is no weakness in this patient? See, when the MCA is actually dividing into the superior division as well as inferior division, okay, you see here, tell me which division of MCA is going in the direction of the motor strip, and look at the direction of the inferior division. Is this inferior division of MCA supplying any motor aspect? Because motor strip is actually located here, okay, it is located here. So you can have affection only if the superior division is getting involved. Inferior division is not supplying motor, it is actually supplying the region of Wernicke. How can you have weakness? Yes? So that is the problem. Okay, that is why many a times patients with Wernicke's aphasia go to psychiatry ward. Because patient might think, he is having some psychiatric problem, the relatives might think. But the actual issue is it is a stroke. Why it was not recognized to be a stroke? There was no weakness. If there was some weakness, facial deviation, anybody would identify this as a stroke. Which is why any acute onset irrelevant talk, always think of a possibility of Wernicke's aphasia. You might not have any weakness. Now, did you understand the importance of understanding anatomy also? Because otherwise you will simply by heart. Only if you know where the inferior division of MCA goes, you will understand why the Wernicke's aphasia due to a stroke is not having weakness. Okay? Which is why I spent some time for anatomy. Alright. Is it very, very clear? Okay? I hope it is pakka clear to you now. Okay? I am sure that you will never ever forget this in your life from now. Okay? Alright. Now, that also is quite clear. Now, the next question is about the speech problems. See, if the dominant hemisphere is involved, you can have language problems. So I just will come back to one point here in this previous MCA proximal occlusion. So in MCA proximal occlusion, if the right MCA is involved, my question to you is, can there be speech affection? Yes or no? Can there be speech affection? Yes or no? Can there be speech affection? Why? If yes, why? Please understand that the answer is yes. But remember, the speech affection is not going to be aphasia. See, aphasia means, it is your central speech apparatus being affected. Whereas here what can happen is, there is a peripheral speech apparatus, because from the corticospinal tract, you will have the fibers actually coming down and actually crossing to the opposite side. So what will happen is that when you have a corticospinal tract involvement, The corticospinal tract will also go and supply the region supplying your tongue muscles, the pharyngeal muscles, laryngeal muscles, everything, no? So which means there can be a dysarthria. So when you have a MCA affection and when you have a corticospinal tract affection, you can have a dysarthria when the non-dominant hemisphere is involved. Okay, non-dominant is involved. You can have still a speech problem, but that is going to be a dysarthria. So what is the difference between a dysarthria and aphasia? Dysarthria is a problem with the peripheral speech apparatus. The corticospinal tract, the subsequent muscles, that is its peripheral speech apparatus. Whereas if you have the language areas being involved like Broca's, Wernicke's, that is when you call a central speech apparatus defect. So there can be dysarthria. Okay, all right. Now assume another scenario. Now before I say anything, I'll just show you this picture. You just have to tell me which division. Okay, this is the particular part that is going to be affected. You tell me what is the vessel affection that I am talking of. Just tell that. What is the vessel affection that I am talking of? Come on, come on. What is the vessel that is affected? See, the region that is being affected is the region around the internal capsule. I can see, all of you are answering. See, now you have all become experts. Tanya, Karthik, Abhijit. See, you have got to have a solid understanding of your anatomy to understand that it is the deep branches of MCA that is involved, the lenticulostriate. So when this is being involved, now you tell me what are going to be the features. Number one, always go systematically. Okay, what is the motor deficit? You are going to have a contralateral hemiplegia. Now you tell me, is this going to be a hemiplegia or a hemiparesis? What do you think? Severe weakness or a mild weakness? Answer is severe weakness. Why is this a severe weakness? Because the lenticulostriate is supplying the internal capsule where the fibers are closely packed. So there is a hemiplegia. And can there be hemianesthesia? Yes, contralateral hemianesthesia. Contralateral hemianesthesia, and you can also have contralateral hemianopia. Now you might ask me, then, and also you can, will you have a speech problem, the language problem? Any speech affection? Which means, any speech affection? Yeah, Prasanna, everybody is saying it is dense weakness. Absolutely right. Absolutely right. Good. Will there be speech affection? That means will there be aphasia? That is what I am asking. Okay, so Karthik is actually saying global aphasia. Karthik says global. Wernicke's global. Okay, I'll just come back to that. Which is why I need all these anatomy figures, because after this session is over, I'll tell you, you will be very confident, okay? Because you will not need any by-hearting. Now you listen to me. If there is a stroke that is involving the lenticulostriate vessels here, by any means, the superior division or the inferior division of MCA is going to be affected, yes or no? Will it be affected? The lesion is entirely in the deep branches. Will the superior division and the inferior division be affected? Already I told you, the vessel pathology is causing a lenticulostriate affection is quite different from a M1 affection. Because lenticulostriate is lipohyalinosis and atherothrombosis. The other one is atherosclerosis. So when you have a lesion in the lenticulostriate vessels, there is no problem with the superior division and inferior division. Why there should be aphasia? There will not be aphasia. If it is a pure internal capsule lesion, there is going to be no aphasia. Okay, there is going to be no aphasia. But there is going to be, are you clear on that? Are you clear on that? And as Lokesh is absolutely saying right, very good Lokesh, there is going to be dysarthria. Why does Lokesh say there is a dysarthria? because this is going and supplying the internal capsule, and in the internal capsule you have the corticospinal fibers. So there will be an articulation defect. There will be a peripheral speech apparatus problem. Okay, so there will be a dysarthria. So just tell me, children, are you very clear conceptually why there is no aphasia in an internal capsule lesion? Okay, whether it be dominant hemisphere or a non-dominant hemisphere, remember, if you have got to have a aphasia, it has got to affect the main branches of the MCA. It's not the lenticulostriate. Okay, all right, all right. So I think I've explained to you well there. Okay. Okay. So speech, you are going to have a dysarthria. Speech, you are going to have a dysarthria. And are you going to have a facial palsy? Yes, you are going to have a contralateral UMN facial palsy. Okay, which means if it is a right hemiplegia, you are going to have a right UMN facial palsy, and on attempted smiling, it is going to be deviated to the left. Okay, all right. So a left MCA stroke in the deep branches. I hope it is clear. Okay, very good. So motor, sensory, visual, speech, facial, everything is clear. Okay, all right. Now I am giving you some scenarios. Okay, we have now become experts in anatomy. Now, let's become experts in radiology. I am not going to give you any history. I have explained so much. I am just showing you a diffusion sequence, and you tell me which is the blood vessel that is involved. And that is my first question. Which is the blood vessel that is involved here? This is a diffusion sequence and it is appearing hyperintense. So assume that the ADC is also hypointense, which means it is an acute infarct. First, you tell me which vessel is involved. Second, you tell me what is the likely clinical manifestation. Is it a superior division of MCA, inferior division? Oh, absolutely right. Ragini, Rajan, from now, no MCA. You have got to tell me which division. We are conceptually understanding, and yes, you should tell me left superior MCA. Okay. The examiner might want to know only MCA, but let's be specific here, because you can have an examiner who might ask you which exact vessel is involved. Here, it is going to be left superior MCA. And can you tell me, as Khais is telling, absolutely right, Karthik is telling absolutely right, this patient actually presented with Broca's aphasia. Why? It is a dominant hemisphere, superior division, Broca's aphasia. Yes, the patient can have weakness, because unlike the Wernicke's area, Wernicke's means there is no motor strip there. Broca's adjacent to that, you can have motor strip. But in addition to weakness, you can have this Broca's aphasia. Rarely, you might have a scenario where specifically that branch to the Broca alone is affected and the patient only has Broca's. That also can happen, but generally there will be some motor deficit also. Okay, good. Now you tell me another patient. You tell me which vessel is involved, and also you tell me what is the likely clinical manifestation. Abhijit, come on. Abhijit, Dr. Me. Dr. Me, what is your original name? Doctor who? What is your original name? Let's know. Arjun. Very good, Arjun. Left inferior MCA. Good. You have got to tell me the side also. Because what happens, children, you might learn inferior MCA and go. In the exam, they might ask you left inferior MCA, right inferior MCA. So you have got to get the orientation also right. This is the left MCA. And as Kamal is telling, Wernicke's aphasia. Correct. Wernicke's aphasia. Okay. All right. Now a tougher one. Okay. Now a tougher one. This is a patient who presented with acute stroke. All the images are that of a patient And can you tell me, in addition to the, say you can have a, first of all you tell me which vessel is going to be affected. First of all you tell me which vessel is affected. Then I'll ask you the next question. Which vessel is going to be affected here? Yeah, it is the right inferior MCA. So the right parietal is going to be affected. So the patient is likely to have, in addition to the sensory, definitely when there is a parietal stroke, you can have cortical type of sensory loss. So just let me know when there is a right inferior MCA division, can you tell me what is the other important clinical feature that can result? Well, for those who are answering, proximal MCA, this is not proximal MCA because this is slightly a higher cut above. Not, you can see this is not the cut at the level of internal capsule, which is why you might feel that this is a larger lesion. It is only the inferior division that is affected. You can clearly see that the anterior part is spared. So it's only the inferior division of MCA that is. Tanya and Vaika and Prasanna, excellent. So when you have a non-dominant parietal involvement, in fact this patient whom I am showing on the figure actually had something known as hemi-neglect. Okay, hemi-neglect. So this is actually, a hemi-neglect actually occurs in right parietal lesions. Oh sir, why does this occur in right parietal? If you ask me, I'll tell you, no need to by heart. I'll tell you why it occurs. Yes, somebody told, you can have constructional apraxia also. Yes, constructional apraxia can also occur because of the dominant involvement, non-dominant parietal involvement. But this particular patient whom I am showing on the figure had hemi-neglect, and I am going to tell you why does hemi-neglect occur. Okay, no by-hearting in my class, only concepts. Okay, first of all, you understand, you look at this particular figure. You see this is the parietal lobe. Okay, this is the right parietal lobe. This is the left parietal lobe. Okay. Now, normal individuals. Okay, first we are talking of normal individuals. Normal individuals, the right parietal lobe is involved in scanning the right part of the visual field and the left part of the visual field. Okay, right part of the visual field, left part of the visual field. And the left parietal lobe, however, is involved in scanning only the contralateral part of the visual field. You can see here, the right one, you see from the right you are having the left part of the visual field as well as right. Whereas from the left you see, I am only marking to the other side, right side. Okay. So what happens is, when there is a right hemisphere involvement, okay, so the right hemisphere is involved in scanning right part and left part of the visual field. Right parietal involvement, this right parietal scanning is lost. So when the right parietal scanning is lost, the left parietal is there, but the left parietal will scan only the right part. What about the left part? It is not there. So which means if I have a right parietal lesion, I will neglect the left half of the visual field. Hemi-neglect. And some students might ask, sir, you said neglecting left part of the visual field. I have also read somewhere that the patient also will neglect the left half of my body. True, children. Because when I talk of neglect, you can have two types of neglects. You can have a personal neglect where the individual neglects his part or his body part, where he might not shave his left part of the beard. He might shave his right part, he might leave this left part. That is a personal neglect. Whereas he might have a neglect to the extra personal space also, which is a, this particular space around. So that is the extra personal neglect. Okay. So you can have either of these. So in the question they might give a neglect of the person not shaving his part. Okay, the left beard, he is just keeping on shaving his, or he might say that he is neglecting the left part of the visual field. So which means if you go and stand right side, or suppose I am having this neglect, you are coming and standing on my left. I am not seeing you. I am only focusing here. You will have to come here to see. Okay, now you might ask me, sir, I understood the scanning of visual field, but I still have a doubt, sir. You said that this person is not scanning here. So how do I know this is a homonymous hemianopia? Well, children, one of the important differentials of a hemi-neglect is hemianopia. One of the important differentials of a hemi-neglect is hemianopia. But the issue is, if it is a hemi-neglect, the patient, will neglect this and he has no idea that this part of the visual field exists. But hemianopia patient will know that there is the other part is dark, and he automatically will actually make some adjustment to see the other part also. Okay, because he knows that this part is actually dark. So the difference between hemi-neglect and hemianopia is, hemi-neglect means you will not have any attempt from the part of the patient to look there. It will be like he is totally neglecting. Hemianopia means yes, if he is shown something here, he doesn't appreciate. But he can make adjustments like this and look this part. Okay, is it very clear? Is it very clear? So you will have a right parietal involvement causing a left hemi-neglect. Okay, now let me see if you understood. I just will ask you one question. What about right hemi-neglect? Right hemi-neglect, which vessel has to be involved? I am asking you a question. Right hemi-neglect, which vessel has to be involved? I am waiting. If you don't answer, I'll just kick you here. Tanya, constructional apraxia will be there? Yes, definitely can be there. If you ask me, sir, right non-dominant parietal constructional apraxia can be there. You can have hemi-neglect. Will everything happen in the same patient? May or may not. That is why I tell you, in a stroke, all manifestations may not be there in a single patient. Okay. So I just want to know what is the vessel that is involved in a right hemi-neglect. Okay, Lokesh is saying right inferior MCA. Right inferior MCA. Tanya, right. Okay, so let me tell you, it is impossible. It is impossible to have a right hemi-neglect. You see here, you look at this picture. If I have a left parietal involvement, just look at what will happen here. Left hemisphere lesion, that is the third picture that I am showing you. Even if the left is gone, you have a right which will be able to scan both parts of the environment. It is impossible to get a right hemi-neglect. Impossible. You will only have a left hemi-neglect. Yes? Clear? Concept. Okay? Prasanna Venkatesh, you were the first student who answered this question correctly. I am very much impressed. Okay, very good. Okay? Alright. Yeah, Lokesh, then you should think of bilateral infarcts, Okay, that's the only possibility. Yes, that can happen, when you have bilateral infarcts. But again, it is otherwise very difficult because right and left parietal being affected, two different vessels, quite difficult. Okay, all right. Now, see, this is another figure. Can you tell me what is the problem with this patient? What is the problem with this patient? I'm just showing you. This patient was asked to draw a circle and he was asked to, mark the markings in a clock. Okay, can you just let me know what is the problem here? Guys, when you are attending this session, my request to all of you is, don't keep this session for a later date. I'll just watch it later. Please sit down now, write the notes and finish it off. Otherwise, if you plan to watch it on another date, you might take more time. This is not a time where of the exam preparation where you have lots of time. The time is less. So please sit at a stretch. You can have your evening tea or dinner, everything with me. Okay. So, but you are not going anywhere. Please stay here and we are going to finish this. Okay. So this is actually a neglect. Okay. So he was asked, basically, the circle actually was drawn. Okay. And then, in fact, he was not asked to draw a circle. The circle was drawn and then he was asked to do the markings. Okay. So when he was asked to do the markings, circle was drawn by the examiner, and when he was asked to do the markings, he will neglect whatever is, it is being kept at the center. The paper is right in front of him. I am seeing everything only in the right part of the visual field. I am neglecting this part. Okay. So I will not actually mark the other place. Because why I specifically showed is because some students actually mistake it for constructional apraxia. Please, this is not constructional apraxia. I'll just show you what is a constructional apraxia. But here, when a clock is actually being drawn and the person is being asked to mark, he is neglecting one exact half of the visual field. This is going to be a neglect. Whereas in case of constructional apraxia, you are giving the patient a model to draw and you see this is how his copy is. Okay, very shabby, is not getting the exact three-dimensional figure. This is what you call a constructional apraxia. But I agree, the part of the brain that is involved, the non-dominant parietal, that is the one that is involved in case of the constructional apraxia as well as your hemi-neglect. Okay, hemi-neglect. All right. Okay. Now I am going to show you another figure. Okay. All right. So the question here is, this patient presented with hemiplegia, hemianesthesia and hemianopia. Okay. This is the MRI. You just tell me which vessel is involved. Okay. Slightly tough question, but let me see if anybody clearly remembers the anatomy picture that I showed you. Okay. Which vessel? So Prasanna has rightly said this is a lacunar infarct. I agree with that, Prasanna. Good. But can you tell me which vessel? Yeah, it's a lacunar infarct. Lenticulostriate, lenticulostriate. So many are going for the lenticulostriate. Okay. Yeah, I saw somebody giving the right answer. Yeah, I think a couple are now giving the right answer. Now see, I'll just bring your attention back to this figure. Remember, we were focusing on the MCA divisions, MCA superior, MCA inferior and the MCA D branches. This is the ACA and this is the ACA D branch. ACA D branch, we'll come to that later. This is PCA, PCA D branch, we'll come to that later. But there is some vessel that is being sandwiched between these vascular territories. And that vessel is the anterior choroidal artery. Okay, that is the anterior choroidal artery. So you see here, this part that you see here is the region of anterior choroidal artery. So when you have an anterior choroidal artery involvement, anterior choroidal is a branch of which vessel? Again, internal carotid. So this is also very close to the internal capsule. So the manifestation can be very similar to that of a deep MCA branch stroke, that is your lenticulostriate stroke, like your hemiplegia, hemianesthesia, hemianopia. But let me tell you, most of the cases of your anterior choroidal artery stroke will not have significant symptoms like your lenticulostriate, though theoretically you expect a dense hemiplegia, hemianesthesia and hemianopia. An anterior choroidal artery stroke is usually not going to produce significant manifestations. Can you tell me why? Can you tell me why? Because I already told you, no? I already gave you the hint earlier. Supply is posterior limb is what Tanya says. Venkatesh, keyhole defect. I do not have any idea what that is. What is a keyhole defect? Vaikha, it is also having corticospinal involvement. Don't think that it is not having corticospinal. Remember when we saw again the branch of the internal capsule, you see here the anterior choroidal is supplying the posterior limb of internal capsule. And you know that genu and anterior 2/3 of the posterior limb is having the corticospinal fibers. So you can have, it's not that there is no corticospinal tract. And who is telling? Arjun Menon is giving me the right answer. Arjun Menon is giving me the right answer. Very good. So basically the problem is, see, anterior choroidal artery I told you is being sandwiched between all these vessels, ACA, MCA, PCA. Okay, it's an exact sandwich area between, just adjacent. Here you have ACA branch, here you have PCA deep branch, here you have MCA deep branch. All are very close. So you have 3 big territories. So you will get some collateral supply from these territories, which is why anterior choroidal artery strokes usually, will not be that significant. In fact, it will not produce significant weakness. Okay, all right. So that is also clear. But theoretically, you can have the manifestations just like an just like a lenticulostriate stroke. Okay. So I hope MCA is clear. Now we are done with MCA. Now we are going to ACA. Now children, you tell me whether it is clear for you on the localization of MCA stroke. Just let me know. Give me a thumbs up if you are clear with the localization of MCA stroke. Okay. All right. And we have done anterior choroidal also. Next is we are going to anterior cerebral artery strokes. ACA stroke. Anterior cerebral artery. So this one is the anterior cerebral artery, you can see here, and you can see the pericallosal branch of the anterior cerebral artery, the calloso-marginal branch. So predominantly it's supplying the medial cerebral hemisphere. Okay, medial cerebral hemisphere, it's quite clear. All right. Okay, so yes, once again let me show you, this is the territorial supply, this is the ACA territory. Okay, predominantly the medial surface. All right, and it also supplies a very, very important region. Can you tell me what is this region that is being highlighted in green? What is that region that is being highlighted in green? Yeah, this is going to be the paracentral lobule. This is going to be the paracentral lobule. Okay, paracentral lobule. So this region of paracentral lobule is actually important predominantly because of 2 reasons. One is this region is supplying the leg area motor innervation. Okay, leg area motor innervation, and also this is involved in the bladder control. If you have listened to my lecture in Doc Tutorials app, where I have, specifically there is one module where I have just discussed bladder, because many students have this bladder confusion. So I've explained that in detail. So bladder involvement, even it is, I think that particular video is available in YouTube also. You can just type my name and search neurogenic bladder, so that you can watch. So these 2 are actually important functions of the paracentral lobule. Now you see here, when you have an ACA territory stroke, that is anterior cerebral artery stroke, first of all, what happens to motor manifestations? So motor manifestations, do you expect hemiparesis? Well, it's usually, you can see it is a lower limb monoparesis. Lower limb monoparesis. That is contralateral lower limb motor paresis. Okay. That is a left ACA involvement can produce a right lower limb weakness. Why does it produce? Because the left paracentral lobule is being affected. The left paracentral lobule is going to supply the right lower limb. Okay, so left lower limb monoparesis. The contralateral lower limb monoparesis. Now let me ask you one thing, can there be upper limb? Usually no, but there can be. Because remember I told you in actual real life, remember all those beautiful diagrams that you have drawn in anatomy on the watertight compartments between ACA, MCA does not exist. So you can have some sort of ACA supplying the region of upper limb also rarely. So you can sometimes develop a hemiparesis, but even if it is a hemiparesis, it will always be lower limb much more affected than the upper limb. Okay. Now next is, can there be sensory involvement? What do you say? Sensory involvement. First tell me whether there will be sensory involvement. That's my question number 1. My second question is, if your answer is yes, if you believe there will be sensory involvement, you tell me what sort of sensation will be affected. Is it going to be the cortical sensation or is it going to be the deep sensation? Okay. So see, the problem here is, there will be sensory affection, because just like you have the motor strip that is located here, in the parietal also you will have the sensory strip. So if I just draw the sensory strip, you might have a sensory strip here in the post-central region. Even the sensory strip also, the leg area is supplied by which vessel? It is the anterior cerebral. So in the sensations also, the cortical sensations especially will be affected. Why? Because it is the ACA supply. Okay. So I hope that figure answers your query. Okay, that figure answers your query. You can have sensory, but it is going to be a cortical type of sensory loss. Cortical type of sensory loss of the lower limb. Usually upper limb sensory will not be there. Okay, motor sensory. Now next question is, will there be visual? Now you answer this. Will there be visual or not? Visual manifestation, will it be there or not? Everybody, just commit to the answer, okay? Even if it goes wrong, it's okay. We are trying to learn it conceptually, okay? That's why, see, many of you have answered correctly, okay? There is not going to be any visual, because where is the optic radiation? You see here, this small particular strip is going to be involved, and that also in the anterior cerebral artery territory. Do you think there is any optic radiation there? You remember the figure of the optic radiation that I showed you. You see here, this is the optic radiation. Do you think this is anywhere related to the anterior cerebral artery? No. Which is why you will not have visual manifestation. You are not going to have visual manifestations. You are not going to have visual manifestations. No visual manifestations. Okay. So that is also very clear. So, so these are the important points that you have got to understand. And you can have a bladder involvement, and bladder involvement usually occurs when there is a bilateral ACA involvement, because some individuals, they can have an unpaired anterior cerebral artery. I'll tell you, if the individual has an unpaired ACA, okay, unpaired ACA, both these regions can be involved. Okay, so when both the paracentral lobules are being involved, you can have bladder involvement. Then sometimes you might ask me, sir, what about one paracentral lobule? Can it produce bladder? Rarely that can also produce. Because when one paracentral lobule is affected quickly means stroke is always an acute event. So when it is being affected, you can have a scenario where the other paracentral lobule might take some time to get adjusted to the the new demand, supplying both sides. So which is why even sometimes, rarely in a single ACA infarct also, rarely you can have a bladder involvement, but classically it is in unpaired ACA involvement. So when you have an unpaired ACA involvement, you might have what? As the motor weakness, you can have paraparesis. See, we have had patients, presenting with acute paraparesis. So somebody has taken MRI of thoracic spine, cervical spine, everywhere he has taken. In the entire spine MRI they have thought it to be paraparesis. Then they did a nerve conduction study thinking, could it be a GBS producing paraparesis? But remember, it was an acute event. So acute event, and nobody bothered to check the plantar as well. Nobody bothered to check the cortical sensations in the lower limb. So this was in fact an unpaired ACA producing a stroke. Unpaired ACA producing a stroke as a paraparesis. Okay. All right. So let me see if there is a. Yeah, Saransh, it's glad that you are liking the session. Thank you. So this actually is clear, no? ACA territory. So motor, sensory, no visual, bladder can be there. Okay. Now, when you have, it's because somebody was typing here, some visually inappropriate behavior. Socially inappropriate behavior. You can have socially inappropriate behavior. I agree. But usually in strokes, you do not have inappropriate or your disinhibition and all in strokes. Usually can have. Why? Because when a single ACA is being involved, only one frontal lobe is being involved. So the other frontal is still active and it is normal. So this social disinhibition and all and your behavioral problems are likely to happen when there is a bilateral frontal involvement. And if you remember my lectures, I have taught in the dementia module in the app that when you have dementias like behavioral variant frontotemporal dementia, where both frontal is involved, that is when you are likely to have the behavioral changes. That is when you are likely to have the behavioral changes. I hope that is clear. Okay. All right. So now you tell me, this patient has presented with acute onset what? Acute onset what? And the CT is showing what? Simple, it's for you to answer. Yeah, Prasanna Venkatesh, good you know about Phineas Gage, though your spelling is slightly wrong. Okay, I hope you know about the episode that has happened to him. Good, so your general knowledge is actually good here. Yeah, so this is going to be a left anterior cerebral artery stroke. Left anterior cerebral artery stroke, left ACA infarct. Okay, so this is a left ACA infarct. And I have already told you the manifestations. Now, you look at this. The earlier one was CT. This is MRI. Now, you tell me which vessel is involved. See, when it comes in the exam, they will give you the clinical feature and give you the MRI. Okay. And you will be asked to diagnose. Okay. Which vessel do you think is affected here? Which vessel? Simple one. Okay. So once we are done with the stroke localization part, next will be COVID-19. It's very, very important. I'm going to discuss in detail about the COVID-19 management. Okay. Because in your exam, some questions are sure shot. Okay. All right. So this again, as many are correctly answering, this also is a left ACA territory stroke. This is also a left anterior cerebral artery ACA territory stroke. Okay. All right. So remember, what is the difference between this section 1 and section 2? Can you tell me which is a section, axial section taken at a lower level? Is it 1 or 2? Which is a section taken at a lower level and which is the axial section taken at a higher level? And you tell me why also. Okay. Arjun, why do you say 1 is lower? Everybody are saying 1 is lower. Why? Prasanna, you are saying 2 is at lower. Prasanna, are you able to see the ventricles in 2? Are you able to see the ventricles in 2? No. See, as Manish Singh is correctly saying, very good Manish, because see in 1 you are able to see the ventricles, which means it is slightly lower. As you go higher, the higher cortical cuts, you will not be able to see the ventricles, just like in the figure number 2. So 1 is a lower cut and the 2 is a higher cut. Okay, all right. So now you see, I'll show you a CT. Which vessel is involved? Plain CT. Which vessel is involved? So I'm just waiting because there will always be a bit of lag between the video shoot and the when it streams on YouTube. Okay, that's the reason why there's a small delay. Abhijit, if you are near me, is it left ACA or right ACA? I'll just give you a kick if you were near me. Okay, it's okay to go wrong. Okay, I'm just joking because I feel. If you make a mistake now, I think you should be happy because you should not make a mistake in the actual exam. See, my belief always is in learning, it's okay to make mistakes because some students always have this feeling, will I be judged if I make a mistake? Please have no inhibitions. Everybody is learning. You are learning, I am learning. So we all make mistakes every day. So we are all learning from mistakes. Okay. Alright, so many of you say right ACA, but still I am not very happy with the answer. I'll tell you why. I am coming back to this. So we have seen this is the ACA. Now in addition to the branches of the ACA that I have already talked about, there is one branch of the ACA that actually comes back. There is a recurrent branch. And what do you call that? The recurrent artery of Hubner. The recurrent artery of Hubner. Recurrent artery of Hubner. Okay. Now this recurrent artery of Hubner is nothing but the deep branches of ACA, which I am highlighting now. So if you ask me, sir, which is the major region that is supplied by the deep branch of ACA, I just highlighted one portion. No, that portion is where? What region did I highlight? Just tell me what region. This is almost very similar to the head of the caudate nucleus. So this is very similar to the head of the caudate nucleus. So that region is going to be supplied by the recurrent branch of ACA. And will the recurrent branch of ACA supply the internal capsule? You remember the figure that I had showed you long before. Yeah, this one. You see the anterior limb of the internal capsule, the inferior portion is supplied by the recurrent branch of ACA. But please understand, even the genu, in this figure I have written, it is the branches of internal carotid and posterior communicating artery that is supplying the inferior part of the genu. But rarely the recurrent branch of the anterior cerebral artery can supply the genu as well. Which is why when you have a facio-brachial monoplegia, okay, whenever you have the recurrent branch of ACA involvement, you might have a facio-brachial monoplegia. Now, why does a facio-brachial monoplegia occur? Because if you look at this particular figure, you see the arrangement is fat lady, face, arms. So, when this genu, this part is involved, so it will cause the weakness of the face as well as arm. Okay, so that is why you can have a facio-brachial monoplegia associated with a Hubner artery stroke. Okay, you can even have it associated with a Hubner artery stroke. So this is the Hubner's artery Humerus artery, and which side is it? This is a right Humerus artery, or you could have said the D branches of the MCA, okay, D branches of the MCA, and you can have a left facio-brachial monoparesis or monoplegia. Okay, so Humerus artery is involved. All right. So here again, just because the caudate is involved, I told you, whenever the basal ganglia is involved, usually it does not produce much of extrapyramidal, though rarely it can produce, which is why commonly you might not find extrapyramidal manifestations as a part of stroke. Okay, all right. Now they might give you another picture, and here again, what do you think is the blood vessel that is involved? I am showing you a diffusion. I am showing you a diffusion sequence. I am showing you a diffusion sequence. Which vessel is being involved? Karthik, I want you to be more specific. Remember, we are done with the ACA thing, you have got to be specific answer. After my class, the only thing I want you to follow is further. It's not just for your entrance. Be specific with your answers. Just like, see, yes, good. Tanya, Blue Minan Doctor, Lokesh, you have just said ACA. It's a D branch of ACA. Minan, it's not MCA, it's ACA. Okay, so this is again, see clearly you can see the caudate nucleus, no? The region of the caudate nucleus. Okay, so this is again a D branch of ACA. D branch of ACA on the left side. So this patient will most probably have a right facio-brachial monoparesis, left recurrent artery of Humener. Okay, all right. So we are done with the ACA strokes. MCA over, ACA over, next coming to the last vessel, PCA stroke. So you see here the posterior cerebral artery, okay, posterior cerebral artery. So this is again the circle of Willis. Okay, so you see here this is the vertebral artery, the two vertebral arteries joining to form the basilar artery. Then you have the posterior cerebral artery. So posterior cerebral artery, there is a posterior communicating artery here, and the part that is proximal to the PCOM is called the P1 segment, and the part that is distal to PCOM is called the P2 segment. So there are branches from the, or vessel branches from the P1 segment, small branches are there. So the P1 segment will be mainly supplying the midbrain and thalamus. The P1 branches will be mainly supplying midbrain and thalamus. Okay, whereas the P2 branches will be supplying the medial temporal, it will be supplying the temporal and occipital cortex. Temporal and occipital cortex. Okay, so that is P1 syndrome, and other is, so whenever you have a vessel that is being involved in the P1 branches, you will call it a P1 syndrome, whereas distal is supplying the cortex. Why is it cortex? Because you can see, P2 is going in this direction, naturally it will supply the cortex. So P1 is going to supply the midbrain and thalamus. Okay, just to again show you different views. Okay, this is, you see these are just different views because you have got to have a 3D view. You see this is a view from the base of the brain. You can see the vertebral artery, again the basilar artery, the posterior cerebral artery also, and you can see the posterior communicating artery which is communicating it with the anterior circulation. This is a view from the lateral side. This structure which looks like an egg is the thalamus. Okay, thalamus is like an egg. Okay, all right, and then you see the lateral view, you see the vessels supplied to the cerebellum as well. We are just focusing or visualizing the posterior circulation. Superior cerebellar artery, you can see the short and long circumferential pontine arteries, the basilar arteries and its branches, anterior inferior cerebellar artery, posterior inferior cerebellar artery, vertebral artery, anterior spinal artery. Okay. Now you see we are just going to deal with the P1 syndromes first. P1 syndromes means you are going to have affection of midbrain and thalamus. Let's have a look at the blood supply of thalamus. See, this is the thalamus, the egg-shaped structure. You see which are the major vessels. One is the thalamic subthalamic arteries, which you can also call it as the thalamo-perforating vessels. Thalamo-perforating vessels, okay, which is supplying the medial part. This is a part of the P1, I told you. But please remember that though P1 is definitely supplying, you can have P2 branches also supplying the thalamus, though mainly it is P1. So P2 branches, you can see you have supply again. So you can see the P2 posterior choroidal artery from the P2. You can also see the thalamo-geniculate artery also from the P2. Okay, the thalamo-geniculate artery also you can see. And from the posterior communicating artery, which actually connects the anterior and posterior circulation, you have another branch which is known as the polar artery. Okay, the polar artery is also there. So these are the vessels: thalamo-perforating, thalamo-geniculate, posterior choroidal and polar arteries are the blood supply to the thalamus. Okay, all right. Now you see, when you have different types of thalamic infarcts, depending upon the vessel affected, okay, you can have different infarct patterns. If you have a thalamo-geniculate artery, this is going to be the site of infarct. You first see the thalamo-geniculate here. Okay, you are seeing the thalamo-geniculate. This is the TG, thalamo-geniculate. So this is where the infarct is. Okay, this is where the infarct is. When you have an anterior polar artery, because we have seen polar artery is a branch of which vessel? PCOM. This is where the infarct is. When you have a thalamo-perforating artery, you can see the infarct is like both sides, because I'll just show you why it is both sides in the next picture. Okay, it can have single side also, but we'll come to that. And this is the posterior choroidal artery, posterior part of the thalamus. Okay, now just have one look at this picture once again, and I am going to show you an image up next. Let me see how many of you correctly identify the infarct, because not only that it is a thalamic infarct, you have got to tell me which vessel is being affected. Okay, so this is the diffusion sequence, and this is the region of the thalamus. I'll just highlight the region of thalamus, the egg-shaped thalamus here, and you tell me which vessel is involved. Which vessel is involved? Great. So it is a polar artery. Okay. See, now children, everything makes sense, no? So rather than, by hearting, if you have the anatomy visualization, which is why, if you are a medicine person also, or a physician, or a super specialist, or whatever you are, your basic science has to be strong. Okay. Otherwise, you would just be mugging facts. If you understand the basic science well, I think it is always easy to connect the dots. Okay, which is why I have been highlighting the anatomy part also quite a lot in this lecture, including the radiology also. So I hope that is very clear to you. Now you see, this is another vessel involvement. So can you tell me here, what is the likely infarct that has occurred here? What is the likely infarct? It is again, this is the thalamus. This is the region of thalamus. So here what has happened is, see, I'll just tell you something. Okay, when it comes here, I'll just tell you what is artery of Percheron. So this is a normal individual, and this is actually a variant. It's not a pathology. Many of you might be having a variant known as artery of Percheron. I'll tell you what this is normal versus artery of Percheron. You see here, this is the basilar artery. It is dividing into two posterior cerebral. So these are the thalamic and midbrain perforators, because I told you there are thalamo-perforating arteries which actually supply the region of thalamus, but not just the thalamus. The thalamo-perforating arteries of the P1 segments, P1 is also supplying the midbrain. So normally these would be single small vessels. Now you tell me, when you have these single small vessels, what is the likely pathology that can affect these small vessels? Is it going to be atherosclerosis or is it going to be lipohyalinosis? What is going to affect? These are small striate vessels, so it is going to be a lipohyalinosis. Correct? No? It is going to be a lipohyalinosis. Now when you have a penetrating vessel that is involved, a single penetrating vessel that is involved, do you think it is going to produce much of manifestations? No. Why? Because there are so many perforators here. So a single perforator involvement usually does not produce much symptoms. However, some individuals will have a vascular variant. It doesn't mean that that particular individual is definitely having some pathology. It's a normal anatomical variant that can occur in some individuals where from the PCS segment of one side, either the P1 of the left side or right side, there occurs an artery of Percheron or AOP. So it begins as the AOP, and from the AOP the further perforators are given off, which means if you have an involvement of the artery of Percheron, okay, again a perforating artery there, but when you have the artery of Percheron involvement, it will cause devastating consequences because it is supplying, it is from the artery of Percheron, you have all these individual perforators that supply the midbrain and thalamus originates. So you will have midbrain and thalamic features also. Okay, very clear. So artery of Percheron will have both features of midbrain and thalamus involvement, and this patient is having a artery of Percheron. In fact, the main clinical features of artery of Percheron include, you can have abulia, you can have drowsiness, you can even have vertical gaze palsy. Why vertical gaze palsy? Can somebody tell me why vertical gaze? Let me see how strong you are in your ophthalmology part also. Why vertical gaze is affected? Because the vertical gaze centers are located in the midbrain. If you see here, this part is actually the midbrain. You know, this red part which I have highlighted now, this is the thalamus. But this part which I am showing, this is the region of the midbrain. Okay, this is the region of the midbrain. So when there is an artery of Percheron in fact involvement, there is a midbrain involvement also, and you can have the vertical gaze centers being affected, which is why in an artery of Percheron stroke, you can have abulia, drowsiness and vertical gaze palsy. Okay, is it clear or not? Okay, that is the manifestation of artery of Percheron infarct. So just coming back, if you see here, that is why I told you in the paramedian perforating, I showed you the infarct per se is affecting both sides. Why did I say both sides? Because single perforator affection will not produce much manifestation. It is when you have an artery of Percheron that actually produces manifestation. In the other scenarios, when you have the thalamus being involved, the type of stroke that results is called a Dejerin-Roussy syndrome. Dejerin-Roussy syndrome. So Dejerin-Roussy syndrome means when the thalamus is being involved, you will definitely have sensory manifestations. So the patient is likely to have, you know, if it is a stroke, it is likely to be a sensory stroke. So if it involves both the VPM as well as VPL, we have already discussed that, entire hemisensory loss will be there, including the face. Okay, VPL as well as VPM can be involved. So there will be a contralateral hemisensory loss. Contralateral hemisensory loss. But in addition to the hemisensory loss, he will also be having burning type of pain. Okay, that is in the same area. So basically to touch, you know, to the sensations, is having the affection of the deep sensations. Remember, thalamus is affected, so definitely both your deep sensation as well as cortical sensation is affected. Remember, deep and cortical will require an intact thalamus. But in case of superficial sensations, it requires intact cortical area only. So you will have a contralateral hemisensory loss and a burning pain. Okay, if you are there in my Telegram group, some weeks back I have shared one case also of a patient who presented acutely to me with a hemisensory symptom. Okay, in fact, it did not even come to emergency. It was a routine OP visit. Last day onwards, she is having a hemisensory loss and burning sensation. But she had no weakness, no facial deviation, nothing. What actually happened is that this was a thalamic stroke. And since there was no facial deviation weakness, it was not recognized as a stroke. In fact, she went to a nearby hospital, but again, since only sensory symptoms, they manage sensory only. But see, what prompted me to think it is a stroke is because of the acuteness of the onset. Somebody who was completely normal by 6 a.m., on the next minute he develops this symptom, you should always think whether it is a vascular, because vascular always will have a acute onset. Okay. Yeah, Tanya, as you rightly said, even in the current INI-CT also, they had kept a similar section. In fact, for that they had given a sagittal, the coronal anatomy image also on the which structure was being involved. Okay, so this is a Digeron-Rowsey syndrome. Okay, all right. So this is Digeron-Rowsey syndrome when the thalamus is being affected. All right. Now this is actually a P1 syndrome. Now you can also have P2 syndromes. We will come to certain other P1 syndromes in a short while. But you can have P2 syndromes when the temporal and occipital cortex are involved. So can you tell me two important P2 syndromes? They are going to be what? Anton syndrome as well as Balin syndrome. Anton syndrome as well as Balin syndrome. These are actually the P2 syndromes. Okay. So when you have a bilateral affection, so these P2 syndromes producing visual problems mainly happens when there is a bilateral affection. Because when you have a bilateral affection, that is when both your P2s are gone. And when does bilateral affection happen? That actually happens when there is hypotension. So whenever there is hypotension, that can cause a bilateral P2 affection resulting in Anton syndrome as well as Balin syndrome. Okay, so these two syndromes, Anton's as well as Balin syndrome, are examples of P2 syndromes. Okay. After a short while, I'll give you a clinical scenario of Anton as well as Balin. Okay. After some time, I'll give you a clinical scenario. We'll come back to that. Okay. Anton syndrome, Balin syndrome, very, very important. All right. Okay. All right. Now to some of the brainstem syndromes. Now in the next half an hour, we'll be done with strokes. I am going to teach you, okay, some of the tips and tricks for localizing a brainstem stroke. Because many students often ask me, sir, often it is very confusing, the brainstem stroke, so many named syndrome, this book gives this, that book gives this, what is the answer? But the basic problem actually is you are not thorough with your neuroanatomy. Either you are not thorough with your neuroanatomy or you have not correlated neuroanatomy with medicine. That is the most likely scenario. You might have learned, but you are not trying to correlate it with medicine. Okay. All right. So now look at this. This is a section, sagittal section. You are viewing from the medial surface. This is the midbrain, pons. You see this is the medulla. All right, this is the basal area. Okay, you see the crus cerebri here. The region of tegmentum you are seeing. Fourth ventricle. This is the cerebral aqueduct. Tectum. Okay, tectum, tegmentum, everything. So this is there. Now, when you have a brainstem syndromes or any brainstem affection, please understand that there are a few important structures which are located in your brainstem. So one is you have various long tracts in the brainstem. You have ascending tracts as well as descending tracts. So that is when you say whether or not there is long tract affection. Okay, so many tracts. Let's try to understand what are passing through the brainstem. Second, you have various cranial nerves located in the brainstem. Third is you can have reticular formation also located in the brainstem. Okay, and you can have the cerebellum also by virtue of various connections like the superior cerebellar peduncle, middle cerebellar peduncle and inferior cerebellar peduncle connecting the midbrain, pons and cerebellum with the midbrain, pons and medulla with the cerebellum. Okay, these are the connections. First of all, I am coming to midbrain strokes. First of all, you and me, we are just going to casually glance through the section of midbrain. I'm just going to casually glance, okay? I'm not going to teach you in detail, but just let us casually glance. This is a section at a higher level of midbrain, at the level of superior colliculus. So how did I understand this is a section at higher level? Because the superior colliculus is there. So that is a higher section. And the below one, I will be showing you a section at the lower level. So when you have the midbrain, always think of the cranial nerves. What are the two cranial nerves that are related to the midbrain? You are having the third nerve as well as the fourth nerve nucleus in the midbrain. And you are having various long tracts. You are having the motor tracts which are going through the crus cerebri. Okay. You are having other structures like red nucleus. Okay. You are having other various structures like the spinothalamic tracts, the medial lemniscus. Okay. Remember, I told you already about the medial lemniscus. Where does it cross? Remember, the posterior column ascends. At the medulla it crosses and then the posterior column continues at the medial lemniscus. That is why I told you all these figures at the initial part. Then the spinothalamic part. Okay. So this is the third nerve nucleus, oculomotor nucleus. Okay. You are seeing that. Okay. Just casually glance. Okay. No need to by heart anything. Just casually glance. That is enough. To solve stroke syndrome questions, you need not be 100% expert, but even if you are a 60% expert with some logic, you will be able to answer all questions correctly. Okay. All right. So this is the trigeminal lemniscus also. This is a section at a lower level. So you can see the trochlear nucleus. So oculomotor nucleus is at a higher level and trochlear nucleus it is a lower level. Remember, even this anatomy question was asked in this current INICET. Okay. With respect to the location of the oculomotor nucleus. So here again you can see the motor fibers as well as the various other sensory fibers also. The spinal lemniscus, okay, all these fibers, medial longitudinal fasciculus, okay, we're just casually glancing through. Now let's look at the stroke syndromes, okay. Now first of all, let me tell you the individual stroke syndromes. Now I'm going to show you the reference for this table is going to be De Jong neurology, okay. So it is going to be De Jong neurology. Now please understand something carefully here. I am just going to tell you some features regarding the brainstem syndromes. Even between standard neurology textbooks, there are certain differences in the component clinical features of individual syndromes. You might ask me, why is that disparity? Because if there is a name syndrome and somebody has named it with these features, why should it be different in different textbook? The reason is, children, this is a stroke. So I told you strokes are actually different. So when you have two individuals with the same vessel affection, there can slightly be differences depending upon the collaterals. So even if you check, say, a textbook like Harrison or maybe a neurology textbook, because Harrison is never a gold standard textbook for anything. It's at your level, Harrison is the gold standard, but when you go to a higher plane, whether for neurology, you have to be thorough with Bradley neurology. For cardiology, you have got to be thorough with Braunwald. But at your level, Harrison is the gold standard. But please understand, between textbooks, there can be variation. So no need to worry too much regarding these small differences, because you will not find a question in the exam which is again focusing on these minute differences. Okay, trust me on that. Now, first of all, you are going to have a syndrome by name Weber's syndrome. Okay, Weber's syndrome. Now, one of the important features of all these brainstem syndromes is that they will be having crossed hemiplegia. They will be having crossed hemiplegia. Now, why are they having crossed hemiplegia is because when you have a brainstem involvement, okay, I'm just telling you a scenario of a midbrain. Okay, let me just take a section of the midbrain here. Okay. I'm just going to draw the third nerve pathway, okay. So this is how the third nerve is going to come out. Okay. Now if you have a lesion, which I am going to highlight here, okay, which I am going to highlight here, this is the one that I am highlighting. So you have a lesion that is involving the third nerve fascicle. What is the difference between a third nerve and a fascicle? The portion of that cranial nerve within the substance of the brainstem is called fascicle. You know, the origin will be the nucleus, then the part that is inside the midbrain of the third nerve, that is called a fascicle, and once it exits out of the midbrain, you will call it a oculomotor nerve. So when you have this sort of a lesion, suppose this is the right side, this is the left side. So you will agree with me that when you have a right-sided lesion there, you will have, let me come back to this, you will have a right third palsy, okay, third fascicular nerve involvement, right third fascicular involvement. But when it comes to weakness, remember I told you the crus is actually being involved. So when the crus is being involved here, remember the descending corticospinal tract, the long tract is a descending tract and it will cross in the medulla only. So when you have a right part of the midbrain that is being involved here, is it going to be a right-sided weakness or a left-sided weakness? It is going to be a left-sided weakness. So you will have a right third involvement plus a left weakness or a left hemiplegia. Okay, so this is actually what is called a crossed hemiplegia. Remember, Weber is not the only condition that produces crossed hemiplegia. Crossed hemiplegia means basically you have a cranial nerve, LM and cranial nerve involvement on one side and the hemiplegia on the contralateral side. So that is what you call a crossed hemiplegia. So when you come to Weber's syndrome, you see here the midbrain base is the one that is being involved. That is the anterior part of the midbrain is being involved. So what are the fibers that are being involved? The third nerve fibers as well as the cerebral peduncle, the crus cerebri being involved, which is why you get a ipsilateral third nerve and a contralateral hemiplegia. Now when it comes to Benedict syndrome, okay, see, Benedict syndrome is actually an extensive lesion, that is in addition to these third nerve fibers and the corticospinal tract that is being affected. What if, okay, once again let me draw, what if you have a more extensive lesion involving these parts? So here you have got the involvement of the crus cerebri, you have got the involvement of the oculomotor fascicle, as well as the red nucleus is also involved. Okay. Now some textbook you might find that in Benedict syndrome they have not written corticospinal. It's okay because there may be, because you cannot tell the blood vessel, see, don't go and supply the crus cerebri, please stop with red nucleus only. You can have variations. So don't just tell that, okay sir, this platform they said this vessel, the other platform they said this vessel. See, this is actually clinical medicine, and when you have clinical medicine there can be such exceptions where a particular stroke might not actually involve this territory. Okay, so even standard neurology textbooks will differ, standard medicine textbooks will also differ. So when it comes to Benedict syndrome, it is involving third red nucleus and corticospinal. It is plus or minus corticospinal, sometimes it may not be affected. So in addition to the features of Weber's, okay, you may also have a feature corresponding to the red nucleus involvement. And what is that feature? It is going to be a rubral tremor. Okay. So in addition to the Weber syndrome, you might have a rubral tremor. Now some students might ask, sir, I saw in another textbook that in addition to tremor, there is also ataxia. but some other textbook ataxia was not written. I'll tell you the reason why. Because have you heard of this particular term that is by name dentato-rubro-thalamo-cortical tract? Dentato-rubro-thalamo-cortical tract. So from the cerebellum also you are having connections to the red nucleus. Where is the red nucleus here? Rubro, red nucleus. So sometimes when the red nucleus is involved also there can be ataxia, but it is not a major feature. Okay. Alright, but the major feature will be a rubral tremor. The major feature will be a rubral tremor. So that is also clear. Benedict syndrome. Now when it comes to the next syndrome, that is called the Claude syndrome. Now here the lesion actually goes slightly backwards. Now here you can have the cranial nerve 3 fibers, that is the fascicle of the third nerve, red nucleus and the superior cerebellar peduncle. Now that is the additional structure here, because here also you might find some textbooks not giving red nucleus only Benedict. See, in Claude syndrome the predominant structure that is being affected is not the red nucleus, it is the superior cerebellar peduncle, which means it's a slightly posterior lesion. Okay, it is slightly posterior, it is not an anterior lesion. Why do I confidently say this is not an anterior lesion? Because had it been an anterior lesion, you have the crus cerebri, the cerebral peduncle here, there will be weakness. So when there is no weakness means it is a more posterior lesion. So you can have superior cerebellar peduncle affection, and because of that what will happen is that in addition to the ipsilateral third nerve palsy, you will have contralateral ataxia and rubral tremor. Rubral tremor, why? You can have red nucleus. But what is the major feature? It is the contralateral ataxia. Okay, alright. Now the next syndrome is North-Nagel syndrome. Okay, we will come to that first syndrome. Okay, the perinods will come in a short while. Next is North-Nagel syndrome. Well, North-Nagel syndrome is again related to the Perrinod syndrome. In fact, it is a variant of the Perrinod syndrome, where again the lesion is actually posterior. So when the lesion is posterior, you can have oculomotor palsy, and along with that you will have ataxia. Okay, so you will have oculomotor palsy, ataxia, again because of the involvement of the superior cerebellar peduncle. In addition to that, you will also have vertical gaze problems. Sir, I did not understand why vertical gaze. Remember, midbrain is the seat for vertical gaze. Sir, how to remember, sir? Midbrain, vertical, the others, pons and medulla more towards horizontal. How to remember? See, which is the cranial nerve that, that is involved in your vertical eye movements. Okay, so you have the third nerve is there, no? The third nerve is there, which is actually involved in supplying, your muscles like superior rectus. So the muscles that are involved in actually supplying your vertical eye movements are located where? In the midbrain. So the other vertical eye movement centers also will be in the midbrain. Okay, at least some of you would have heard about the interstitial nucleus of Cajal and all in the midbrain. So there will be vertical gaze problems also. That is called North-Nagel syndrome. Now another student is going to ask me, sir, you said ataxia, but you did not say which side, sir. Is it ipsilateral ataxia or contralateral ataxia? In one platform I saw ipsilateral, another platform I saw contralateral. I will tell you why. Now see, the basic reason is, again you have got to have an understanding of anatomy. So why is there, some books it is written ipsilateral. In fact, both are right. You can have ipsilateral or contralateral. I'll tell you why. See here, look at this picture carefully. You have multiple markings here. So you focus on only what I tell you to focus on. So you first look at dentate nucleus here. From the dentate nucleus, you have fibers going to red nucleus, dentato-rubro. Then it goes to the thalamus. Okay, dentato-rubro-thalamo. Then it goes to the cortex. So you have a dentato-rubro-thalamo-cortical. Is this pathway crossing or not? Is it crossing or not? It is crossing. It is crossing. You can see that at the level of the red nucleus, that is, where is the red nucleus? In the midbrain. It is crossing. And then when it comes to the descending pathway, that is the cortico-pontocerebellar. I am sure that in physiology, you would have heard of double crossing. If you have not, please understand that this is the double crossing. From the cortex, you have again the corticopontocerebellar fibers. So from the cortex to the pons, you can see the pontine nucleus. Then again it crosses to the opposite side, corticopontocerebellar. Okay. So basically the problem is, here also you are having crossing. The second crossing, this crossing is at the pons. Now in case of a midbrain involvement, so don't you think that when you have all these connection involvement, so whether or not the lesion is before to the crossing or after the crossing, you can have variations, correct? No? Ipsilateral ataxia or contralateral ataxia. Because something that is on the same side of cerebellum will have ipsilateral ataxia. But if it is contralateral, you will have contralateral ataxia. So the problem I am trying to tell you is, don't confuse too much regarding ipsilateral, contralateral in these Northnagle and all. Even De Jong just tells you it is ataxia. But you might have some textbook saying contralateral, and this is the reason why. So no need to burn your brain for that. I hope that is clear. But only thing you have got to understand is, if it is a ventral lesion, you will have the pyramidal tract and all being involved. When it goes to dorsally like Northnagle, did I say about any weakness in Northnagle? Because it is a posteriorly located lesion. Okay, that's why. Now coming to the Parinod syndrome. So I'll tell you what this Parinod syndrome is. Now look carefully here. You observe the region. This is the midbrain, which I am marking as M. You can see the pineal body here, no? So either when you have a pineal tumor, can even have a stroke also you can have. When there is involvement, suppose I am just talking of a pineal gland tumor, which is again, it's easy to explain. So when you have a pineal gland tumor, okay, you see this is a normal pineal gland, quite small, very small, no problem. But when there is a tumor, what happens is that it actually becomes big, becomes further big. It will go and press on the midbrain. So it will have clinical features. So clinical features will be there corresponding to the midbrain involvement. And in Parinod syndrome, what are the ocular or visual manifestations? Ophthalmological manifestations of Parinod syndrome are very important. Upgaze palsy. Sir, why upgaze, sir? Why not horizontal gaze? Remember, PPRF and everything that looks after your horizontal gaze is, where is it located? PPRF, parapontine reticular formation, located in the pons. So midbrain, upgaze palsy you will have. You will have lid retraction or Collier sign, convergence retraction nystagmus, light near dissociation, convergence dysfunction, square wave jerks, skew deviation. In the main section of the doc tutorials app, I have gone more detail to explain about the individual components also. But for the time being, you understand these are the manifestations of Parinod syndrome. Okay, all right. So that is also clear. These are about the midbrain syndromes. These are about the midbrain syndrome. So if you are asked, sir, but tell me, sir, when it comes to an actual patient, how do you identify that the lesion is in the midbrain? See, localization of midbrain, my single most important clue will be the cranial nerve. If I have a third nerve involvement, do you think this is going to be a pontine lesion? Do you think this is going to be a medulla lesion? Do you think this is going to be a cerebellar lesion? No. So your single most important clue will be your cranial nerve. Otherwise, you will have to look other features also. If you have an ipsilateral third nerve and a contralateral hemiplegia, and you are thinking that the lesion is probably in the medulla, you have absolutely no clue regarding neuroanatomy. Okay, I hope that is clear. Okay, all right. So that's about the midbrain syndromes. Okay, now one another commonly asked question is, when you have an aneurysm involving the posterior communicating artery. See, once the third nerve comes out of the midbrain and goes anteriorly, you just observe in this figure which is that vessel. You see the posterior communicating artery here, which is the vessel that is which is the nerve that is very adjacent to the posterior communicating artery. It is going to be your cranial nerve 3. So when you have a PCOM aneurysm, it is likely to press on the third cranial nerve. Rarely it can press on the fourth, because fourth is also there slightly near, but commonly it is the third one. So PCOM aneurysm, why does it affect? No need to by heart. PCOM aneurysm third nerve, PCOM third nerve. No, it's because neuroanatomically they are adjacent to each other. which is why in a PCOM aneurysm you can have a third nerve involvement. And what word did I use? Third nerve involvement. When I say Weber syndrome, I say fascicle involvement. Okay, all right. So that is also clear. Now Pons. Now are you with me? Now just let me know if you are with me. Like, let's just casually look at the pictures. We don't have time to learn too much neuroanatomy, but remember what I told you. You need not be 100% expert, even 60% expert with some common sense. You know, the basic common sense, like, you know, third nerve is in the midbrain and 5, 6, 7, 8 is in the pons. These are the ones that are required. So I am just looking at a higher section. I am seeing some cranial nerves. I am seeing the mesencephalic root of the trigeminal nerve. I am seeing the medullary velum. Yeah, I am seeing some peduncles here. So I am seeing some trapezoid body. I am seeing the trigeminal nerve. Can I have a lower section here, please? Yes, I am now having a lower section. This is my area of interest. I like this section very much. Okay, just look at this section. Now this section is from where the questions can be asked. You see the abducens nucleus here. Yes. And you see the facial nerve nucleus. You also see the facial nerve fascicle going taking a round turn. So rather than just going anteriorly, it goes slightly posteriorly and then turns back. Unlike the trochlear nerve, which entirely goes back and then turns and comes forward, but facial nerve will go for a bit behind, and then, you know, it winds around the sixth nerve nucleus and then comes forward. Okay, then comes forward. All right. Okay, so you know this is the facial colliculus. All right, now just again once to look at the figure, facial colliculus. So I am seeing the facial colliculus here. I am seeing the abducens nucleus somewhere here, and I am seeing the facial nerve taking this facial nerve fascicle taking this course and coming out of the facial nerve. Okay, all right. So here also I am noticing one fact. The corticospinal tract is located anteriorly. Very, very important. So that means if you have got to have weakness in a pontine stroke, the lesion has to be anterior. You cannot have a posterior pontine lesion with a weakness. Correct? No? All right. Are you all with me? I hope you are all understanding. All right. So, okay. Now look at me. Now look at me. Very important. Remember, this is like a movie. You skip a few slides, you are gone. Okay. So please listen to this. When I'm going to talk a couple of minutes about abducens nucleus, okay. So this is the abducens nucleus. I have already told you, abducens nucleus is slightly a special nucleus. Why is it so special? You can have fibers to the lateral rectus muscle, and also you have certain interneurons, abducens internuclear neurons, which helps it to, you know, via the MLF, it is going to the oculomotor nucleus as well. Okay. Now, you tell me, okay, I'm going to ask you, what is the difference between abducens nerve involvement, I'm talking of the deficit, and abducens nucleus involvement? You tell me what is going to be the difference. Tell me, I'm waiting for you. Okay, Lokesh is telling internuclear ophthalmoplegia. Lokesh, does internuclear ophthalmoplegia occur in case of abducens nucleus involvement? I am expecting who is it? Yeah, very good. Vaika, very good. Vaika, excellent answer. When you have an abducens nerve involvement of the left side, my only defect, whether it be a fascicle or a nerve, okay, abducens fascicle or a nerve, my only defect will be a left lateral rectus palsy, okay, left lateral rectus palsy. But if I have a left abducens nucleus involvement, abducens nucleus by virtue of the interneurons and MLF, it is connected to the third, so it is supplying the medial rectus also, okay, it is supplying the medial rectus. So left abducens nucleus is involved in conjugate gaze. Remember I told you it is involved for gaze. So abducens nuclear involvement will produce gaze palsy. Okay, will produce gaze palsy, which means my gaze to the left, even the right medial rectus also won't be able to act. There will be a gaze palsy. Whereas here it will be an abduction defect alone. It will be an abduction defect alone. It will be an abduction defect alone. All right. Very clear. Now. Let me just teach you the Pontine syndromes. I am going to show you two tables. I want all children to draw these two tables. First of all is regarding the Pontine syndromes involving the sixth nucleus. Okay. And second is the Pontine syndromes involving the sixth nerve. Okay. Sixth nucleus, sixth nerve. Now, first of all, I am going to talk about, rather than all named syndrome, is it, Revie syndrome or Fauville, whatever name you give, please don't by heart these names. It is very unlikely that they are going to ask such names except for some like a Digerin syndrome. Okay, but you first understand, you can learn the names, but understand what is happening. Because ultimately when you learn something, it's not just for your entrance, it's for your life. Okay, so you try to understand what is happening, because just because you know a name doesn't make much difference. Will it make difference in the life of a patient? If you learn medicine, only if it makes difference in the life of somebody else, yes, you should learn for entrance, no doubt. But you think with a viewpoint like this, okay, I have understood conceptually, next time I see a similar case, I would be able to think like this. All right. Okay. Now see, if there is a lesion in the, in the dorsal pons, I am going to start off with the second one. Dorsal medial pons. Okay. Dorsal medial pons. First of all, am I going to get an abducens sixth nerve lesion? That is the first thing I want to know. Okay, you first answer, you fill it for me. Will you be having a dorsal medial pons affection? Will it produce a ipsilateral abduction palsy? That is question number 1. Second is whether there will be an ipsilateral gaze palsy. Next, whether there is a contralateral hemiparesis, and next whether there is ipsilateral seventh nerve. Now see, if the dorsal medial pons is involved, first point I want to tell you is regarding hemiparesis. Why is there no hemiparesis? There is no hemiparesis. You just tell me why there is no hemiparesis in a dorsal medial pontine lesion. Why there is no hemiparesis in a dorsal medial pontine lesion? I'm just trying to test whether you have understood or not. Okay, that's why I'm asking you this question. Tanya, you are absolutely right. Very good. Because the corticospinal tract, you remember, I told you the pontine section, I told you, I was just casually going through this. I told you specifically the corticospinal tracts are all located anteriorly. So, if a patient does not have a contralateral hemiplegia, you can boldly say this is not a ventral pontine lesion, this is a dorsal pontine lesion. Okay. And when it is a dorsal medial pons, I am probably talking of a lesion somewhere here. Dorsal medial pontine. So you tell me, is it going to be the abducens nerve or the abducens nucleus that is going to be affected? Is it going to be the abducens nerve or the abducens nucleus that is going to be affected? So it is the abducens nucleus that is going to be affected, because of which the patient is going to have a ipsilateral gaze palsy. Why ipsilateral? Same side lateral rectus and contralateral medial rectus. Left means left gaze. Will you be having an ipsilateral abduction? Is it a nerve or a fascicular lesion? No, it's not a lateral abduction alone. In fact, the abduction will be affected, but in a true sense, it is a gaze palsy, not an abduction palsy alone. And will you have a seventh nerve palsy? Yes. Why is there a seventh nerve palsy? Because the seventh nerve goes back, winds around the sixth nucleus and comes. So when you have a dorsal medial pontine, you will have ipsilateral seventh nerve palsy. Okay. Now, what if there is a ventral and dorsal medial pons? What did I say? Both the ventral and dorsal medial pons involvement. So, which means this will be true, gaze palsy will be true, because again the abducens nucleus is involved. Sir, when it becomes ventral and dorsal, won't the abducens fascicle also be involved? It will be involved, but see, that will produce abduction. But when the nucleus is involved, gaze will definitely go. Because even in a gaze problem, a pure nuclear lesion also abduction will be affected. But the problem is, gaze per se will be affected. So, if it is a ventral plus dorsal medial pons lesion, which is a Fauvillier syndrome, next time you use this term Fauvillier syndrome, rather than, just remembering the name Fauvillier, I want you to understand what and where is the lesion. Okay. So, you will have a ipsilateral gaze, you will have a seventh nerve, but here you have corticospinal tract. And why is there a corticospinal tract involvement? Because it is a ventrally placed lesion. Okay, so that is these are the pontine syndromes involving sixth nucleus. Okay, I hope you have drawn this table. Okay. How one's gaze can be normal if abducens is normal. Okay. So Lokesh is asking how the gaze can be normal if abduction is normal in nerve palsy. I did not say that. See, nerve palsy means left abduction is gone, no doubt about that. When gaze nucleus is gone, left abduction is also gone. Naturally, it has fibers from the abducens nerve. At the same time, the contralateral medial rectus is also gone. So the gaze per se, when he is asked to look left, abducens fascicle or a nerve means only the abduction will be defective. Okay, but the right medial rectus will be looking here. Abducens nucleus means you will have involvement of the gaze per se. Entire gaze will be actually affected. All right. Okay. So any doubts here? Any doubts here? Tanya, I did not understand your question. Can you just repeat what you are meaning there? Okay, meanwhile, I'll go to this next table, the pontine syndromes involving sixth nerve. Again, draw this table. Localization, ipsilateral abduction palsy, ipsilateral gaze palsy, contralateral hemiparesis, ipsilateral seventh nerve palsy. Okay, just draw this table. Yeah, sixth nerve lesion also can produce, definitely, Tanya. But when it comes to sixth nerve, cranial nerve lesion alone, do you think you will have other manifestations like seventh involvement and all? No. So when it is a brainstem involvement, you will have other coexisting features also. Okay. All right, that is a question. If that is what you meant, can it be a pure nerve lesion somewhere outside? You will not have associated, seventh palsy, no? Other features will not be there. All right. So here, now when it comes to syndromes involving sixth nerve, now when it is a ventral medial pons alone that is involved, ventral medial pons, so it's front medial, so that is called Raymond syndrome. Okay, that is called Raymond syndrome. So when that is being involved, okay, ventral medial, first of all you think whether there is sixth will be involved. Okay, so first of all I'll just show you the picture there. So this is going to be your ventral medial pons. Okay, look at this figure. Ventral medial pons. Okay, ventral medial pons. Now the ventral medial pons means it is ventral, it's forward. So it is not going to affect your nucleus. Nucleus is posterior, no? Dorsal aspect is where the nucleus. So here what will happen is that there is a ventral medial pons. You will have sixth nerve involvement. You will not have gaze palsy, there is no gaze palsy. There is corticospinal tract because it's a ventral lesion. There is no seventh nerve palsy. Why there is no seventh nerve palsy? Because seventh nerve you can see is here. I was talking of a ventral medial lesion. Facial nerve, winds around and goes laterally. You can see the course. It goes like this and comes like this. Okay, all right. So next is regarding Millard-Gubler syndrome when there is ventral medial and lateral pons. Okay, so it is what? Ventral, medial plus lateral pons. So ventral lesion, medial plus lateral pons. So what is the difference? Facial nerve will be affected. So that is called a Millard-Gubler syndrome. Millard-Gubler syndrome. So there you will have, in addition to these features, the same as that, only difference is you will have an ipsilateral 7th palsy. Okay, ipsilateral 7th palsy. Okay, so I hope that is very clear. And similarly, if you have other structures, you can have a brainstem syndrome where your medial longitudinal fasciculus alone is involved. So MLF alone is involved means you can see, in case of what will that produce? It will produce an internuclear ophthalmoplegia. So internuclear ophthalmoplegia. So INO, in case of young individuals, the commonest cause is multiple sclerosis. There is a demyelination involving the MLF. Whereas in case of elderly, it is going to be stroke, that is the commonest cause. Stroke, that is the commonest cause. So you tell me from this figure, which MLF is going to be affected? Now the concepts are very clear. If the right MLF is affected, you tell me which side adduction will be affected. So if this is right, left, the first image is being asked to look to right. In the second image is being asked to look to left, but again you can see there is a adduction deficit. Now if I ask you, so adduction is by medial rectus, no? Why can't this be a cranial nerve 3 involvement? Just let me know. Why is this not a third nerve palsy? Why is this not a third nerve palsy? That's what you have got to tell me. Because medial rectus is supplied by third nerve. I agree that MLF goes and supplies, but why not this is a third nerve palsy? Correct. The patient is not having other features of third nerve. There is no ptosis. There is, isolated medial rectus involvement is very rare. Can very rarely happen, but it is very, very rare. Isolated medial rectus involvement alone is very rare in a third nerve palsy. Okay. And somebody said down and out. See, all cases of third nerve palsy may not have down and out eyes. It is a complete third nerve palsy that can have a down and out eyes. But even partial third nerve palsy also, you cannot have just a medial rectus involvement alone, very rare. Okay, you will have some sort of a ptosis and all. All right. Okay. Now I hope that is very, very clear to you. Okay. Now you just, this is just, we are not learning this, it's just for you to understand. This is the midbrain. Sir, how did you understand this is a midbrain? Midbrain looks like a Bermuda. It looks like a Bermuda. Yes? You agree with me now? Or is it my thought alone? It looks like a Bermuda, no? So midbrain, you see when it comes to the vessel supply, this particular medial aspect is actually supplied by the paramedian branches at the top of the basilar artery. Okay? And when it comes to the next quadrant, you can divide it into various quadrants. This part is supplied by the proximal PCA, okay, and you can have the next part being supplied by the SCA, superior cerebral artery, and the proximal PCA. It's just for you to know, okay, all right, okay, all right, and this is the pons. You can see again the medial aspect being supplied by the basilar artery paramedian branches. And this is the circumferential branches you might have learnt in your anatomy. In fact, in the main section of the app, I have already told you about the long circumferential branches and the short circumferential branches. So you might be familiar with that. Okay, so this is the circumferential branches. And this is again a lower section of the pons. You can see this is the region by the basilar artery paramedian branches. This is the anterior inferior cerebellar artery and the basilar region branches, lower section of pons. Okay, all right. And this is the region of medulla, because now we are going to see the medullary syndromes, the last part of the stroke syndromes. Okay, so this medial part of the medulla is this one, and this one is the lateral part of the medulla. So medial part of the medulla mainly supplied by the vertebral artery and the anterior spinal artery. Lateral part, you have the vertebral artery, you also have the pica also supplying. Yes, pica is a branch of the vertebral artery, that is true. So when it comes to lateral medullary syndrome, you know this is also known as Wallenberg syndrome. Okay, so Wallenberg syndrome or the lateral medullary syndrome. Now here again, let me tell you, there is no need to by heart the clinical features. All you have got to understand is the structures which are located in the lateral medulla. Because when it comes to lateral medullary syndromes, the structures that are involved in the or located in the lateral medulla, they are the ones that are going to be affected. Okay, so correspondingly the laterally located structures are the spinal nucleus of the fifth and the spinal tract, nucleus ambiguous. Okay, you will have the descending sympathetics, which is why you have the ipsilateral Horner syndrome, vestibular nuclei, cerebellar peduncle, spinocerebellar tracts. So these structures which are located in the lateral part of medulla, let me just see if I have a picture here. Yes, you can see the structures. Just have a look at these structures which are located in the lateral part of medulla. You have the spinothalamic tract. You have the spinothalamic tract. You have the spinocerebellar tract, ventral and dorsal. Nucleus ambiguous is there. Descending nucleus of the fifth nerve is there. Nucleus tractus solitarius, vestibular nucleus is there. Descending sympathetic tract is there. Rustiform body is there. Okay, olivocerebellar fibers. So these are located in the lateral part of the medulla. Okay, and what are the structures located in the medial part of medulla? If I may highlight that, you see this is the medial part of the medulla. Okay, so just tell me what are the structures located in the medial part of the medulla. You will have the 12th nerve. Okay, you have the 12th nerve. You have the medial longitudinal fasciculus also, MLF. And you are seeing the beautiful pyramid also medially. Okay, beautiful pyramid also medially. Now you guys tell me, in case of right lateral medullary syndrome, okay, this is a question for all of you. Right lateral medullary syndrome, which side is the weakness? Is it right side or left side? Which side is the weakness? Right lateral medullary syndrome, is it right hemiparesis or left hemiparesis? See, when it comes to medial medullary syndrome and lateral medullary syndrome, I told you specifically the pyramid is actually located in the medial part of the medulla. So when the pyramid is located in the medial part of medulla, you are not going to have any weakness when the lateral medulla is involved. So lateral medullary involvement will produce no weakness. There is no weakness. Okay, so please understand that it is in the lateral medullary syndrome, because they are going to give lot of clinical features in lateral medullary. You can have loss of pain and temperature of the ipsilateral face and contralateral body. In fact, in the main section of the doc tutorials app, I have told you why. Because of time, I am not able to go into the details of the trigeminal supply and the nucleus of trigeminal nerve. So you can refer from the app. Then you will have a decreased ipsilateral corneal reflex, You will have a soft palate weakness, loss of gag reflex, vocal cord palsy, ipsilateral Horner syndrome because of the descending sympathetic involvement, cerebellar ataxia because of the inferior cerebellar peduncle, which is your restiform body being involved, and you can also have lateropulsion. Lateropulsion you need not know at your level. Okay, if anybody is interested, you can message me. I'll tell you what a lateropulsion is. Will not be asked for your exam. Okay, and it is a medial medullary syndrome which is called Dejerin syndrome. Now this again, be careful. Dejerin-Rousey syndrome is the syndrome that is a thalamic stroke. But medial medullary syndrome is also called Dejerin syndrome. It is also called Dejerin syndrome. Okay, it is called Dejerin syndrome. Okay, all right. Now, when the medial part of the medulla is actually involved, okay, when the medial part of the medulla is involved, the 12th nerve nucleus is involved, okay, and also that is you will have, or the fibers, even the nucleus or the fibers. So you will have a ipsilateral 12th nerve palsy and a contralateral hemiparesis. Ipsilateral 12th involvement, contralateral hemiparesis. Why does this contralateral hemiparesis? Because see, corticospinal tract will cross only in the lower portion of the medulla, whereas in lateral medullary syndrome the lesion is at the level of the inferior olive, and because of that, okay, it has further got to travel down to cross to the opposite side, which is why it is a contralateral hemiplegia. Okay, so that is Dejerin syndrome. So that is also clear. Now last couple of words regarding the cerebellar affection. So cerebellum, I told you, is connected to the brainstem by means of the cerebellar peduncle. So you have just look at this particular picture and try to understand conceptually. This is a superior view. This is at a higher level. Sorry, this is a higher level view. This is a lower level. So you see, higher level, you see the superior cerebellar artery supply, anterior inferior cerebellar artery supply, posterior inferior cerebellar artery supply. Okay, very clear. And you see at a lower level means you will not be having the superior cerebellar artery. You are having ICA is there, you are having pica is there. Now I am going to show you some images. You have got to tell me which is the vessel that is being involved. First of all, I am showing the diffusion sequences here. You tell me in this particular patient which is the vessel that is being involved. Now first of all, you look whether the cerebellum is involved from the most higher cuts alone. This is the higher cuts. Okay, this is the higher, and this is actually, because how did I identify this is higher means, see, this is probably the region of the midbrain, because you can see your Bermuda here. Then it actually comes to the region of pons. This is the higher section of pons. Then this is the lower pons. Okay, this is again pons. This is the medulla. So you tell me it is involved from the higher cuts itself or not? Yes, it is involved. So which is the likely vessel? This is likely to be superior cerebellar artery stroke. Superior cerebellar artery stroke. Okay, superior cerebellar artery. And the next one, can you tell me which is the vessel that is being involved? You see here, this is actually the pons that you can see. So you just look at this particular figure. I'll just show you another figure which I showed you earlier also. Now you can look and tell me which is the vessel that is involved. You tell me which is the vessel that is involved. Okay, so the vessel that is involved here, as you can directly correlate with the anatomy image, is the anterior inferior cerebellar artery. Anterior inferior cerebellar artery. Okay, anterior inferior cerebellar artery. Very good, Lokesh, excellent. Good. And what about this? What about this? This is actually the region of the medulla. Okay, slightly might be difficult for you to understand, but this is the medulla. And this is the lateral medullary syndrome, in fact. Okay, This is the lateral medullary syndrome, and it is the pica territory being involved. Because remember, in the exam, if you are asked what is the most common vessel that is involved in lateral medullary syndrome, it is the vertebral artery. Remember, vertebral artery is the most common vessel involved. Okay, most common vessel that is involved. So you can have a pica involvement also. I agree with the fact that pica is also a branch of vertebral artery. Okay, now that ends stroke localization. Okay, so very major topic of today is over, stroke localization. Are you clear with this? Yes or no? Give me a thumbs up if you are clear with stroke localization. We have seen regarding ACS strokes, MCS strokes, PCS strokes, the midbrain strokes, how to localize conceptually. And also one point, if there is an internal carotid artery involvement, it's not like if there is an internal carotid occlusion, what will happen? I'm not talking of MCA, ACA. If you have an internal carotid artery occlusion, what might happen is, one is the patient can have ipsilateral blindness and contralateral hemiplegia. I'm very sure you understood why there is a contralateral weakness, but what is the reason for the ipsilateral blindness? It is because of the involvement of the ophthalmic artery. Because ophthalmic artery is also a branch of the internal carotid artery. Yes, all right. So I hope everyone is clear. Okay, all right. Okay, so I hope you are clear with the stroke localization. Now next we will go on to the stroke management. Okay, so in half an hour we will finish the stroke management, and then we will move on to COVID. Okay, so we are all having dinner, everything tonight. Okay, and even good night also. I am going to tell good night to you because I am going to prolong the session. But please, my request to you is, please don't prolong it. You be with, don't actually keep it for a later date. Just watch it at a stretch. Just keep on writing the notes, but just be at your ease. Just be at your ease and listen to the lecture. Okay, all right. So now I'm going to the treatment of stroke. Now this is very important, which many students have confusion, doubts. First of all, let me tell you, stroke management, acute stroke management is the guideline that you have is the HASA guideline, American Heart Association, American Stroke Association guideline. Now from today onwards, whenever you are going to quote something regarding the management, you have got to quote the HASA guideline. It's not like you are going to say Harrison gave this, or some other textbook gave this, or somebody taught you like this. Always in medicine you have got to quote the guidelines. So please quote the guidelines, and this is the guidelines. The latest guidelines of the HASA came in 2018, but in 2019 there was a revision of the criteria. The screenshot, I have just put that. Okay, so this is the 2000 update to the 2019 update to the 2018 guidelines. So whatever I am going to tell is regarding that. Now, when I am going to tell regarding management of stroke, please children, please be attentive. This is very important because even in INI CT, they asked you a question this time regarding the CT angio. It's just because you did not know how to properly go with the management of stroke, you have got that question wrong. Okay, because I have clearly explained these in my lectures also, how to approach and how to treat a acute stroke. All right, now first of all, I am going to tell you what are the usual scenarios that we do when we are actually doing an emergency duty. So if you are a medicine resident, okay, who is on emergency duty, just suppose you have done your MBBS, you have just gone to, you have taken medicine residency. I'll tell you what happens in the emergency room when you have a patient with an acute stroke. Now when a patient with a stroke presents with an emergency, he comes to the emergency, the first thing that I have to check is it a stroke? Okay, because it might be a patient might be brought with some altered responsiveness, it might be hypoglycemia. So you have got to confirm, is it actually a stroke? You have got to ask acute, is it a history of an acute deficit? You have got to find out, is it a stroke clinically? Okay, is it a stroke clinically? That is the first question. Now the next question you have, once you are quite sure that it is a stroke, okay, next question you have got to ask yourself is he a candidate for revascularization? Is he a candidate for revascularization? Now what do I mean by revascularization candidate? It means that, see, when you have a vessel that is being occluded by a blood clot, what happens is, vessel being occluded by a blood clot, you can treat in different ways. The ideal way of treating is you have got to lyse the clot and revascularize the blood vessel. So, is he a candidate for revascularization means there are two methods of revascularization. You can either go for thrombolysis, okay, you can either go for thrombolysis, or you can go for a mechanical thrombectomy, thrombolysis or a mechanical thrombectomy. Now thrombolysis, mechanical thrombectomy. Thrombolysis means you are injecting a drug and intravenously, and that drug is going to lyse the clot. That is a thrombolysis. Mechanical thrombectomy means you are using an endovascular approach. Okay, you are going inside the vessel, endovascular approach. So in the endovascular approach, you are going, and with the device you are actually taking out the clot, okay, or you are removing the clot. So these are the two revascularization modalities. Now is he a candidate for revascularization? Is that what I have got to know? Now if he is a candidate for revascularization, I have got to do revascularization. So I am going to tell you how to identify that he is a candidate for revascularization or not. First of all, I am going to tell you regarding thrombolysis. Now the patient is in front of me, okay. I have seen that this patient developed a stroke just 2 hours back. Now I have got to understand what is meant by this window period. So in case of an acute stroke, for thrombolysis, the window period is 4.5 hours. The window period is 4.5 hours. Now 4.5 hours is the window period, means from the time of onset of stroke within 4.5 hours. It is not 4.5 hours after bringing the patient to the emergency. It is 4.5 hours within symptom onset. If the patient is brought, you can actually go for a thrombolysis. But remember, if you go for a thrombolysis, suppose this patient was brought at around 4 hours 15 minutes. After your initial evaluation, now it is 5 hours. You cannot thrombolyze. You can thrombolyze only when you are about to give the drug, it is within 4.5 hours. Okay. So the window period for thrombolysis is 4.5 hours. Now a patient has come to me in the emergency, and that patient, it is just 2 hours. He says that, sir, I just had a stroke 2 hours back. So if he had a stroke 2 hours back, as a medicine resident, I would be thinking like, okay, this person is a probable candidate for thrombolysis. Why? Because he came within window period. And for thrombolysis, it is 4.5 hours. Now I will shift this patient to imaging. After, I quickly check the RBS, but it is not like, GRBS I will be checking. It's not like I'll take the GRBS, I'll send and wait for the result to, it should be a spot GRBS. It should not be like I should take some sample, routine blood sample, and then send it to some random lab and I get a result after 1 hour. No, it should be a GRBS that should be measured then and there without wasting any time. You do the GRBS as well as you take a quick ECG. These are the only two investigations that is to be done at an emergency level. Why ECG? Because you might find that this patient is having a atrial fibrillation. You might find that this patient is also having a myocardial infarction. Probably the myocardial infarction would have been the trigger for the stroke. It would have been a cardioembolic stroke. So you just do these two investigations, GRBS and ECG. Not even your platelet count, nothing. You take this investigation and then then what you do is that you shift the patient to the imaging gantry. Okay, so third, I have checked whether, second I have checked whether he is a candidate for revascularization, and if I see that he is a candidate for revascularization, send for imaging. Okay, send for imaging. So I quickly send for imaging. There should not be any delay. There should be a dedicated stroke center in a particular hospital. So I'll send for imaging. Now when I send for imaging, the thing is, suppose, I'm going for an imaging. Please understand that Lokesh is asking if diabetic should we do ABG. No, ABG not to be done in the emergency. Okay. So send for imaging. Now when I go for an imaging, you might ask me, sir, why to do an imaging? That is what you have got to understand. Why are you sending the patient for doing an imaging? First of all, you have, it is not just to see an infarct, and just be convinced that, okay, this is a stroke. Rather than that, it is to rule out stroke mimic. Rule out stroke mimic. So stroke mimic means, sometimes you can have a patient with a CA lung with a brain metastasis. CA lung with a brain metastasis that might present with a hemorrhage, with a weakness. So you might say that, sir, CA lung with brain metastasis, can it present acutely? Well, it can. It can present acutely. So CA lung with brain metastasis is there, okay? Because sometimes it presents in a subacute to chronic manner, but it can very well present acutely. Sometimes it might be a large meningioma, okay, that has produced this weakness. Sometimes it is a subdural hemorrhage that has produced the weakness. So you taking imaging is to rule out, one is to rule out stroke mimic, that is one. Second is rule out intracranial bleed. Rule out intracranial bleed, which means if you have a patient in front of you, sometimes it is very difficult to identify that this is a ischemic stroke or a hemorrhagic stroke. You might tell me, Saurav, I am coming to that. Don't worry, I am coming to that. Now, to rule out intracranial bleed, you might ask me, sir, intracranial bleed means they will be having altered sensorium and all. No? See, not necessarily. A small bleed in the region of internal capsule can exactly mimic like your ischemic stroke. You might have learned in your MBBS days that, bleeding will actually produce altered sensorium. It can produce altered sensorium, but need not always. Need not always. So you have got to rule out intracranial bleed. That is the second thing. Okay. So rule out stroke mimic, rule out intracranial bleed, and also to find out whether patient is a candidate for thrombolysis. How is that? I'll just come to it. Patient is a candidate for thrombolysis. Okay, so whether the patient is a candidate for thrombolysis. Now, these are the reasons why you are taking imaging. Now, next question is, sir, should I go for CT brain or should I go for MRI brain? Because in your exams, you may be asked question, what is the next step in the management? Is it CT, MRI, whatever it is? So please understand that. See, when you go for an MRI, it will always take time. Okay, it will take time. CT means you can take it more quickly. However, there may be certain tertiary care centers who have a dedicated MRI facility for stroke. Just adjacent to their emergency, they have MRI, and there, it is just stroke and stroke alone they are looking after. Because otherwise, if you think you will do MRI, by the time you are going to shift a patient to the MRI, you might find that there is another patient there for which the MRI is ongoing. You cannot just get the patient out of the previous patient out of the MRI gantry. So my point is, usually it is CT that is preferred because MRI will actually cost too much of time. Okay, it is not just because of the cost alone, it will take time. So it is ideally CT brain that is being done. You can go for an MRI if that facility is there and there is no time wastage at all in your facility. Now next point I want you to understand, this is very, very important. This is where the question was asked in INI-CT. See, when you go for a CT brain, what are you trying to visualize? When you go for a plain CT, you are trying to visualize your brain parenchyma. Okay, you are trying to visualize your brain parenchyma. But is that all enough? Is the brain parenchymal visualization all enough? No, it's not alone enough. You have got to visualize vessel also, the vessels also. Because remember, if you have some large vessel occlusion, like if the proximal part of the MCA is involved by a clot, if there is a large vessel occlusion, which we abbreviate as LVO, if there is a large vessel occlusion, thrombolysis may not be that effective and you have got to go for a mechanical thrombectomy. Okay, so the point is, always in your stroke center, when you go for imaging, it should be a CT brain, and followed by that you have got to do a CT angio also. CT angio of the brain and neck vessels. CT angio of the brain and neck vessels, which will help you identify what? Large vessel occlusion, LVO. Okay, so this is important. Now, once you clinically assess the patient, if the patient is within 4.5 hours, okay, and if there is no large vessel occlusion, and if there are no contraindications for thrombolysis, then you can actually go for thrombolysis. Okay, you can go for thrombolysis. So you have got to clinically identify stroke, you have got to rule out stroke mimics, and then you go for a CT brain followed by a CT angio, and you look whether there is large vessel occlusion or not. At the same time, please assess 2 scores. So assessment of 2 scores, which is, what are those 2 scores? Okay, what are those 2 scores? You can go for a NIHSS score, which is a clinical scoring, and also aspect score, which is a radiological scoring. Radiologic scoring. Now, NIHSS score, I have explained it in detail in the doc tutorials app, but here because of want of time I cannot explain too much in detail. So NIHSS score is a score that is ranging from 0 to 42. A higher NIHSS score means patient is having worse, larger stroke, means the sensorium is bad, too much of weakness, so much of neurological deficit. Whereas aspect score is a radiologic score which actually tells you what is the extent of infarct in the imaging. Okay, extent of hypodensity in the imaging is the aspect score. Now, you can go for thrombolysis if the following indications are met. What are the indications? Remember, these are the indications of the American Heart Association, AHA. What are the indications? One is a diagnosis of ischemic stroke with a disabling neurologic deficit regardless of severity. Okay, so there is a ischemic stroke. Will you thrombolyze a patient with a hemorrhagic stroke? No. So with a disabling neurologic deficit, and the symptom onset within 4.5 hours. Why? Because that is the golden period. Now, suppose you are having a wake-up stroke. What do I mean by wake-up stroke? That is, patient has presented to the emergency. So the relatives are saying, doctor, till yesterday 11 p.m. he was perfectly fine. We saw him going to sleep. I also went to sleep. Morning he usually wakes up at around 6 o'clock. By 6 o'clock he was not waking up. I went to the room, knocked the room. He was not opening. Somehow I actually went inside. I find that he was having a stroke. Now what is the issue here? You are not quite sure what time he developed the stroke. It could have been 12 a.m. It could have been 1 a.m., 2 a.m., 4 a.m., 5 a.m. Even just 15 minutes prior, 5:45 a.m. So previously, before 2019, when the revision of the guidelines came, what we did is that we never thrombolyzed patients with a wake-up stroke. Okay, so in such scenario, we did not thrombolyze. But now with various trials, we know that even if it is a wake-up stroke, in such a scenario, you can go for the diffusion flare mismatch. In the main section of the app, I have explained to you what is a diffusion flare mismatch. So here please understand, if there is a diffusion flare mismatch, then that is indicating there is a potential penumbra. What do I mean by that? Remember, when I say that whether a patient is a candidate for a revascularization therapy, I mean that there should be a penumbra. If there is, this is an occlusion here, and this is the dead tissue. Surrounding is the penumbra, that is the tissue at risk. There should be a penumbra, that is the area that should be salvageable. Because only if there is a penumbra, you should go for revascularization. If there is a massive infarct that has occurred, and if there is no possible penumbra, what are you trying to achieve by revascularization? There is nothing that you are going to achieve by revascularization. So my point is, if you have an acute stroke, you are going for revascularization, it means you are trying to save the penumbra. Okay, let me just see if there is any doubt. So if Dev is asking, if the patient has reached 4.5 hours, should he go for CT? Yes, CT and CT angio you should go, okay, but you will not thrombolize. Okay, it is not a waste of time. You want to know what has happened to the patient. Will you just clinically diagnose stroke and just write off? Because you have to see what exactly has happened in this patient. Okay, so let's see the indications. And age more than 18 years. Okay, age more than 18 years. Now please understand that some students ask me, sir, acute stroke the patient presented. I actually went at an imaging and I find that the CT brain is normal CT brain. Should I thrombolize? Patient is having weakness, but the CT is normal, sir. Should I thrombolize? See, please remember, again I reiterate the fact, the reason why you are taking a CT in case of an acute stroke is not to somehow identify the infarct, because stroke is a clinical diagnosis. Okay, so the basic reason is CT would take some time, because sometimes the initial 24 to 48 hours, only at around say 40 to 60% cases will have abnormal CT. It might take some time for the hypodensity to develop in the CT. You might have an obvious hypodensity in these 40% cases, but sometimes it may take time, which is why CT is not a very sensitive investigation for acute ischemic stroke. If you are asked what is the most sensitive investigation, it is diffusion weighted MRI. Okay, it is diffusion weighted MRI. So please understand that. So even if you do not find an infarct, you can very well go ahead with thrombolysis. Now, what are the contraindications for thrombolysis? This is very, very important. This can be asked for your exam. Children, everyone, please be attentive here, because in the exam they may give you a clinical scenario where you are given a contraindication, okay, and they might ask you regarding next step. Okay, so one or the other contraindication may be there. Now you see, severe head trauma within 3 months, ischemic stroke within 3 months, okay, previous intracranial hemorrhage any time in life, intracranial, it need not be intracerebral, even if it is subarachnoid, whatever, any bleed any time in life, suspected SAH, suspected infective endocarditis, suspected aortic dissection. Now you may ask me, sir, suspected infective endocarditis, does that mean that every patient with stroke we should go for echo and then only thrombolize? No, it's not like that. You should thrombolize. Okay, you should thrombolize, because unless there is a high suspicion of infective endocarditis, a patient having fever, murmur like that. A recent intraaxial or intraspinal surgery, that is within 3 months, intracranial intraaxial neoplasm, GI malignancy or GI bleeding within the 21 days. These are all contraindications. Some more contraindications are there. This include active internal bleeding, systolic BP more than 185 or diastolic more than 110, that cannot be lowered safely. So if there is a hypertension is on the higher side, remember, just because the patient has a BP above 185, 110 doesn't mean it is a contraindication. You should give medication and try to bring down the BP, But sometimes there may be a scenario where in spite of your medication, the patient, is actually having a high BP. In such case, it is a contraindication. Bleeding diathesis is a contraindication. INR 1.7 is a contraindication. Sir, does that mean every patient you should go for INR? No. Only if you have a suspicion. Patient was on warfarin and he has taken the anticoagulants. Like that, you can go for the INR. And if he has received heparin within 48 hours with abnormal APTT, that is about your unfractioned heparin, and low molecular heparin within the previous 24 hours, again a contraindication. Platelet less than 1 lakh, current use of direct thrombin inhibitors or factor 10A inhibitors, CT showing acute bleed, and if the CT shows extensive hypodensity, which means you have the aspect score. I have told the aspect score in the main section of the app. So in case of a large stroke, you will have a low aspect score. So which means low aspect score means the penumbra is likely to be less. It means there is an extensive infarct. The penumbra is very less. Here again, there is no purpose of revascularization. These are the contraindications. Okay, remember. Now, this is the table that is given in Harrison. So you might say, sir, I saw the table in Harrison and I found that these are the only contraindications, and I find that recent myocardial infarction is not a contraindication. In fact, this is a contraindication, which means if the patient has had a recent myocardial infarction, you cannot thrombolyze. So why did you not say that point? Let me tell you, this is absolutely wrong now. I do not mean that this is some technical error that happened in Harrison. It is because, Harrison actually, the 20th edition came in around 2018. The guidelines have been revised since then. Please remember, Harrison is a textbook. So if you ask me, sir, okay, I agree Harrison is a textbook, but in the exam, won't the examiner put question from Harrison? See, let me ask you one thing. Who is going to put the medicine questions for your exam? It is going to be somebody with MD medicine and he is practicing. If he is practicing, if he has seen patients with stroke, he should definitely know that it is the latest guidelines that has got to be followed. Recent myocardial infarction is not a contraindication. Take it from me, it's not a contraindication for thrombolysis. So you have got to be updated in medicine, okay? Just because Harrison has this doesn't mean this is the state of art in the stroke management. Please stay updated, okay? Please stay updated. All right, so this is the indication and contraindication. So coming back to the case scenario that we saw, patient was in the emergency. He actually was shifted to the imaging and a CT was taken. Probably there is some infarct, there is no large vessel occlusion, and it's within the window period, and he decides he's going to go for a thrombolysis. So he can go for a thrombolysis. So when he goes for a thrombolysis, please understand what is about the dosing, everything. So I have taken this screenshot exactly from the guidelines, okay? Exactly from the latest guidelines. So you have got to give the dose. Altiplase dose is 0.9 mg per kg, which is given over 1 hour as an infusion, okay? So initially with 10% of the dose as given as a bolus dose over the initial 1 minute. Subsequently it is given as an infusion over the remaining 1 hour. But remember, though it is 0.9 mg per kg, the maximum dose is 90 milligram. Maximum dose is 90 milligram. And you have got to admit the patient. Now suppose you have started thrombolysis. While you are doing thrombolysis, now these steps which I am mentioning now is very important, which can come in your exam as a next step question. While the thrombolysis is going on, because for altiplase infusion, it will take 1 hour, okay? So while the altiplase infusion is going on, if the patient is having severe headache, or he is having worsening neurological deficit, or he is having significant vomiting, now what will you do? Will you continue with the lysis? Answer is no. Why no? Because there is a good chance that this lysis would have caused a hemorrhagic transformation. So it's always important that once you decide to thrombolyze the patient, your duty does not end there. You have got to carefully monitor the patient during thrombolysis. You have got to watch out. Just 1 second, let me just change my camera battery. 1 second, just wait. All right, just let me know if my audio video is perfect. Okay, so one question, just to answer Dev. So Dev is asking, if the patient almost reached exactly at 4.5 hours, should you take a CT? Why can't we thrombolize? Because there is option of thrombolysis. Well, the problem is, without taking a imaging, you cannot go for thrombolysis. Because you can never be 100% this is not a hemorrhagic stroke. I told you, you can have a small bleed which has produced hemiparesis. So what if you don't take the imaging, you don't understand that this is going to be a hemorrhagic stroke, and then what will happen? It will cause further bleed and massive hematoma. So you cannot take that a risk. Okay, all right, okay. If the patient has hemorrhagic stroke and we are worried about 4.5 hours, yeah, correct. Munib Shah, you're absolutely right. All right, so all right, now when you have shifted the patient to the ICU, you have started the thrombolysis is going on. So the nursing staff has helped you in starting the thrombolysis. Will you just go away from the scene? You will not go away from the scene. Remember, it is very important to measure the blood pressure every 15 minutes during an IV and during and after IV alteplase infusion for about the first 2 hours, then every 30 minutes for the next 6 hours, and then hourly until the 24-hour period. Now, can you tell me why such strict monitoring of BP? You see the initial part, they are looking at every 15 minutes, then every 30 minutes, and then for the remaining time, they are looking hourly. Can you tell me why they are doing such stringent monitoring? The reason is because if you do not monitor this, if the blood pressure goes high and if thrombolysis is going on, or even if thrombolysis has finished, see, when you thrombolize, there will be lysis of this clot, no? So there, the vessel will be a bit fragile. So if the BP is high, when the blood is going at high pressure, that will cause hemorrhagic transformation. So it is very important to control the BP, and that is why the BP has to be controlled. Now children, please understand all this. You have to understand, because in the exam they will ask you what is the next step. Okay, because even you saw in this INI CT also, there was a good number of weightage towards neurology questions also. Okay, so it's very, very important. Now if the BP measurements is actually very high, okay, if the patient is having high BP measure, you can go for 10 minutes or even 5 minutes BP monitoring. Don't think that patient comes with high BP. Okay, as per the guideline it says only 15 minutes, so I'll monitor only 15 minutes. No, if the BP is on the higher side, if you feel like, you can monitor further frequently also. Okay, all right. Now once you have done the thrombolysis, okay, suppose I have thrombolized the patient. After 24 hours, that is 24 hours after thrombolysis, I will take a repeat CT. That is the guideline. 24 hours after thrombolysis. Thrombolysis will be over in 1 hour, but 24 hours later you have got to take a repeat CT. Why are you taking a repeat CT? Because what is the danger with thrombolysis? There is a chance of hemorrhagic transformation of infarct. So one clinical question that can come for your exam is, if during thrombolysis the patient is having headache, deficit, then there is no point waiting for 24 hours to take the CT, take it then and there. Suppose thrombolysis is over, after 3 hours there is again worsening of deficit, headache, vomiting, then also don't wait for this 24 hours. But uneventful thrombolysis, nothing bad has happened, then what happens is that after 24 hours you can actually go for a repeat CT, and repeat CT you are taking to look for hemorrhagic transformation. Okay, so that's what you will do. Now if you ask me, sir, what about antiplatelet? When I give thrombolysis, do I give antiplatelet then? No, you will not give, because you will start the antiplatelet only after the 24-hour repeat CT. Sir, why sir? Why I should wait for 24-hour repeat CT? Aspirin is a good drug that will prevent the further stroke. Because please, first of all, remember, you giving aspirin in acute stroke is not for acute management. Aspirin is not a revascularization therapy. Aspirin is not going to lyse the clot. Aspirin is only for secondary prophylaxis. That is, aspirin is only to prevent a further stroke from happening. Okay, so please understand that. So you will start only 24 hours after a CT. But you can start aspirin straight away if the patient presented out of the window period. If the patient presented out of the window period, you are not thrombolizing, no? Then you can actually go for aspirin. But as Kaustubh rightly said, only after ruling out bleed in the 24-hour CT, you can go for antiplatelet. Okay, that is quite clear. Now in the exam, they might ask you, patient was started on acute on alteplase and the patient developed bleed. Okay, there was some headache, vomiting. So you took a repeat CT and you find that, it's a mess, it's a bleed. So what will you do? This is very important. Again, screenshot from the guideline. They will ask you what is the next step. First, first and foremost, stop the alteplase infusion. Then you send the blood samples for CBC, PTINR, APTT, fibrinogen levels. Then you go for an emergency non-contrast CT, okay, repeat CT, because you are suspecting bleeding. Okay, I am talking of suspecting bleeding. And if there is a bleed is there, you will give the patient cryoprecipitate. Okay, you will give the patient cryoprecipitate, tranexamic acid. Okay, you can give the patient, and also supportive therapy, like you might have a patient might be having features of raised intracranial tension. You might have to give the patient a 30-degree propped up position. You will have to hyperventilate the patient, maybe mannitol, hypertonic saline. You've got to reduce the intracranial tension. Okay, and if the sensorium worsens, you might also have got to intubate. But the most important point is actually stopping the infusion and starting cryoprecipitate as well as tranexamic acid. Very, very important. All right. Okay. Now another possible potential question is, if you are thrombolizing the patient and the patient develops orolingual angioedema, how will you manage? Okay. Let me see if there is any doubt there. Okay, so Varun is asking, suppose if I have thrombolized the patient, after 24 hours the patient is stable, there is no signs of intracranial hemorrhage, why do CT? I'll tell you. Even if the patient is completely stable, you might have a scenario where the repeat CT contains multiple spots of bleeding. Okay, the patient might not have, don't think that all bleeds will be very much symptomatic. Small bleeds you can see, or a hemorrhagic transformation even, without much worsening of symptoms and patient not having headache. If you do not take a CT and simply start antiplatelet there, what will the antiplatelet cause? It will cause further bleeding. Okay, so in such a case, you will have to hold the antiplatelet. I hope Varun Kamath, your doubt is clear. Okay, so orolingual angioedema in case of the IV alteplase. So what we will do is that you will discontinue the IV alteplase. You will administer the patient with IV methylprednisolone, diphenhydramine. Okay, you will administer ranitidine, important. And if there is a further increase in angioedema, you can even administer epinephrine subcutaneously. And they might ask you what is the selective bradykinin receptor antagonist which is used, which is icatibant. It is not much commonly available, but you might get this as a question, icatibant. Okay, that is how you will manage orolingual angioedema. Okay, so I hope you are very clear with the indications for thrombolysis, contraindications for thrombolysis, okay, and how you will actually manage a patient during thrombolysis. Okay, now just just one more point I want to tell you is that when you are actually thrombolizing, suppose you have brought the patient from the imaging gantry back to the ICU for thrombolizing. If you have high blood pressure, because in the exam they might give you a clinical scenario where a patient is presenting within the window period. So patient presents within window period and the blood pressure is high. It is just 2 hours now. BP is maybe 220, 130. They may ask you what is the next step. First option might be withhold thrombolysis, not to do thrombolysis. You can abandon thrombolysis. Next option will be control the hypertension. Answer is controlling the hypertension. If the patient is in window period, please try to control the hypertension by agents like labetalol, nicardipine. Okay, you can go for agents to control, which is very important. So the detail of the blood pressure control, what agent, what dose, I have explained in the main section of the app in doc tutorials. Okay, alright, so you can go back and listen to that. Now, the next question is, we have studied in detail A to Z about thrombolysis. Now the next question is, I have taken a CT brain plus CT angio and I get this particular image. This is CT angio. Okay, which means why is an angio taken? There is vessel involvement, to find out the vessel involvement. Now I am going to show you this particular picture. Let me see who is smart enough to pick what is the abnormality here. I'll just wait for a couple of minutes to find what is the abnormality here. Okay, nobody is answering. Okay. Yeah, Manish, excellent. Left side is the problem. I agree with you. Good, Manish. Which vessel can you tell me? See, this one is the MCA, middle cerebral artery. Okay, middle cerebral artery is going like this. This is also middle cerebral artery. See, right side MCA I can trace very well. I am able to see it very well. Okay, right side middle cerebral. But when it comes to the left side, you can see that there is some sort of a cut off, no? It comes like this, but then, here it is gone. So this is a proximal MCA occlusion. You remember what we learned in the clinical features? We have beautifully learned, we conceptually understood about the proximal MCA occlusion. So this is actually a proximal MCA occlusion. Okay, this is a proximal MCA occlusion. This is a proximal MCA occlusion. Okay, alright, this is a proximal MCA occlusion. Now the issue is, if the MCA is occluded proximally, see, if you ask me, sir, if the MCA is occluded proximally, the patient is having stroke, patient is within window period, so everything is fine, no? So what is the issue here? There is one issue. Proximal occlusions means the vessel caliber will be slightly larger, no, compared to distal. So proximal occlusion means the clot will be large. So if you give a thrombolytic agent, it will not easily dissolve. So the issue here is proximal occlusions poorly respond to thrombolytic therapy. Sir, does that mean that you will not thrombolyze a patient who is having a proximal occlusion? No. Even if if the patient is having a proximal occlusion, if he is in the window period, you should definitely thrombolyze, because some sort of dissolution may be there, though it might be difficult. But the issue here is, if you find out there is a large vessel occlusion, there is another revascularization modality that you can do. That is mechanical thrombectomy. Mechanical thrombectomy. Mechanical thrombectomy. Now, mechanical thrombectomy means, I told you, by the endovascular approach, you are trying to remove the clot, okay, the blood clot. So I'll just show you a diagrammatic representation. Everyone please be with me. You see, there is a particular device, you have these retriever devices. Okay, you have the clot retriever device. You can see there are different types of retriever device. Even now you have aspiration device. All these devices I have explained in the main section of the app. So solitaire device, you are seeing that this is going to a clot, and this is where the clot is. So the device is grasping and disrupting the clot. Okay, the device is grasping and disrupting the clot, and then it retrieves the clot. It actually pulls out the clot. Okay, so this is actually called a solitaire retrieval device. Okay, clot retrieval. So did you understand why did I have to go for a retrieval? Because the clot is very large, so that I don't expect that by means of a thrombolysis alone he might improve. So that is called mechanical thrombectomy. Next you might ask me, before that I'll just show you a picture. Just see, this is an actual mechanical thrombectomy. This is the device, solitaire device. And whatever I am highlighting now, these are the clots that have been removed from the vessel. Okay, this is how the endovascular route you actually remove the clot. Okay, it's very clear, no? All right, so you remove this clot. All right, now you might ask me, so just like the window period for thrombolysis, is there any window period for mechanical thrombectomy? So when you generally say window period for stroke, you generally mean window period for thrombolysis. But similarly, you have a window period for mechanical thrombectomy as well. Now, till a couple of years back, the window period was 6 hours, which means any patient with a stroke within 6 hours having a large vessel occlusion, you can go for mechanical thrombectomy. But remember, all patients within 6 hours, you cannot just do a mechanical thrombectomy, only if there is a large vessel occlusion. So till a couple of years back, it was 6 hours. But now it is understood that even in the 6 to 24 hour period also, 6 to 24 hours after the onset of symptoms, even in that period also, you can go for a 6 to 24 hour period also, you can go for a mechanical thrombectomy in certain scenarios, only and only if you have a facility of CT perfusion and MR perfusion in your hospital setting. So if you have a facility of CT perfusion or MR perfusion, and by the CT perfusion or MR perfusion you are able to demonstrate penumbra, even in the 6 to 24 hour period also you can go for a mechanical thrombectomy. Okay, but if you are in a center where you have only you do not have the CT perfusion facility, you can only do mechanical thrombectomy up to 6 hours. If you are in a facility where you do not have the facility for mechanical thrombectomy, you can only do thrombolysis. If you are in a facility where you do not thrombolyze, you cannot revascularize the patient. This is not an excellent center. Okay, any tertiary care center should be equipped with a stroke unit. Okay, otherwise it is a fault. Okay, now next question is Kaustubh is asking, give CPR thinking that it might cause rib fracture. You might think that okay, this is likely to cause rib fracture, so I should not give CPR. No, so it's always a risk versus benefit. So there is a slight chance of reperfusion injury, but you should always go for risk versus benefit. Okay, now the question is, Lokesh is asking, is the thrombectomy done by neurologist or neurosurgeon? Well, thrombectomy is usually done by interventional radiologist. Okay, interventional radiologist. But please understand that nowadays even neurologists are also taking fellowships in interventional radiology and doing mechanical thrombectomy. Okay, so as of now, majority of the places it is done by interventional radiologist, but please understand that even neurologists can also do. All right. Okay. Now just to ask you, I think there is some video getting stuck. Just let me know if my voice is breaking or is it just that the video is getting stuck. It's probably the net issue, but I just want to know if my voice is very clear. It's okay even if the video is breaking, but voice is clear or not. Just let me know in the chat box. Yeah, video is okay. I just want to know my audio is okay or not. Yeah, if it's video, it's okay. Okay. All right. Voice enough. You can just watch some slow motion in the video. That is perfectly fine. I don't mind. So all I want is my voice to be perfect here. All right, dear children. So let's move ahead. So I hope you understood what is this mechanical thrombectomy, and I'll just tell you what, just like you learned the indications and contraindications of thrombolysis, you have got to know what are the indications for mechanical thrombectomy in a systematic manner. Now, one important point is there should not be important previous disability, that is a pre-stroke MRS score, that is your modified Rankin score 0 to 1. I'll just tell you what it is, don't worry. See, let me ask you a simple question first of all. If the patient had a previous stroke and he is having grade 0 power already, or maybe grade 2 power or so, grade 2 power, and he develops another stroke, already he is bedridden, he develops another stroke, do you think mechanical thrombectomy will be ideal in this patient? Answer is no. Why is it not ideal? Is because when you do a mechanical thrombectomy in such a patient, what are you trying to achieve? You are trying to save the penumbra. But when you go for a patient who has already had a significant stroke, do you think there will be a good penumbra? No. So MRS means modified Rankin score. It is basically a score of disability ranging from 0 to 6. 6 is actually death, but it's otherwise 0 to 5. Just on the disability, 5 means it is significant disability where the patient is bedridden and incontinent and is constantly requiring nursing attention. So to go for a mechanical thrombectomy, the MRS will be 0 to 1. That is, either the patient should have previously had no symptoms or no significant disability. Okay. But once the patient is having disability, is requiring already somebody to walk by means of a previous stroke, in that case, you will not be able, if there is a significant stroke, you will not go for a mechanical thrombectomy. Okay. Now, occlusion of the internal carotid artery or MCA segment 1, that is, it has got to be a proximal segment. If it is a M4 segment or M3 segment or even M2 segment, some scenarios you might do M2, but majorly M2 segment you will not do. So it's mainly with respect to the M1 segment. Okay, that's the importance of learning your M1, M2, M3, M4. Age has to be more than 18, NIHS score more than or equal to 6, then the aspect score more than or equal to 6. I have already explained aspect score, in the app. If anybody is having doubts with aspects, if you have not watched my lectures, you can inbox me, I'll be happy to help you. All right. So in between, my laptop is getting some notifications, my kids' online class is going on. So on the other room, my kids' class is going on. My son is learning. These online classes, even it does not spare all these LKG children. My son is in LKG. So, even for me, to stay attentive for half an hour in a class is very difficult. For him also, I just wonder, how he's able to sit continuously. Okay. All right. So now is the era of all these online classes. All right. So let's try to leave with that. All right. So, okay. So finally, you understood what are the indications for a mechanical thrombectomy. Yes, you understood what are the indications for a mechanical thrombectomy. Now, revascularization modalities is perfect for you now. Now, what if the patient is presenting outside the window period? So, if the patient is presenting outside window period, now then what will you do? You will give antiplatelet. You will give the patient antiplatelet. So, you can give the patient a 325 milligram loading dose of aspirin. But here again, you have got to check the CT also. And after that, you can put the patient on aspirin 150 milligram. But remember, this thrombolysis also, once you are done with the thrombolysis, after the 24 hours, you can put the patient on aspirin 150 milligram. Okay, aspirin 150 milligram. Only thing is that you will not give the loading dose in the other case. Outside window period, you can give the patient as 325 loading dose followed by aspirin. But remember, it is a single antiplatelet. It's not dual antiplatelet for stroke, except in the TIA. I'll come to that. So you're going for single antiplatelet, and you will also go for statins, BP control, diabetic control, all are very, very important. So that is, antiplatelet. Whereas when it comes to TIA, transient ischemic attack, so here what you will do is that, yes, you will go for antiplatelet loading dose, but when you go for antiplatelet as loading dose for TIA, you will go for loading of both aspirin 325, some guidelines say you can go for 300, plus clopidogrel 300 milligram. So you are loading with both antiplatelets, okay, and then what you will do is that you will go for maintenance dose with aspirin 150 milligram to continue, 150 you will continue, whereas clopidogrel you will give the patient 75 milligram clopidogrel for 3 weeks. For 3 weeks, okay, and then stop clopidogrel and continue aspirin. So the difference is, if it is a TIA, but I'll just add something here, or minor stroke. What do I mean by minor stroke? The NIHSS is less than or equal to 3, okay, a minor stroke. In those two scenarios, TIA or NIHSS less than or equal to 3, you will go for a dual antiplatelet loading, followed by first 3 weeks you will go for dual antiplatelet, both aspirin and clopidogrel. Beyond 3 weeks you will only go for aspirin. Okay, very, very clear. Alright, so that is also clear. Now, some students might ask me, sir, if you said it is single antiplatelet that is being given for stroke, any other indication for dual antiplatelet in stroke? One indication is TIA and minor stroke. The other indication is, if the patient is having a symptomatic intracranial disease, intracranial vessel disease. Now what do I mean by that? When the imaging was taken, there is some vessel involvement, like there was some stenosis involving the MCA or ACA, so some vascular stenosis intracranially. In that case also, symptomatic intracranial vessel disease, as well as in extracranial unstable plaques, I'll tell you, extracranial unstable plaques. So how do you identify an extracranial unstable plaque? What is this extracranial unstable plaque? Which means in your carotid artery there might be some plaque. Usual plaque is not an indication for dual antiplatelet, but unstable plaque, how do you identify it is an unstable plaque? You will do a neck vessel Doppler. You will do a neck vessel Doppler. So once you do a neck vessel Doppler and you find that it is an extracranial unstable plaque, dual antiplatelets. If it is a symptomatic intracranial vessel, also dual antiplatelets. Okay, symptomatic intracranial vessel also, it is going to be dual antiplatelets. So how long you will give the dual antiplatelets in this case? In this case, you will give the dual antiplatelet for 3 months. Okay, dual antiplatelets you will give for 3 months. Very, very important. Clear? Alright, so that is also clear. Now, next, what if this is a cardioembolic stroke? In that case, you will have to go for anticoagulation. But remember, even if it is a cardioembolic stroke, acute management, if the patient is having an atrial fibrillation, because one student a couple of days back sent me a doubt in my WhatsApp, like, sir, the patient is having an atrial fibrillation and a stroke, patient presents with stroke, what is the first step? One option was thrombolysis, second is anticoagulation. Please understand, even if it is embolic stroke, cardioembolic stroke, first of all, you will have to do revascularization, whether it be thrombolysis or mechanical thrombectomy. Okay, so that is very clear. You have got to anticoagulate the patient. Okay, so I hope you understood when to thrombolyze, when to do mechanical thrombectomy, what about antiplatelets, when to go for single antiplatelet, when to go for double antiplatelets, these indications, and when to go for anticoagulation. Okay, so let me see if anybody is having a doubt. Munib, I did not understand your question. We are still going to manage anyway despite prognosis. I did not understand. Kaustubh, you are saying site of stroke syndrome determines the prognosis. Okay. See, I'll tell you in simple language. Which is the larger compartment, posterior fossa or the, your anterior cranial fossa and middle cranial fossa? The posterior fossa is a very small compartment. So when you have a stroke involving your posterior fossa, especially your cerebellum, see, you do not have space to expand. Okay. So posterior fossa strokes, they are likely to, especially if it is cerebellum, they are having a slight poor prognosis. But again, I cannot dogmatically say, because even a proximal MCA stroke will have a very poor prognosis. Sometimes you might be given, in fact, a few years back in AIMS, they gave a scenario of a patient with a massive MCA stroke, large MCA stroke. So patient was having all sorts of raised ICT features, altered sensorium, and his sensorium was dipping. And the question was, what is the management? You tell me what is going to be the management in case of a malignant MCA stroke. Large MCA stroke, and the patient's consciousness is actually coming down. Malignant MCA territory stroke. What is going to be the management? Because you might not actually have with a mannitol alone, that might not reduce your intracranial tension alone. You will have to go for a decompressive craniectomy. Decompressive craniectomy. So what is this decompressive craniectomy? Decompressive craniectomy means, I told you brain is a compartment which cannot expand. You have a rigid skull. So if you have a left MCA infarct, you will remove this portion of a skull, which actually slightly eases the tension of your brain, allows it to slightly expand. And then this skull part you might keep somewhere else, okay, on your abdomen or so, subcutaneously. And then, you might actually at a later point, once a patient improves in a few months, you can actually go for, you can keep it back in the scalp. So this is called a decompression craniectomy, which is done in case of a malignant MCA stroke. You might get a clinical scenario. In fact, it has been asked once also, a large MCA stroke, and they are asking you what is the management. So that is going to be a decompressive craniectomy. So cardioembolic stroke, NOAC. So see, you can go, I'll tell you, when you go for anticoagulation, you can go for warfarin as well as NOACs also. So that certain scenarios, warfarin has advantage, certain scenarios NOAC has advantage. Suppose, if it is a patient with a prosthetic valve, prosthetic valve, it has got to be warfarin. You can give only warfarin. Similarly, if the patient is having chronic kidney disease, you can give only warfarin. In other scenarios, you can give for NOACs as well, like your apixaban, dabigatran. In fact, I just have a table, if you want to just take a screenshot also of the various anticoagulants and the dosing also, which is again can be asked in your exams as well. This is very, very important. Even they might ask you regarding the antidotes as well. Okay, I'm sure you would have learned this in your pharmacology lessons. What are the antidotes for this dabigatran? And dabigatran is a direct thrombin inhibitor. And what is the antidote for apixaban, edoxaban? Can you just tell me what is the antidote? Idarucizumab and andexanet alpha. Okay. So idarucizumab okay, and andexanet alpha. So idarucizumab is for what? Idarucizumab is for dabigatran, and for the remaining you can go for andexanet alpha. Okay, the remaining you can go for andexanet alpha. All right. Okay. Let me check if there are any doubts. Varun Kamath, what is the use of learning stroke syndromes when the treatment is going to be safe? Well, see, I'll tell you, as a clinician, I'll tell you this. See, first of all, you have got to localize a stroke, where it is, Because you can say that, sir, why we are localizing, you go for a CT, MRI. See, don't think that all over India, you will have facility for a MRI everywhere. And even CT also, I told you, initial 24 to 48 hours, CT can be normal. So at that time, you just simply, if you say, this is some stroke, I do not know where it is, but some stroke somewhere, you have got to clinically localize this. Even brainstem stroke also, CT, sometimes it might appear very much normal. Because brainstem especially, I'm sure you would have learned in your radiology as well, CT is sometimes difficult to appreciate the infarct. It can be appreciable, but sometimes it's difficult. So the point is, you have got to localize to, understand where the stroke is. Okay, all right. So that is also very, very clear. So, and one last point in the management of stroke, suppose you have your carotid artery which is having a big plaque. Okay, so you are managing the stroke. Do you think this is all enough? The plaque is still there, no? You will have to manage, no? So there are two options. One is you can go for a carotid artery stenting. Carotid artery stenting if there is a carotid plaque. Now remember, this is not a revascularization. This is again a secondary prophylaxis to prevent a further stroke. You can go for a carotid artery stenting. You can see the balloon that is inflated, and you can go for the stent, or you can go for an open procedure like a carotid endarterectomy, where it is an open procedure and you are actually removing the plaque. Okay, this is called carotid endarterectomy. So by this, we finish the stroke localization and stroke management. If there is any other doubt that you have, I will be, towards the end, I will be sharing my phone number. Please feel free to ask. But I think, in this quick revision program, I have been able to give you an overview on the stroke management, because even in the INI CT exam, I could see some students not even understanding why the CT angio is being taken. Okay, so many got that question wrong regarding the CT angio, but I hope you have got a 360-degree coverage on the stroke localization from a clinical point of view as well as treatment point of view. And so in just another 5 minutes, I am going to start the next topic, COVID-19 management. Okay, so 5 minutes is for you to have your dinner and for me to have a coffee. Okay, so 5 minutes only, we are going to start with COVID. Please remember that this topic is going to fetch you marks for your exam. What I am going to talk about next in COVID, remember, I am going to talk about management of COVID-19. Okay, I am going to talk about management of COVID-19. I am going to explain to you. So this you can expect question not only from the medicine part, from the pharmacology part also, and even the anesthesia questions, some of them I will be discussing. Even the pathology also briefly I will be touching. So in 5 minutes we are going to start COVID-19. Please just share this link with your friends as well, in your batch groups as well, because COVID-19 is very important. Just share it in other groups saying that we are just about to start COVID-19. Very, very important. I'll just start in 5 minutes. In 5 minutes break, we are going to start COVID-19. Okay, 5 minutes. COVID-19, take a quick break. We are going to start with COVID-19. Okay. Yeah, in 5 minutes. Okay, so is the audio video fine? Just let me know if my audio video everything is fine. Okay, all right. So we are going to start with the management of COVID-19. Okay, so let's start without wasting any time. First of all, please basically understand that a few words regarding the pathogenesis of COVID-19. Why do you have to understand this? Because when we come to the management of COVID-19, to understand regarding the how the various drugs act, you have got to have a basic idea regarding the pathogenesis. So, see, in case of COVID-19, what you are seeing is that, are you able to see my slide? 1 second. Yes. All right. So, see, in case of COVID-19, you have all these spike glycoproteins. Okay, you see all these spike glycoproteins, and you know that this is a single-stranded RNA virus. So, this spike protein, okay, the spike protein will go and bind with the AC receptor, ACE2 receptor, that is your angiotensin converting enzyme 2 receptor. So when the spike protein goes and binds with the receptor, that is when this receptor binding will cause the internalization of the virus. So this ACE2 receptor is present in different sites. Okay, naturally, this is why COVID-19 is a multi-system disease. So you have this receptor present in the nasal epithelium, type 2 pneumocytes, endothelium, blood-brain barrier, myocardium, intestine, hepatocyte, kidney. So in all these regions, you will have the ACE2 receptor. And that is responsible for COVID-19 being a multi-system disease. Clear? Okay. All right. I want you to write the notes also quickly. All right. Be with me. Now this spike protein, I told you, binds to ACE2. But in addition to the ACE2 receptor, it also requires a very important co-receptor. That is, spike protein binds to ACE2. In addition to the ACE2, it requires a co-receptor which is called TMPRSS2. Okay, so TMPRSS2 is an important co-receptor which is again required for the action. Okay, that virus, the protein binding to the ACE2, this TMPRSS2 is very important for activating the spike protein, and also it enhances the binding of the spike protein to the ACE2 receptor. So it has a very important function to play in COVID-19 pathogenesis. Now subsequently to this, after this spike protein binding to the ACE2 and the function of the co-receptor, what subsequently happens is an internalization of the virus. So the virus actually gets inside, the viral endocytosis is there. And I told you this is a single-stranded RNA, then it sheds off its genetic material and subsequently it uses the machinery of the cell, of the host cell. So it uses the host cell machinery and subsequently there occurs a viral replication. And this viral replication can result in release of this virions. So you see here, this is the S protein, ACE2 receptor, TMPR SS2, endocytosis of virus, subsequent shedding of its material, using the host cell machinery, replicating and releasing the virions. So I hope till this part is very clear. Okay. Now we go on to the pulmonary involvement. So you know that lung involvement is very common in COVID-19. So the virus basically binds to the ACE2 receptor. I told you the type 2 pneumocytes are having the ACE2 receptor. So the virus goes and bites to the ACE2 receptor in the type 2 pneumocytes. Subsequently, viral replication and release of virions. And when there is a viral replication happening, this will also activate the immune system. So when the immune system is activated, there is activation of lymphocytes, neutrophils, monocytes and macrophages, and that results in the release of various inflammatory cytokines like TNF alpha, interleukin 1 and interleukin 6. All these cytokines are released, okay, and these cytokines will be responsible for a part of the manifestation. Even it can result in cytokine storm also. Now coming to the pulmonary involvement itself, I told you the type 2 pneumocytes are having ACE2 receptor, but it's not just the type 2 pneumocytes, even the capillary endothelium is also having the ACE2 receptor. Now what is the importance of the capillary endothelium also having the ACE2 receptor? Because you can have in comparison to the other viral pneumonias like H1N1 pneumonia, this COVID-19 can involve endothelium and cause endothelitis. That can actually predispose to a thrombotic state also. Okay, so this endothelitis can predispose to a prothrombotic state. So COVID-19 is a prothrombotic state. At least many of you would have seen maybe someone developing these coronary events, cerebrovascular events, venous thrombosis, all secondary to COVID-19, and the reason is because it is a prothrombotic state. All right. Okay. Now, when it actually involves the lung, we are just sticking on to the lung involvement here. So, in the early stages, the SARS-CoV-2, so it is acting on the type 2 pneumocytes, okay, and it is involving the capillary endothelium as well. So, when the disease progresses, okay, in case of severe disease, just have a comparison with the early stage with the late stage of the disease. What happens is that you can see there is activation of all these inflammatory cells like lymphocytes, monocytes, macrophages, neutrophils, and also there is hyaline membrane formation, there is fibrosis, and these cytokines which we talked about earlier can result in cytokine storm. In addition to that, the endothelium is actually involved, so there is endothelitis. Now this is a very, very important term. Endothelitis can occur in COVID-19, okay? Alright, so this can lead on to thrombotic complications. Now, what can happen is that in the initial stages of COVID-19, when the patient is having interstitial edema and thickening, okay, that is the initial stages, you can have some sort of an interstitial edema and thickening. So in that stage, the patient will have dry cough only, okay. You might have seen many COVID patients having dry cough. So because there is the interstitial involvement is there, such patients are less likely to have any resting desaturation. So normally at rest, they will not be having a resting desaturation, but probably when they are used to a 6-minute walk test, when they are asked to do a 6-minute walk test, that can precipitate breathlessness, but otherwise no resting desaturation. So when does resting desaturation occur in COVID-19? Well, in the late stages, when you have these alveolar exudation happening, so the alveoli getting filled with exudates, you have this pneumonia developing. In such a scenario, here again you see a comparison between the alveoli in the normal state versus the disease state. You can see normal state, the type 2 pneumocytes, but again these pneumocytes getting distorted, the inflammatory cells and cytokine release, okay, cytokine storm, alveolar flooding, there is a capillary endothelium being affected resulting in vascular leakage, there is prothrombotic state. Okay, so this is what actually happens. But when the patient develops alveolar flooding, what happens is that there is resting desaturation. Okay, so I hope that is very, very clear. Okay, all right. So this part is actually clear. Now, in addition to the pulmonary involvement that I was talking to you about, COVID-19 has lots of extra pulmonary involvement as well. So it can have involvement in the neurologic system, in the renal, hepatic, GI, thromboembolism, cardiac, endocrine and dermatological. So like thromboembolism, we have already said, you can have DVT, pulmonary embolism and all these thrombotic events, even cardiac events also, like a cardiomyopathy, myocardial infarction, cardiogenic shock, okay, acute cor pulmonale, endocrine problems like hyperglycemia and diabetic ketoacidosis. Now this is again very important because what we have seen is that diabetic control is often very difficult in cases of patients with COVID-19. What is the reason? Yes, per se COVID-19 also can result in reduction of your insulin secretion. That itself can cause a hyperglycemia. And yes, you can have dermatological consequences like petechiae, libido reticularis, urticarias, lupus pernio-like lesions. Neurological affections like stroke, GBS, encephalopathies, even some cranial nerve palsies, renal involvement like AKI, you can have patients with proteinuria, hematuria, hepatic involvement like your raised transaminases, bilirubin being raised, GI involvement like diarrhea, nausea, vomiting, anorexia. So let me reiterate the fact that because of this distribution of ACE2 receptor, COVID-19 is a multi-system disease. Okay, I hope you have written this down. Yes. All right. Now, next, very, very important, you have got to know regarding certain terminologies of the NICE guidelines. Okay, so they might ask you something regarding acute COVID-19. What is the definition? Ongoing symptomatic COVID-19 and very, very importantly, what is a post-COVID syndrome? These definitions are actually very important. When you say acute COVID-19, which means signs and symptoms of COVID-19 up to 4 weeks. Again, let me reiterate the fact that acute COVID-19 doesn't mean the date when your RT-PCR becomes negative or a RAT becomes negative. It is when the patient, has signs and symptoms up to 4 weeks, that period is actually acute COVID-19. But if you have signs and symptoms for 4 to 12 weeks, that is 1 to 3 months, you call it ongoing symptomatic COVID-19. Okay. And what is this post-COVID syndrome? That is the signs and symptoms that develop during or after an infection consistent with COVID-19 continuing for more than 12 weeks. So you see this time differentiation, 4 weeks, 4 to 12 weeks and more than 12 weeks and are not explained by alternative diagnosis. That is what is called a post-COVID syndrome. Okay, all right. Now coming to the spectrum of disease manifestations in COVID-19, see 85% of the individuals, okay, will have an asymptomatic or mild disease. Okay, so this is the international data and 15% will have moderate to severe disease and the ones with moderate to severe disease are the ones that require hospital admission and out of this 15%, 5% will require critical care management in the ICU. But the Indian data is such that it's almost 3% of the individuals who require critical care management. Okay, very clear. Okay, all right. Now, I am going to discuss with you the treatment guidelines. So, what you should follow is that I'm sure that there are different state guidelines, okay, for COVID-19. But for your entrance exams, you have got to stick to this guideline because that is the one that is endorsed by the Ministry of Health and Family Welfare also. So the AIMS ICMR COVID-19 Task Force guidelines, which actually divides the COVID-19 patients into 3 categories, having a mild disease, moderate disease and severe disease. This is the categorization. Now this is important, mild, moderate and severe. You are likely to get questions for this, especially the moderate ones. more likely to be asked, but this is very, very important. Now, let's first come to the treatment options in COVID-19. Okay, I'm generally talking of all the treatment options. So the general options you have available are, one is your oxygen is available, antivirals, anti-inflammatory drugs, by which I mean steroids and IL-6 agents, anticoagulants and other supplements. In addition to this, you can have other agents also, like anti-fibrotic agents like your nintedanib. Okay, but there are many agents whose role has not been convincingly proven. Now, out of these whole list of agents that are available, in addition to oxygen, if you take into account the drugs alone, something that is proven without any doubt to be of benefit is the steroids and also the role of anticoagulation. The others are also having evidence in favor, but again, convincing evidence is always in favor of steroids and anticoagulants. Because we have seen that over the past 2 years, since this COVID-19, lots of treatment guideline changes. But it's steroids and anticoagulation which holds a very, very firm place. Okay, very important. Now this chart is very important. I want you to focus on this. Okay. Now see this. I'm trying to tell you the utility of the various agents in the time course of, or the disease course of COVID-19. You see here, this is the time course, and you see this is the severity of illness. So you can have initial stages of viral replication, subsequent stimulation of adaptive immunity, and finally the hyperinflammatory state. One very important treatment point that you should know is that antivirals are having best use when they are started early in the disease course. Why do I say it? Because it is in the phase of viral replication that you have your best utility of your antivirals. So try to start it early, antivirals. Whereas it comes to anti-inflammatory drugs, that is mainly in the stage of adaptive immunity and the hyperinflammatory response. So if you start the anti-inflammatory drugs straight away in the early viral replication phase, it might not yield you the desired result. Okay, so anti-inflammatory drugs, anticoagulants, you see more towards the stimulation of adaptive immunity and the hyperinflammatory phase. This is very, very important to understand. All right, okay. I hope you have just quickly drawn this figure. Now, the ICMR and the AIMS guidelines, I told you they are dividing it into mild, moderate and severe. So on what basis are they dividing? It is based on the symptoms, the respiratory rate and the SpO2. So mild disease means the patient is only having upper respiratory symptoms and is without any shortness of breath or hypoxia. Whereas when it comes to moderate disease, I told you this is based on respiratory rate. So the respiratory rate more than or equal to 24 per minute, the patient is having breathlessness, or when the SpO2 is in the range of 90 to 93%. Now, let me tell you one thing, it is either of this. It is not that the patient should have only one, it is, it should have both. Suppose even if the patient's saturation is relatively normal, if the respiratory rate is high, so some students, they might just think that, okay, COVID-19, all you have got to monitor is the saturation levels. Please understand that saturation level is definitely important. SpO2 is important. But something that is very, very important is along with the SpO2, also look at the respiratory rate. Because the patient might be maintaining a normal saturation at the expense of a higher respiratory rate. When it comes to a severe disease, the respiratory rate is more than 30 per minute. So moderate is 24 to 30. And severe disease means the SpO2 is less than 90%. Okay, that is when you call it a severe disease. So this is the basis of classification. Okay, all right, so that is also clear. Now, first let's go to the management of mild disease. Okay, mild disease. So mild disease means the patient is having upper respiratory symptoms, okay, without shortness of breath or hypoxia. Okay, the patient is having upper respiratory symptoms without shortness of breath or hypoxia. In such individuals, you can go for home isolation and care. Okay, all right. Now, in the mild disease variety, please understand that the guideline says about certain must do's and the guidelines say about certain may do's. First of all, let's quickly go through the must do's. Now, these are very important because these guidelines can be asked as question. They may ask you something regarding management or a false statement. So, must do's: physical distancing, indoor mask use, strict hand hygiene. Symptomatic management. Please remember that symptomatic management doesn't mean that you put the patient on antibiotics. Symptomatic management means it is hydration, antipyretics, antitussives and multivitamins. Always stay in contact with the treating physician. Monitor the temperature and oxygen saturation. You can use a SpO2 probe as well. But remember, even if you are having a mild disease, if you are having the following warning signs, please take a medical attention. Like if you are having a breathing difficulty, if you are having a high grade fever or severe cough, particularly if it is lasting for more than 5 days. Okay, and if the patient is having certain high risk features, I'll come to the high risk features. These are individuals who are elderly, having other comorbidities like coronary artery disease, chronic liver disease, CKD. We'll come to that. So if there is some high risk features, the threshold for seeking a medical attention should be very less. Okay, now these are the must do's that you have got to do. Now coming to the may do's, which means this is not 100% necessary. It is not very imperative that you start on this, but these are therapies which are based on a lower level of evidence. So you can use tab ivermectin, but again remember, it is not 100% necessary in all cases. So 200 microgram per kilogram once a day for 3 days, but please avoid in pregnant and lactating women. Now when I say about individual drugs also in this discussion, keep in mind the contraindications like pregnancy and lactation, because all this can come as clinical scenarios. So other than ivermectin, you can also go for tab HCQ. Again, was always a matter of debate whether to include or not right from the initial part. Initial guidelines were so much favoring, but now it is just a may do. It is not a must do. So what is this may do? It means the evidence is not very strong. So HCQ 400 milligram BD for 1 day followed by 400 milligram OD for 4 days unless there is a contraindication for HCQ. And inhalational budesonide. So the steroid can be given via a meter dose inhaler at a dose of 800 microgram BD for 5 days. That is to be given if the symptoms are persistent beyond the 5 days of disease onset. So you might see that there will be some subset of patients who are initially okay, but the fever and cough keeps on persisting. So if it persists beyond 5 days, please go for a budesonide meter dose inhaler inhalation. Okay, all right. So that is it about the management of mild disease. Now coming to the management of moderate disease. Moderate COVID-19 infection. So already I have told you what is this moderate COVID-19 infection. I have told you the respiratory rate and the SpO2 cutoffs for classifying it as moderate COVID-19. In your exam, they might give a clinical scenario of a patient having a respiratory rate of 26 and a saturation of 92. Now you have got to identify this is a case with a moderate disease of COVID-19. Okay, all right. Now coming to the management. So remember that the moderate disease you have got to admit in ward. Yes, definitely the serious disease you have got to admit in the ICU. So moderate disease as per the guidelines you have got to admit in the ward. Now what is the target oxygen saturation? Important. See, your target SpO2 in case of a moderate disease is 92 to 96. However, if the patient was having a chronic obstructive pulmonary disease before, the target actually goes to 88 to 92%. Okay. Now, this is the oxygen target. This again can be asked as a question. It is a potential question. What is the target SpO2? Now, this SpO2 can be given by devices. There are lots of devices that are given for oxygenation. We'll be coming to that shortly. So, the preferred device is actually the non-rebreathing mask. Okay, you can go for rebreathing mask. You can go for others also like nasal cannula, your plastic mask. So all you can go for, but preferred is actually the NRBM. Now, awake proning is encouraged in all patients. We'll come to awake proning and its advantages in a short while. In all patients requiring supplemental oxygen therapy. So what do you actually do in case of this awake proning is that you actually sequentially change your position every 2 hours. Okay. Now that is it on the oxygen support and the awake proning. Now coming to the anti-inflammatory therapy. So once the immunity or the inflammatory cells come and then there is a release of cytokines, hyperinflammatory state, these steroids are actually very useful. And what steroid are you going to use? You can go for either methylprednisolone or dexamethasone. Now if you ask me, is there any specific advantage of one over the other, like methylprednisolone over dexamethasone? My answer is no. As of now, both of them are almost having equal efficacy, except in case of say pregnant females, and probably you are expecting some preterm delivery and there may be a there is an issue of lung maturity. In such cases you can go for dexamethasone. Otherwise either methylprednisolone or you can go for a dexamethasone. Now look at the dose. It's very 5 to 10 days. So moderate disease 0.5 to 1 mg per kg in 2 divided doses for 5 to 10 days is the steroid treatment. Now if you may ask me, pulse steroid therapy. Well, there is no definite role for pulse steroid therapy and this dosing is enough. There are certain conditions like your systemic lupus erythematosus where you give pulse steroids. No, here there is no role of pulse steroid therapy. So patients may be initiated or switched to oral route if they are actually stable or improving. You can go for the oral steroids. Now regarding anticoagulation. Now anticoagulation is also very, very important. You can go for the conventional, either you can go for the unfractionated heparin or the low molecular weight heparin. One second. Kaustubh, as you said, antivirals are to be given in initial days in mild cases. Why the guidelines? See, mild disease means there is no significant viral replication. And you remember I told you, Kaustubh, there are only 2 drugs which is having definite proven role. One is steroids and other is anticoagulation. Antivirals, yes, they are having some benefit. They are not having much benefit, in case of the mild disease, which is why they are not that preferred in mild diseases. Because, you will have to have a good degree of viral replication. When you give antivirals like, say, remdesivir, do you think it is without any other adverse effects? There are problems with it. So always it is risk versus benefit. If it is a mild case where the patient is totally asymptomatic, what do you think, Kaustubh? Should we go for an agent like an antiviral like a remdesivir? No. So what I was meaning is that early viral replication, if it is a moderate disease, early in the course of a moderate disease than late in the course of a moderate disease. That is what I meant by early initiation. Okay, because many patients straight away would have a moderate disease and there will be a high degree of viral replication. Don't wait, go for early treatment. I hope you are understanding it. Okay, all right. So yeah, I hope only the video is lagging. I hope the audio is perfect. Okay, in case the audio is actually breaking, just let me know. Okay. Sorry. Okay, now coming to anticoagulation. So anticoagulation, I told you, unfractionated heparin as well as low molecular heparin you can use. Now look at the dose of low molecular heparin. It is given at a dose of prophylactic dose. It is 0.5 mg per kg per day subcutaneously. It is a once daily dosing in case of moderate. Now in case of severe disease, this will actually change. That is why I want you to be careful here. This is a once daily dosing of anticoagulation. And also make sure there is no contraindications for bleeding. Okay, I hope it is clear. Now Tanya is asking, can NOAC be given for moderate disease? So for anticoagulation, heparin as well as the low molecular heparin is actually the ones which are there in the AIIMS ICMR guidelines. But there are trials with the NOACs also, But so far, none of the Novaks have shown any superiority. See, when do you prefer a particular drug? When it is superior to the other drug. So considering all these cost issues compared to heparin, and also no significant risk benefit over the Novaks, over the conventional heparin as well as the low molecular heparin for this COVID-19, that is probably why as of now they do not feature in the guidelines, Tanya. Okay, I hope it's clear. Okay, alright, so that's it regarding the anticoagulation. Now, suppose it is a moderate disease. Now, a patient with moderate disease, I have told you about the anti-inflammatory drugs, anticoagulation, okay, and then regarding the monitoring, okay. Now, regarding monitoring, okay, remember antivirals, those who are asking, okay, antivirals, I will be coming to it in detail, don't worry, we are going to have an A to Z coverage of the clinical management of COVID-19. Let me tell you, from this lecture alone, you can have, 4 or 5 questions, because naturally COVID-19 will form at least 6 or 7 questions might be there directly or indirectly linked to COVID for your exams, considering all micro, patho, pharmac and medicine. Okay, now to monitor patients. You have got to monitor the work of breathing, hemodynamic instability and change in oxygen requirement. Now, just because a patient was initially categorized as moderate doesn't mean that he will stay in the moderate category for long. He might improve going to the mild category. He might worsen going to the severe category. So always you have got to have a good monitoring of both the clinical status as well as the lab status. Now about X-ray, you will have to go for serial X-ray, but don't keep on repeating HRCT unnecessarily. HRCT needs to be done only if there is a clinical worsening, because I have seen many patients with COVID-19, when we get these referrals, you see that they would have done at least 6 or 7 CTs during their hospital stay of around 2 months. So HRCT needs to be done. It's not to see at every stage, regarding the improvement, only and only if there is worsening. Dear children, for your exams, they will give you clinical scenarios and they might ask you what is the next step. So always remember, you might ask me, sir, what sort of questions can we expect? Based on the next step, what is the management? So you should know HRCT, okay. Only if there is worsening, you go for HRCT, okay. And what about lab monitoring? Yes, you will have to go for your inflammatory markers, because once it goes to the stage of hyperinflammation, the inflammatory markers can be raised. So CRP can be raised, and D-dimer also you have got to do it 48 to 72 hourly. CBC, LFT, RFT, you do it 24 to 48 hourly. Now this monitoring also please keep in mind. When it comes to severe disease, you will have more frequent monitoring, okay. And IL-6 has to be done only if the patient is deteriorating. Here also I have seen sometimes, people unnecessarily repeating IL-6. IL-6, one thing is, the cost is there and it is to be done only if the patient is actually deteriorating, okay. All right. Now finally coming to severe disease. I have already defined what is a severe disease, where the respiratory rate is more than 30 and the SpO2 is less than 90 on room air. That is severe disease. Now coming to severe disease, see, first of all, coming to the monitoring, so you have got to monitor the work of breathing, you have got to monitor the hemodynamic instability and the change in oxygen requirement. One second. Yeah, and here you see serial X-ray, HRCT to be done only if there is worsening, okay. One second, just sorry. This one, is the previous one. Just disregard this, only the slide actually got repeated. This is not the monitoring for the severe COVID-19, okay. The severe COVID-19 monitoring is coming up. Now coming to the high risk features, you remember I told you, whenever you are having a patient admitted with COVID-19, always watch out for high risk features, which means there will be certain high risk features which might want you to closely monitor a particular patient, even if he is having mild disease. So age above 60 years, cardiovascular disease, hypertension and CAD, diabetes and other immunocompromised states, chronic lung, kidney or liver disease, cerebrovascular disease and obesity. These are high risk individuals you have got to have a careful monitoring. They are likely to go for a severe disease. Okay, all right. Now, this is another table. Now, this, all of you please understand, this table that I am showing now is not from the AIIMS ICMR guidelines, but this will actually give you a rough clue for attending the questions in your exams regarding identification of who is the high risk patients. So comorbidities I have already told you, like diabetes, hypertension, cardiovascular disease, if there is already a pulmonary disease, CKD, CLD, immunosuppressives, then if the HIV with a CD4 less than 200, age more than 65 and BMI more than 30. So these are the comorbidities. But when it comes to clinical assessment, hypoxia, when the SpO2 is less than 94, tachycardia more than 110, respiratory rate more than 24, and if the patient is having hypotension, systolic less than 90, diastolic less than 60, altered sensorium and P by F ratio, PaO2 by FiO2 ratio less than 300, this again is a high risk individual. Now, sometimes laboratory values also can help to prognosticate. Laboratory values can also hint which patient is a high risk patient. So if you have a CRP more than 100, if you have a CPK which is more than twice the upper limit of normal, more than 300 microgram per liter of ferritin, an LDH more than 245 and a TROP-T elevation or a D-dimer that is high, all this is giving you a clinical clue. This is a high risk patient. Okay, high risk patient. Okay, so you are saying, it's a bit fast, but it's a quick revision program, so you have got to be a bit fast. Okay, so you listen to me, okay, you watch this, you write the notes quickly, and then, if you want, you can just watch it again in the YouTube as well. Okay, now, next question is, let's try to understand what is the basis for severe COVID-19. Why does certain individuals go into severe COVID-19? What is the basis? The basis is that it is when there is a dysfunctional alveolar capillary oxygen transmission. So you know that the alveolar capillary membrane is across which the gas exchange occurs. So when there is an impaired gas exchange that is happening, when there is an endothelitis and endothelial barrier dysfunction, as well as when there is a fulminant activation of coagulation cascade, these are the scenarios when a patient goes to severe COVID-19. Okay. All right, now let me explain to you how you are going to manage a patient with severe COVID-19. So first of all, a severe COVID-19 patient has to be managed in the ICU. Remember, moderate I told you it is in the ward, severe you have got to admit in the ICU. So you have got to give the patient respiratory support. So you can consider the use of NIV in patients with increasing oxygen requirement. So NIV can be given in different ways. Don't worry, I will be coming to that. For around 5 minutes, I'll be talking of oxygen, how to actually give oxygen in patients with COVID-19. All right, and you can consider the use of HFNC in patients with increasing oxygen requirement. Whereas in certain patients, you might require even ventilation as well, intubation and ventilation. Which patient HFNC, which patient NIV, which patient intubation, we'll see in a short while. Don't worry, but I was just telling you the guidelines. Now you use the conventional ARDS protocol for the ventilatory management of COVID-19 patients. So you know that the conventional ARDS protocol is a low tidal volume ventilation. Okay, now coming to the anti-inflammatory therapy. Now coming to the anti-inflammatory therapy in COVID-19, you see you can give the patient steroids. Methylprednisolone can be given. When you give methylprednisolone, when it is a severe disease, you see the dose is actually high. It is 1 to 2 mg per kg IV in 2 divided doses. Or you can give an equivalent dose of dexamethasone, both are equally effective. And how long it is given? 5 to 10 days. So whether it be moderate disease or severe disease, the duration of steroid is same, but the dose is different. Agent chosen is also same. Anticoagulation also you can go for either unfractionated heparin or low molecular heparin. Again, see the dose here. It is 0.5 mg per kg, but it is not once daily, it is twice daily. Okay, so the dosage is different in case of severe COVID-19. All right, Now coming to the supportive measures, you have got to maintain euvolemia. Okay, and if there is a sepsis, you manage according to the sepsis protocol that you have in your ICU. All right. Now, how will you monitor severe COVID-19? So, severe COVID-19, it is quite clear you have got to more closely monitor. So, serial chest X-ray, HRCT to be done only if there is worsening. That stays true even for moderate also. But you see, CRP and D-dimer 24 to 48 hours. You see the CBC, KFT, LFT and IL-6 to be done, LFT daily. Okay, so you have got to daily do these routine blood investigations, and IL-6 to be done only if the patient is deteriorating, as in case of a moderate disease. Okay, that is also clear. Okay, so now you understood by the protocol, mild, moderate and severe disease, how you are going to treat, how you are going to monitor. Now we are going to come to the individual agents. First of all, oxygen. Now this per se can be a question for your exam. This is very, very important. Okay. All right. Okay, Akash is asking, whether I am tired or not. I am not tired. In case you are tired, that's the only thing. So oxygen. Okay. So oxygen therapy in COVID-19, I'll tell you when you are going to give this oxygen therapy in COVID-19. Okay, you have got to understand. Please understand, you see this graph, this is the time course of the disease. Okay, this is the time course of the disease, and this is the PaO2. This is the symptom onset. Okay, now you see in the initial part, okay, the patient is having a stable course. Then what happens is, as the disease progresses, the patient may have intrapulmonary shunting. The patient can develop intravascular microthrombi because of the endothelitis. There is loss of lung perfusion regulation. So all these features may be there. Now in the initial stage, when these features are just developing, the patient may not have obvious dyspnea. You might have heard of the term happy hypoxia, where there is a respiratory compromise, but the patient is not obviously dyspneic at that particular point of time. But you see here, beyond a particular point of time, the patient is having a reduced lung complaints, increased dead space, increased consolidation and atelectasis because there is fluid exudation to the alveoli. There is carbon dioxide retention, and also you can have anxiety and fatigue for the patient. Now that is when the patient actually goes a further downhill course. Now what is the importance of this graph is the non-invasive oxygen therapy. Non-invasive oxygen therapy may have its utility up to this stage. That is before the patient develops obvious dyspnea. But once the further features like all these reduction in lung complaints, increased dead space, that actually might push the patient to require a mechanical ventilation. So patient might require a mechanical ventilation. Okay. So that is very, very important. Okay. Now, how to assess respiratory distress? Patient might be admitted in the ICU. Okay. So regarding anticoagulation. Okay. So Kaustubh is actually asking regarding anticoagulation, how many days it should be continued. See, as long as the patient is in the hospital and is having a moderate to severe disease, you have got to give anticoagulation. Now, an exact answer for your question is actually doubtful, because you might have seen some hospitals discharging the patient on oral anticoagulants. But actually the guideline does not favor a discharge on oral anticoagulants, because the answer to that, as of now, the answer to your question is, if you feel that the patient is ambulant and patient goes home and he can resume his normal activities, there is no need to continue anticoagulation in such patients. So during the time of hospital stay, where the patient is actually bedridden and already you have an endothelitis, you continue anticoagulation. At the time of discharge, no need to continue anticoagulation, except for the patient having some other features like the patient is bedridden for a stroke, or the patient is having some neck of femur fracture and he is already bedridden. Except for such scenarios, there is no need to continue. So better during the hospital stay. And there is one extension to your question, Kaustubh. Some students also have the doubt whether we should use D-dimer as a surrogate marker for deciding whether to continue oral anticoagulation or not. Because sometimes there may be a mild patient and you might have D-dimer to be high. Okay, then you might have a doubt. Patient is fine, no problem, he is walking around, D-dimer is high, should I anticoagulate? As of now, as per the guidelines, no need to anticoagulate the patient. Even moderate to severe also, suppose you have decided to discharge the patient. On the discharge day, you have done a D-dimer and you find that it is elevated. Please remember that D-dimer elevation does not compulsorily make this an indication for leaving the patient or discharging the patient on oral anticoagulation. As of now, the majority of the guideline consensus is that you will continue anticoagulation only if there is some other cause that is likely to precipitate thrombosis in the individual. Okay, I hope your question is solved, Dr. Kaustubh. Okay, now how to assess respiratory distress? Now assessing respiratory distress, you can go for symptoms like dyspnea, tachypnea and chest tightness, and then you can go for the SpO2 by your favorite pulse oximeter measurement. You can measure the oxygen saturation. You can also measure the PaO2, which will help you, and also the PF ratio, which is your PaO2 to FiO2 ratio. All this will help you assess the respiratory distress of the patient. When it comes to exam question also, they will be giving you some value, either the SpO2 value or the PaO2 to FiO2 ratio, to indicate to you the severity of respiratory distress in the patient. Okay. Now coming to oxygen delivery. When it comes to oxygen delivery, next few slides are important because even you might get a question from this with respect to your anesthesia question as well, which is why I told you whatever I am taking now is very, very, very important. Okay. Now coming to the oxygen delivery in case of COVID-19. So you can go for the conventional oxygen therapy, that is with your nasal cannula, plastic mask or your non-rebreathing mask. So that is one method, conventional oxygen therapy. You can go for your high flow nasal oxygenation, that is by a HFNC, that is a high flow nasal cannula you can give, and you can go for a non-invasive ventilation as well, NIV. Okay, so these are the modes of oxygen delivery to the patient. So let me tell you a bit regarding the high flow nasal oxygen system. So if somebody might remember the previous INICT, not this one, the previous one before that, they had actually asked a question on this. So remember, this is actually the HFNC equipment. It is having a flow meter, a humidifier, the tubings and the nasal interface. Okay, these are the components of the high flow nasal oxygen system, very important. Now the technique of HFNC. Many students have inboxed me like, what is the advantage of a high flow nasal cannula or this high flow nasal oxygen delivery system? So how is it done? First of all, let us try to understand. You will fit the nasal prongs. You will initiate with the maximum flow, and for the patient just put a surgical mask because you want to avoid the aerosol dispersion, and you start with higher FiO2 and adjust the FiO2 as per the oxygenation, and you start with 37 degrees Celsius and you can bring it down to 34 degrees Celsius. And what are the physiological effects of your HFNC? So you are actually trying to give the patient a heated, humidified air at a high FiO2 and a high flow, and this will improve the oxygenation. So this is very, very important because compared to the conventional oxygen delivery systems, HFNC improves the oxygenation as well as it reduces the dead space. It generates an extrinsic PEEP of 4 to 6 centimeter water, and also it lowers the respiratory rate. Now this is the physiological effects of a high flow nasal cannula, important. Now suppose you have started HFNCs in a patient. How do you monitor the HFNC? One is you can go for the respiratory rate, breathing pattern or SpO2, you can do that. And something very important and a potential question is the ROX index. So ROX index for monitoring of HFNC, it is a ratio between the SpO2 to FiO2 and the respiratory rate. And what is this ROX? It is respiratory rate and oxygenation, that is your ROX index, which is used for monitoring HFNC. And how is it useful? Because this, when you use this ROX index, it can be a predictor of the HFNC failure. Because if the ROX index is less than 2.85 at 2 hours, or less than 3.47 at 6 hours, or less than 3.85 at 12 hours, this is going to be an indicator of HFNC failure. If you ask me, how long can you keep the patient on a high flow nasal oxygen? Well, there is no definite guideline on you should keep for these many hours or these many days. Okay, you look for the symptomatic improvement of the patient. Okay, all right. Now coming to non-invasive ventilation. So basically, what is this non-invasive ventilation? You're trying to generate positive pressure in the airways, either by as a standalone device or via a ventilator, and this is delivered via an interface. Okay, either maybe a full face mask or a nasal mask. And this NIV you can give in two forms, either as a CPAP or a BiPAP. In case of CPAP, continuous positive airway pressure given throughout the respiratory cycle, whereas in BiPAP it is a varying positive pressure during inspiration and expiration. Now just try to look at these devices. This is a nasal mask. So advantage of the nasal mask is, the patient can still, eat or drink something, but there is always a risk of air leakage. This is a complete face mask for giving NIV, complete face mask. And the last one is actually a helmet device that you are seeing. So you can give a NIV by means of a helmet device also. Okay, all right. Now suppose you have decided you are going to give this patient NIV. What are the problems with NIV, non-invasive ventilation? So when you give NIV, there is always a risk of aspiration, which is why patients who are in altered sensorium, you will not prefer NIV. And also there is a likely chance of claustrophobia. And one major, when you compare NIV and HFNC, many students ask, which is better, NIV and HFNC. See, NIV has always a chance of causing a lung injury because of excessive tidal volume. So does that mean that your HFNC is totally free of that? No, that also can cause even your barotrauma, but it is comparatively very less compared to your NIV. Okay, and another very, very important point is there is a higher mortality in patients with a P/F ratio less than 150. So that is also very important. So when the P/F ratio is less than 150, if you give NIV to such patients, it is likely to be counterproductive. So that is also an important problem with NIV. So what are the contraindications to NIV? When there is an altered level of consciousness, when you are having an agitated uncooperative patient, copious respiratory secretions, persistent vomiting, hemodynamic instability. Now how is this important for your exams? Because in your exams also they will give you clinical scenarios. So please remember, if it is a patient with an altered sensorium, so there is always a risk of aspiration, patient is having persistent vomiting, you cannot have a face fitting mask being given and that will actually increase the risk of these aspirations. These are contraindications to NIV. Now what about mechanical ventilation? Okay, so mechanical ventilation in case of COVID-19. So let's see what are the possible indications, clinical indications for mechanical ventilation. So one is impending airway obstruction and signs of unsustainable work of breathing. In spite of probably giving your NIV or maybe HFNC, patient is still having problems, increased work of breathing, you can go for intubation. Refractory hypoxemia, hypercapnia or acidemia, encephalopathy, all are indications for endotracheal intubation. Okay, important. Now, what are the principles of ventilatory management in ARDS due to COVID-19? First of all, even the tidal volume, it is a target tidal volume is 6 to 8 ml per kg of the predicted body weight. Next important point is to set the PEEP to prevent lung de-recruitment, important. And you see, you have got to monitor the hemodynamics, respiratory complaints and gas exchange at each PEEP setting. It's very important to closely monitor the ventilator parameters in patients with COVID-19. And if the plateau pressure is more than 30 centimeter water, you can consider reducing the tidal volume to where minimum like 4 ml per kg, you can reduce the PEEP and allow high plateau pressures in patients with obesity or reduced chest wall lung complaints. Okay, now this is very, very important. These are the ventilatory strategies. So they may ask in your exam regarding which of the following is true regarding ventilatory adjustments in patients with COVID-19. So this is very, very important, very, very important figure. Okay, all right. Now, next is a very, very important table. So I hope you know till this much part in management of COVID-19. Is there any doubt? We are just moving forward. Just let me know. Like any doubt till now in the COVID management, if you want me to answer any doubt, just type in the chat box. And are you all awake with me? Like, or have you dozed off? Okay. So I know that this is an exhaustive session, but we'll finish actually with COVID management. Okay. All right. Okay, all right. So, you know, this is next an algorithm. This is a very, very important flowchart that I'm going to show you. Please draw it now. See, this is the approach to respiratory failure to patients with COVID-19. Now, you might have a doubt. See, suppose a patient is having hypoxia, you know, how to manage, what to start, with respect to oxygen therapy. First of all, you know, if the patient is having no obvious respiratory distress, okay, that is your patient is having no obvious respiratory distress, you start with simple oxygen supplementation by a nasal cannula at around 4 to 6 liters per minute. Okay, simple oxygenation by a nasal cannula. However, if the patient is having a worsening of hypoxemia with your nasal cannula oxygen administration, then you go for a non-rebreathing mask at 15 liters per minute. Okay, at 15 liters per minute. All right. Okay. Now, now coming to step 2, which is a mild to moderate respiratory distress. So where your P by F ratio is in the range of 150 to 300 range, your SpO2 less than 90 to 94%. Okay. Now there you will go for the non-invasive strategies. Now when you go for non-invasive oxygen strategy, it can mean either the HFNC, the awake proning as well as NIV. Now out of these three, yes, definitely the preferred modality is the HFNC. Now HFNC is preferred, very, very important point, when the hypercapnia is minimal. When you have significant hypercapnia, this is not that favored. So you have a minimal hypercapnia, that is when your HFNC is preferred, whereas your NIV is preferred when the patient is having significant hypercapnia. That is, suppose this patient is actually having a COPD. So there is natural tendency for hypercapnia. So COPD with moderate hypercapnia or cardiogenic pulmonary edema, you would actually prefer your NIV. Now what about awake proning? The details of awake proning is coming up in the next few slides. But awake proning, see, you can do awake proning either alone or in combination in a patient with a HFNC. That is, along with HFNC awake proning or along with NIV, you know, awake proning you can do. So awake proning either you can do either standalone or along with these other HFNC or NIV. But if the patient is having severe respiratory distress, if you remember one slide before I told you, when the P by F ratio is less than 150, what about the utility of when there is a severe respiratory distress, when the P by F less than 150, that is when you know you will go for invasive mechanical ventilation. Invasive mechanical ventilation. You will not try NIV in a patient whose P by F is less than 150. This can also be asked in your exam. Okay, they might give a P by F ratio of 130, and then you might be asked what is the next step. You will have to go for mechanical ventilation. So this flowchart on the algorithmic approach to respiratory failure in COVID-19 is important. All right. Okay. Now, So dear children, today, in this session we'll discuss COVID-19, and the remaining part, I'll take as a separate lecture on another date. I'll just let you know the date. Okay, so because otherwise we'll have to go till morning 2 o'clock or 3 o'clock to finish. All right, so now next is regarding awake proning. Now this is important. You might get a physiology question or maybe a medicine question per se based on this fact. How is awake proning going to help you? Now be very attentive here. Be very attentive here. Now a comparison of the supine position versus the prone position. So this is the axial. This is the sagittal view. So you see, when the sagittal view, when the patient is lying supine, the dorsal alveolus will be actually collapsed, whereas the ventral alveoli will be distended. So when you look at the PTP, what is this PTP? It is the transpulmonary pressure. Transpulmonary pressure. So what happens is, there is a great disparity between the transpulmonary pressure of the dorsal alveoli and the ventral alveoli, and this marked difference between the transpulmonary pressures is responsible for over distension of the ventral alveoli and this dorsal alveoli being collapsed. Okay, that occurs in supine position. Okay, and also there is the blood flow is actually also, there is a mismatch in the blood flow to the different portions of the lungs. But in case of prone position, what you see here is that you see the difference between the transpulmonary pressures in the dorsal and the ventral alveolus. You see here you had 3 plus and 3 minus, huge disparity between 3 plus and 3 minus. Here it is 1 plus and 1 minus. So the degree of disparity between the dorsal and ventral alveolar, the transpulmonary pressure is less in case of prone position, and you get a better distribution of blood flow. Okay, so you get almost a homogeneous oxygenation with a good blood flow in the prone position, which is why prone ventilation or awake prone ventilation is actually useful. Okay, all right. So this is just to show you the hemodynamic changes that actually happen from a supine to prone position. When you are lying prone, there is a decreased gravitational pressure on the heart and mediastinum. There is a decreased compressive effect of the abdominal organs on the lung, and you can have a homogeneous chest wall compliance due to restriction of the anterior chest wall movements. Okay, so this is very, very important. Okay, prone position. So you see how the proning is actually done. As per the guidelines, 2 hours you can change the position, but some guidelines go for 30 minutes to 2 hours also, like 30 minutes, 1 hour. So you keep changing these positions, different such positions. Okay, that will actually help. Okay, all right. All right. Okay, so now we have done with the oxygen delivery part. Okay, the devices which are used, and your exams, if they ask you regarding the which mode to select, everything I have explained to you, even algorithm also I have given to you. Now regarding the antivirals, now this is very important. Even pharmacology also you can expect a question, very, very, very important. First of all, coming to remdesivir. First question is probably, how does it act? Well, it has got to act by inhibiting viral replication. It acts by inhibiting the RNA dependent RNA polymerase. Okay, so this is an adenosine nucleotide prodrug. So basically how it acts is that it will inhibit the viral replication. Okay, so this polymerase is necessary for the viral replication, and remdesivir will block the viral replication, which is useful in the phase of active viral replication. So this may be considered in patients with moderate to severe disease. You remember previously somebody was asking me, can you give in mild disease? Because the utility is actually in moderate to severe disease, risk versus benefit. And also within 10 days of onset of symptoms. Why within 10 days of onset of symptoms? Because that is the period of viral replication. So you will not actually go for a delayed remdesivir. So you go for remdesivir within 10 days of onset of symptoms. So how are you going to dose your remdesivir? Well, you are going to give a 200 milligram as a IV as a single dose on day 1, which is followed by 100 milligram IV for 5 days. Okay, so dosing regimen, dear children, please understand this may be asked. And this IV dosage which I told you is to be given over 30 to 120 minutes. Okay, all right. Now if you may ask me, how many days will you give remdesivir? Remdesivir is usually given for 5 days. But if you assess the patient on day 5 and you find that there is no substantial improvement, you can extend it up to 10 days, but not beyond that. Okay, that is how long you will treat with remdesivir. All right. Now, is remdesivir free of side effects? No. You can have nausea, skin rash, hypersensitivity reaction, bradycardia, hypotension, and increased ALT to AST ratio. So these are the possible side effects of remdesivir. Okay, very important. Now, what are the contraindications for remdesivir? One is hepatic dysfunction. So if in question they have given a patient who is having a significant hepatic dysfunction, that is an AST to ALT ratio more than 5 times upper limit of normal, remdesivir is contraindicated. Renal impairment when the GFR is less than 30. Pregnancy lactation, very important. They again might ask you as a possible clinical scenario of a pregnant woman with a moderate disease, you cannot give remdesivir. Okay, unless you can give, this is not an absolute contraindication, unless you feel risk versus benefit. The patient is having a early moderate disease or moderate to severe disease, and you feel that you want to actually give the drug. Okay, that is again you have got to discuss with the relatives about the risk also and then give the drug. Then children less than 12 years and also history of hypersensitivity to remdesivir or any component of the formulation, that is also a contraindication. Okay, all right. Now this is very important. Okay, now next what you have got to understand is, see, remdesivir is an antiviral, but you might have already seen in your practice as well as in the various news channels also, people running around for remdesivir. So there was rampant usage of remdesivir, because of which there was an advisory by the Ministry of Health and Family Welfare regarding the rational use of remdesivir. Now they put forward certain statements which is very important. This again is very important. So remdesivir should be used only in select moderate to severe patients on supplemental oxygen. So that is a subgroup where you have got to give remdesivir, because it is a reserved drug that is approved under emergency use authorization, which is abbreviated as EUA, emergency use authorization, only based on limited scientific evidence. Because you remember, I told you only steroids and anticoagulants have definite evidence. Okay, so please understand that remdesivir is not a drug you just give left and right like paracetamol. You have got to be careful while using this drug. This is not indicated in mild COVID-19 patients who are in home care or COVID-19 care centers. Okay, now physicians or doctors, they are advised to exercise extreme caution using. So the point is, when you are in a hospital setting, a house surgeon or even a resident, a medicine resident should not actually prescribe remdesivir. It has to be by a senior consultant or in conjunction or after taking an opinion from a senior consultant. This guideline actually came because of the rampant use of remdesivir even for mild cases. So it has to be advised by senior faculty members or the COVID specialist. Okay. Now even if you are ordering a remdesivir during the odd hours, you have a patient admitted in the midnight, you still have to contact the duty doctor, has to contact the senior doctor over a telephone and then, decide and then give COVID-19. And any order that you give for remdesivir, it should have the name, designation and signature of the concerned doctor. Okay. And also the hospital, in the tertiary care hospital where you are giving this remdesivir, there should be a special drug committee. And this drug committee should be there monitoring in how many patients the remdesivir was given today and was it given for the apt indication. There has to be a committee also. Okay, all right. And also the remdesivir should be procured and by only the hospital facility. You should not actually send a relative to actually go and get the remdesivir. Okay, so that is also important. So what about the other antivirals? The other antivirals other than remdesivir are favipiravir, lopinavir, ritonavir, ivermectin as well as convalescent plasma. These are the other antivirals used. Now coming to favipiravir, just like remdesivir, this is also an inhibitor of RNA dependent RNA polymerase, thereby it will inhibit the viral replication. In fact, this was an antiviral drug this is an antiviral drug that is used to treat influenza. But please understand at present, it is not found to have any effect, that is mortality benefit in patients with COVID-19. Moreover, it can lead on to teratogenicity, transaminitis, neutropenia and even hyperuricemia. So these are the problems with favipiravir and hence it is not that favored. Okay, clear. Alright. Now coming to lopinavir ritonavir. So what is this lopinavir ritonavir? It is basically a co-formulation of lopinavir and ritonavir. This also has no effect on mortality or severity of COVID-19 patients. Now what about ivermectin? Well, ivermectin, as you all know, is a semi-synthetic anti-helminthic agent. Now this is a maybe given drug. You remember the mild cases, and also this is given only in mild cases. It has not shown to be useful in case of moderate and severe cases, and this is given maybe in mild COVID-19. It's not necessary. Dose is 200 microgram kg once daily for 3 days. There is no dose adjustment required in hepatic or renal impairment. Okay, so that is it with respect to ivermectin. Okay, and what are the contraindications if you have a hypersensitivity to ivermectin? Pregnancy and lactation. And also, what are the side effects? Pruritus, rash, arthralgia, synovitis, edema, tachycardia. So increased AST to AST ratio. These are all, the side effects of ivermectin. Now, a very important point is that when you use ivermectin, please don't combine it with azithromycin, because this will affect the cytochrome enzymes and will increase the levels. So it will increase the serum levels of ivermectin. Hence, you should not combine ivermectin plus azithromycin. I have seen in many scenarios, people prescribing azithromycin as an antibiotic, and they have also put ivermectin also for patients with mild COVID-19, which is not to be done. Okay, not to be done. Very important. Okay. So Kaustubh is asking why favipiravir is prescribed left and right. See, I'll tell you, favipiravir, for a particular period of time was used. But now, remember, the guidelines keep on changing. Our understanding of the drugs also keep on changing. There was a time where favipiravir was used extensively. But now we understood, okay, favipiravir is not having a definite effect on the mortality as well as the severity of COVID-19. Okay, all right. Now, what about convalescent plasma? The mechanism of convalescent plasma is that the convalescent plasma will contain antibodies to the SARS-CoV-2. So basically, you are expecting that this will help to suppress the virus and it will modify the inflammatory response. So in the initial case series, you remember when COVID-19 started, everybody was going for these convalescent plasma. But now it is understood that, there is no definite evidence of the efficacy of this convalescent plasma. The randomized controlled trials that have been done, they have not shown much benefit. So convalescent plasma is not there in the guidelines. Dear children, please understand, you have got to be aware of what are the agents which have definite effect, what are the agents which may have an effect, what are the agents which do not have an effect. And this actually keeps changing as we learn more about COVID-19. So this was not the scenario early. You remember early, left, right, we were giving drugs like HCQ, okay, and remdesivir also rampant use as if it was some magic drug. Okay, so please understand it is not any magic drug, remdesivir. Okay, so what about the immunomodulators? This is again important. So immunomodulators that you can use in case of COVID-19, you can use the anti-IL-6 drugs as well as the JAK inhibitors. Now, what are the anti-IL-6 drugs that you can use? You can use anti-IL-6 receptor monoclonal antibodies as well as agents that target IL-6. So, one is targeting receptor and other is targeting the IL-6 molecule per se. So IL-6 receptor tocilizumab and sarilumab is targeting the IL-6 receptor, whereas siltuximab is targeting the IL-6 molecule. Now this is very, very important. JAK inhibitor, baricitinib. So lot of studies is ongoing now with respect to baricitinib in COVID-19. So that is also a JAK inhibitor that can be used as an immunomodulator. So tocilizumab, well, how does it act? It will inhibit the binding of IL-6 to IL-6 receptor. Now, when will you consider tocilizumab? So tocilizumab you will consider when the patient actually meets all the following criteria. Remember all the following criteria, and what are they? One is rapid deterioration or the presence of severe disease. Okay. Next is ideally within 24 to 48 hours of onset of severe disease, patient not improving despite use of steroids, and the inflammatory markers like CRP, IL-6 are very, very high. Okay. And the patient is not improving steroids and there is no active bacterial, fungal or tubercular infection. So these are the scenarios where you will go for tocilizumab. Okay, very clear. Now tocilizumab is given at a dose of 4 to 6 mg per kg. It is given in 100 ml NS over a period of 1 hour. Now what are the adverse effects? You can have infusion related allergic reactions, deranged LFT, late onset secondary infections, and we have had lots of case reports of severe disseminated strongyloidiasis with the use of tocilizumab. So strongyloid infection can actually get precipitated. In fact, a severe disseminated form can precipitate as with the use of tocilizumab. Why? Because the immunity level actually goes down. All right. Now regarding baricitinib, see baricitinib, how does it act? I told you this is a Janus kinase inhibitor. So it blocks the signaling via the cytokines like the interleukin 2, 6, 12 as well as the interferons. But baricitinib is also currently not in the guidelines. Okay. Baricitinib is also not in the guidelines. All right. Okay. So what are the indications of JAK inhibitors? JAK inhibitors means your baricitinib in COVID-19. Now very important, this is considered only in patients who have not received tocilizumab or on mechanical ventilation. The patient is requiring more than 8 liters of oxygen or FiO2 more than 0.4 or higher levels of respiratory support for at least 8 hours. And the patient is not improving despite more than 24 hours of standard care. So in such sort of severe cases is when you will go for tocilizumab. And in certain scenarios where the patients cannot be used on corticosteroids, suppose the patient is having a severe bleeding peptic ulcer, in such a scenario also you can go for baricitinib, even tofacitinib. You know, you have studied tofacitinib with respect to rheumatoid arthritis. Here also tofacitinib also you can use when the corticosteroids cannot be used. But please understand that the baricitinib or tofacitinib should be used in pregnancy only if, again, risk versus benefit, you feel that okay, we are in a state where you will have to give. Okay, all right. Now the dose of baricitinib is oral preparation. Oral is 4 milligram once daily. Tofacitinib oral 10 milligram twice a day. And the duration of treatment of the JAK inhibitors is 7 to 14 days based on the clinical response or until hospital discharge. So that is how you will treat the patient. Very important, you should not give the patient baricitinib or tofacitinib in patients who have already received tocilizumab, which is again very, very important. Okay, all right. Now so this is actually about the use of Janus kinase inhibitors. Okay. Now a few contraindications that you have got to know regarding baricitinib, especially the neutrophil count less than 500, active severe infections, substantial immune dysfunction, renal failure, pregnancy. Why? Because it can lead on to immunosuppression, cytopenias, and remember baricitinib per se can have prothrombotic effects and it can cause derangement of your liver function test. Okay, which is very important. Now coming to anti-SARS-CoV-2 monoclonal antibodies. How do these monoclonal antibodies, at least some of you would have heard of these antibody cocktails. So what is the target? The target is actually the receptor binding domain of the spike glycoprotein You remember while we started off, I had shown you the spike glycoprotein. So it is targeting the receptor binding domain, that is the domain that binds to the AC2 receptor. And the antibody cocktail, that is your combination of casirivimab and imdevimab. So that is being given in India also May 5th. It has been given emergency use approval. So why it was given is because it reduces the chance of hospitalization by 70% in patients with mild to moderate disease, and time to resolution of symptoms also it reduces by 4 days. And what is the dosage? It is 1200 milligram IV or sub-Q. So you give 600 milligram of casirivimab and 600 milligram of imdevimab. That is the dosage of these antibody cocktail used. So the aim of the cocktail or this particular monoclonal antibody is basically to prevent the disease in the high risk groups. So we have already seen who are the high risk group of individuals earlier, and it is these high risk group individuals that you should be giving the antibody cocktail. However, there are certain patients in whom you should not give this antibody cocktail. Who are they? Those that require oxygen therapy due to COVID-19. So they are having a COVID-19, okay, and those who require oxygen therapy should not be given, and those who are on chronic oxygen therapy due to some other non-COVID illness, okay, and because of the COVID-19 they are having an increase in the oxygen requirement, they also you should not give. And if it is more than 10 days from the symptom onset, because see how are they acting, the spike protein binding to the receptor. So once the viral replication phase is over, there is particular no use for these monoclonal antibodies, okay. And let's try to see who are the high risk individuals who are going to benefit. These are the high risk individuals. We have already seen them early in another tabular column also. That is the ones with coronary artery disease, high BMI, okay, the ones with chronic liver disease, chronic kidney disease. So those are the individuals whom you will think of this monoclonal antibody cocktail, okay. Now regarding the drug 2-deoxy-D-glucose, which on a sudden day, it came as some sort of magic, where in fact there was not too much of magic. It is again just a modified glucose, and again you do not have definite evidence. I again repeat the statement. The only two drugs with definite proof, one is steroids and what is the other one? It is anticoagulation. So it's a modified glucose, acts by arresting viral replication, and the DGCI on May 1 gave it a emergency use approval in COVID-19 patients. So it is given in the form of a sachet powder and dissolved in water and taken BD for at least a week. So it is proposed to cause a faster recovery in COVID-19 patients who are hospitalized, and they are currently not in the guidelines, okay. 2-DG is not in the guidelines. Dear children, remember all these are very important points. These may be asked as questions. Now see, the last slide for today, because the remaining part, I'll be taking on another day, because I suppose, at least some of you are tired, though I am not tired, or at least I am not appearing tired. So this is regarding the discharge policy in COVID-19. So we have discussed in detail regarding the management of COVID-19 A to Z, okay, management of COVID-19. Now regarding the discharge policy. Now discharge policy also, you will have difference in the guidelines based on individual states, okay. But what you have got to follow is the guidelines of Ministry of Health and Family Welfare, the latest updated guidelines. So let us see, if there is a mild disease, which is very mild or a pre-symptomatic disease, you can discharge after 10 days of symptom onset, okay, and no fever for 3 days, okay. That is when you can discharge. Is there an RT-PCR required at the time of discharge? No RT-PCR required at the time of discharge. However, at the time of discharge, which is actually written in small letters, might not be clear for you, they will have to go home and self-monitor their health, okay. It's you alone for yourself in that time, go home and take care of your health for remaining 7 days. That is what is being told. And then regarding the moderate cases. Now, already we know how it is being classified into this mild, severe, moderate and severe. Now here again, let me remind you, there may be individual state guidelines which may be slightly different, but you have got to follow this guideline which I have taught you for your exam, because that is the guidelines of the AIMS ICMR and the one that is followed by Ministry of Health and Family Welfare. Okay, all right. So COVID-19, Keshav, you mean DMRD, disease modifying anti-rheumatoid drug. So moderate COVID, either the fever resolved within 3 days and oxygen saturation maintained without support. So in this scenario, you will discharge after 10 days of symptom onset when there is absence of fever without antipyretics, resolution of breathlessness and no oxygen requirement. However, when the symptoms are not resolved and demand on oxygen therapy is continuing, okay, because if the fever has not resolved within the 3 days, in such a scenario of a moderate disease, because moderate disease we are dividing into two, in such a scenario you will discharge only after the resolution of clinical symptoms and the ability to maintain oxygen saturation for 3 consecutive days. That is only when you will discharge a patient with moderate category. Okay. And what about severe COVID-19? So, but again remember, for both the mild cases and moderate cases, no RT-PCR required before discharge. Important. Okay. But after that, he has got to go home and has to be at home isolation for 7 days. When it comes to severe COVID-19, the discharge is only after clinical recovery and the patient tested negative once by RT-PCR after the resolution of symptoms. Very, very important. Okay. And this severe COVID-19 actually includes those patients who are immunocompromised, HIV patients, transplant patients, malignancy patients, all will automatically go to the severe group. Okay. So that is it regarding the management, that is regarding the discharge policy of COVID-19. Okay. So once again, dear children, what have we learned today? We have learned in detail regarding 3 topics. Okay, 3 topics in detail. One is regarding the stroke localization. Number 2 regarding the management of stroke. Number 3 in detail regarding the COVID-19 management. These are very, very high yield topics. Let me again remind you one more thing. I have already done a INICT quick revision program. If you type my name and INICT QRP, you will find 3 videos. So where I have taken almost around 10 hours or so, 3 videos combined. Please go through those videos because I am not repeating the topics in that videos. Why? Because see, if you ask me, are those videos, INICT quick revision videos, are they actually, Javed, your question, it is not approved. Okay, it is not approved, but again it can be used. If you see the guidelines, AIMS ICMR guideline, it is not like approval. Okay, so but it can be used in certain scenarios, and I have told you which scenarios they can be used. Okay, all right. So please go through the INICT quick revision program, because INICT QRP, in those 3 videos I have entirely covered most of the systems in a question format. Okay, so it will actually help you for the revision. So in this NEET PG QRP, I am going to focus on certain important clinical management issues. I am going to take one more class where I will be teaching you regarding myocardial infarction, bronchial asthma guidelines, rheumatoid arthritis management guidelines, which are also equally important. So they also are likely to be asked, but because of a lack of time now, and I'm just keeping for another day, and probably because you are a bit tired. So so we'll go for that on another day. I'll just let you know in my Telegram group also regarding what is the next date of the next session. So just note my phone number. This is you can just ask me any message. This is my WhatsApp number. Okay, this is my WhatsApp number. You can text me for any doubt. And I have a Telegram group as well. It is the Dr. Rahul Rajeev medicine group. Okay, you can just inbox me, maybe send me a WhatsApp message, or I'll just add you in the Telegram group, or maybe send me a message in Telegram. I'll add you in that Telegram group. So I'll keep you posted in the Telegram group as well. When is the next class? Even in the Doc Tutorials Telegram group also, I'll just let you know. I hope today's class was beneficial. Okay. So Gautam is asking, in the INICT, have you covered all systems? Yes, I have covered all systems in the INICT QRP. There are 3 videos. There are 3 videos and almost 10 hours are there of questions which have been covered in all systems. That is why I am not repeating the same. They are important for NEET also. You might ask me, sir, INICT topics are important for NEET also. I would say yes. Why? Because see, years back there was a scenario where the NEET exam pattern and the Central Institute pattern were different, whereas the Central Institute would go for a more clinical approach, whereas NEET was factual. But now that is not the scenario. It is almost like the clinical pattern is there for both. So please watch my INICT QRP. So that was a different style in which I took. It was just question and quickly. It is a quick, very rapid revision covering most topics. So that will be helpful. So I hope today's class was useful for you. Okay. Tanya, definitely I'll share that in the Telegram group. Don't worry, I'll do that. Gautam, you can look at my INICT QRP videos. So I hope you need not by heart all these stroke syndromes from now on. Conceptually you are clear with that. So why have I selected certain topics is because those are the topics where you likely have confusions. Even myocardial infarction. I have seen students messing up with questions of myocardial infarction. It's because they do not know the exact guidelines. They have written some probably in the notes some important points, but how actually it is managed as per the guidelines they are not aware, which is why when it comes to a clinical scenario they are having difficulty. Please remember, when it comes to clinical scenario, often they ask you what is the next step. Okay, so that will be actually helpful if you know the guidelines. Janil, I told you I'll be conducting one more session because there are some other important management issues, clinical management issues which I like to discuss with you, like myocardial infarction, the management of STEMI, NSTEMI as per the latest guidelines, bronchial asthma, JINA guidelines. Okay, all right. So Alkai's FMG session, even for FMG also I had done a quick revision program. I think it is there in the Doc Tutorials app also. Okay, it is there in the Doc Tutorials app. Just check, it might be there in the YouTube channel as well. Okay, all right. Any other queries you want to know? Stay tuned to the Doc Tutorials Telegram group and my Telegram group as well. I'll let you know the next date. Any doubts, just let me know. COVID-19 is very important, okay? Anything and everything that I told about COVID-19 in this class is important. Don't think that, okay, I learned these topics from COVID-19. Because, you cannot just go to the exam hall without knowing this in detail. Very, very, very important, okay? All right. Yeah, thank you, Abhijit. Thank you. It's happy that you have liked the session. Okay. All right. So just those who have probably just joined now or you are busy, just go through the YouTube and you can just quickly go through the session. Okay, in a fast mode, which will actually help you. Okay. I also have a Facebook page by name Dr. Rahul Rajeev. So if you search, other than my personal FB page, which is Rahul Rajeev, and other than that, you have a Dr. Rahul Rajeev page also. Even you can send a request in my personal page also, but you can actually follow the Dr. Rahul Rajeev page also. Okay. Yeah, Jamil Takar, thank you so much. Thank you. Any doubts? Just let me know. Guys, keep studying well, okay? Keep studying well. We'll see you for the next lecture, okay, of myocardial infarction, bronchial asthma, rheumatoid arthritis, the guidelines, okay. And also just let me know if you want to have some other topic also discuss. If there is a common topic which everybody finds difficult, I'll be happy to explain. All right. Okay, so thank you so much for joining, and yes, so good night everyone. Good night. So study well, stay happy, stay healthy, okay. Yeah, thank you.